Well, it's a treat to welcome everyone to this second annual UW-MCW Multidisciplinary CNS and Spine Metastasis Update. Joe and who have done a terrific job assembling really almost all the, or many of the thought leaders in the field with regards to these topics across a multidisciplinary panel. So that it's terrific. I mean, back in the day, anybody could treat brain metastasis. We would get consults and it went to just about anybody, and it was similar for spine metastasis. And certainly everybody on the panel and attending today know that that's not the case, and that's a good thing. And I really congratulate everybody who's contributed or made those two sites and the thoughtfulness around turning personalized care to brain metastasis and spine metastasis part of their passion. So I congratulate you, I cheer you on, and I'm anxious to hear what you have to say. Bob?
Thank you. Thanks very much, Chris. I really want to welcome everyone to the second annual collaborative multidisciplinary approach to CNS metastases. There's really two take-home messages that I hope we all leave this meeting with. One, this is a truly very, very important problem. We know that CNS metastases are usually the end-of-life event of many, many cancers. And, we've accepted that too long. We've known since the early days of the Patchell papers, which I was honored to be part of, that it need not always be the case. And as we begin to look at that problem and see, can we assist, help, palliate, or cure these people that have always been considered the unfortunates, we begin to understand we do that collaboratively. And this is a great example of that. Joseph and Mahua have put together a wonderful group of really thought leaders to attack this problem at its biology, its pathophysiology, its diagnosis, its imaging, and its collaborative multidisciplinary treatments. And each aspect of that puts that puzzle together with great, great importance. So I'm thrilled that this is a truly multidisciplinary product of two major medical centers here in Wisconsin working together. And I'm thrilled that it represents that broad range of people attacking a difficult problem, because that's what gives our patients hope, and that's what inspires us. So I really want to congratulate both Joe and Mahua on this group and this panel. And like everything nowadays, I find I learn, and I love that. So thanks very much for putting this together. Thanks for being part of it. And we look forward to, again, another very, very fruitful meeting. It's the best. And then Joe and Mahua.
Thanks, Dr. Dempsey. And Dr. Schultz, that's a very kind introduction. And with that, it is my great pleasure to invite everybody to the state of Wisconsin, although virtually. We are lucky to have two great academic institutions in Wisconsin, Medical College of Wisconsin and UW. Between the two cancer centers and in collaboration with our community oncologists, we provide comprehensive cancer care for the entire state and beyond. Our goal in creating this educational activity is to improve cancer care of Wisconsinites by providing update from the leaders in the field of neuro-oncology on cutting-edge development in terms of surgical advances, clinical management, and innovative clinical trials in the field of brain and spine metastases, while also integrating our patient's perspective into this whole process. And with that, I would like Dr. Bowie to say a few words before we get started.
Thanks so much, Mahua. And thank you, Dr. Schultz and Dr. Dempsey, for those kind words and your introduction. I have to echo Mahua's welcome to this second annual symposium on central nervous system metastases. We are incredibly excited to share the presentations that our amazing panelists have prepared. Having had the opportunity to go through all of those, we're in for quite a treat today. It's been just an amazing collaborative effort between these two institutions. Last year, I had the pleasure of speaking at this event, and having gotten to know Mahua through that venue last year, it was wonderful that we had the opportunity to do this collaboratively. This has kind of turned into a biannual symposium, our springtime symposium. We concentrate on primary malignancies. Obviously, today we're going to be concentrating our efforts on CNS metastases. And as Dr. Dempsey had pointed out, this is such an exciting field. I feel like in this day and age, as Dr. Dempsey had pointed out, we do have the opportunity to offer hope for some patients. And I think with the amazing advances that we've seen across multiple disciplines that we'll hear from today, you know, medical oncology, neurosurgery, radiation oncology, and even getting into the quality of life aspects with discussions with regard to the neuropsychologic impact of the therapies that we'll discuss. It is truly a multidisciplinary approach to care, and we certainly hope to emphasize that with the discussions that we have in store for you. So thank you everyone for your attendance. I think we have Dr. Gandhi is a radiation oncologist at Northwestern University, working primarily at that facility's Proton Center in Warrenville, Illinois. He has certainly established himself as a true expert in the field of brain metastases, being the principal investigator of practice-changing clinical trials, which I've been blessed to be a part of as well, specifically for patients with brain metastases, led through the efforts of NRG Oncology. He's always been an amazing colleague and probably a better friend. And despite the fact that we have differences across our sports teams, we do tend to just share in just the value of baseball and football, even though that we have absolutely competing interests in those fields. And so it's a pleasure to have him here today to discuss personalized radiotherapy and the management of brain metastases.
Hey, thanks so much, Joe, for the very kind introduction. Joe and I have a lot in common. I married a Bears fan, and I've enjoyed seeing Joe slowly migrate to a Wisconsin sports fandom, which has been fun. Thank you, Mahua, for also inviting me to speak here. I also wanted to thank Dr. Schultz and his leadership in radiation oncology. And personally, I was a resident in radiation oncology over a decade ago at the University of Wisconsin, so it is a distinct pleasure to see Dr. Dempsey, who I was thought of as a role model, as of an excellent physician. So thank you for the excellent opportunity. The topic of my presentation is personalized radiotherapy, the management of brain metastases. As I mentioned, I have no disclosures, but it is a distinct pleasure to be able to speak at this conference because I do have one personal disclosure, and that is I owe a debt of gratitude related to my career to the two institutions who have are co-hosting this meeting. In high school, I did my first research at the Blood Research Institute, which is just down the street from Medical College of Wisconsin. And in college, I worked in the laboratory of Dr. Paul Harari, currently chair of radiation oncology at the University of Wisconsin, where I also did my residency. In addition, as mentioned, I am a diehard Wisconsin sports fan. Badger, Packers, Brewers, great game last night. And yes, I was at the NBA Finals when they won the championship. They always say you can take the Wisconsinite out of Wisconsin, but you can never take the Wisconsin out of a Wisconsinite. So it is a tremendous pleasure to be able to speak about a topic that is very near and dear to me, and that is the management of brain metastases. You know, as Dr. Schultz mentioned earlier in the introduction, management of brain metastases and our patients with brain metastases in radiation oncology used to be limited to essentially one hammer, and that was the use of whole brain radiotherapy, which you can see on the right. Essentially the use of two lateral X-ray beams to treat the entirety of the brain, inclusive of all parenchymal brain and all cognition-specific structures. We've come a long way since that time, and now we have a much larger toolbox. And I want to speak to that toolbox and how we can use the variety of radiotherapy tools for the management of brain metastases. So these are the three tools that I see in our radiation oncology toolbox. The first is stereotactic radiosurgery, the delivery of high-dose radiation to a small, grossly evident macrometastasis. The use of intensity modulated radiotherapy to deliver hippocampal avoidant whole brain radiotherapy, and the use of proton therapy to consider treating patients with leptomeningeal carcinomatosis. So firstly, how do we consider brain metastases? Well, when we get a patient's MRI and we see macrometastatic disease, as everybody knows, it takes at least 1 billion cells for a tumor to show up on an MRI, even the thinnest slice MRI that we can do. And we can use radiosurgery to target the macrometastatic disease. But we always know that there are pockets of micrometastatic disease, less than 1 billion cells elsewhere in the brain. And in that respect, the role of whole brain radiotherapy has allowed us to treat both the macrometastatic disease, but also the micrometastatic disease, and prevent conversion of those micrometastases into overt disease. Over the last decade and a half, we've seen a tremendous advantages in the use of stereotactic radiosurgery, gamma knife radiosurgery, which is what the Medical College of Wisconsin has and what I have in my brain tumor center here in Northwestern and Medicine Cancer Center in Warrenville. Started first with the C class, eventually we got to the Perfection, and now we use the Icon, which allows frameless approaches to gamma knife radiosurgery to treat multiple brain metastases, but also LINAC-based radiosurgical platforms, which I believe is what the University of Wisconsin has, a very advanced form of radiosurgery that can allow people to treat 5, 10, 15, 20, 25, 30 brain metastases all in a single setting. Really has been due to the technical advances we've developed in radiosurgery. Now, these technical advances in radiosurgery happened in part because we've come to appreciate that conventional whole brain radiotherapy, the use of lateral fields that come in from the sides, is associated with cognitive toxicity. And the summation of that data has demonstrated that we see an impairment in memory function as a consequence of the whole brain radiotherapy that occurs fairly early in the survivorship of our brain metastasis patients, up to 3 to 4 months after both therapeutic and prophylactic whole brain radiotherapy. And what is interesting is that there seems to be a differential sensitivity of memory-related domains as compared to other neurocognitive domains, and there's a clear impact on patient-reported cognitive functioning. So over a decade ago, we questioned, back when I was at the University of Wisconsin, why is it that the memory domains are so exquisitely sensitive to the effects of brain radiation? And one plausible answer to that question came from decades of scientific and investigation with respect to the hippocampus. And it started with this seminal case study of Mr. H.M. There's actually been a whole book dedicated to this gentleman's life and the research that happened thereafter, and I highly recommend that read. In 1957, he underwent a bilateral mesial temporal lobectomy for relief of medically intractable epilepsy. And upon awaking from that procedure, he developed a severe anterograde amnesia, an amnesia that prevented him to recall any facts or events that happened for the rest of his life. But it didn't have any impact on his ability to remember facts or events that happened prior to that event, to that procedure, and it had no effect on other aspects of his cognition. This case study really launched several decades worth of research into understanding hippocampal physiology with the following 3 main points. Number 1, that the hippocampus houses a compartment of neurostem cells that are specific to memory-related functioning. These stem cells generate into new neurons called neurogenesis, and that's what allows us to encapsulate memories. For instance, as I'm speaking right now, I'm hoping many of you, your hippocampi so early on a Saturday morning is able to activate and generate new neurons to remember this presentations to follow. And what is really interesting is that process of hippocampal neurogenesis is actually quite exquisitely sensitive to radiation therapy. So over a decade ago, our team had hypothesized that if we could use advanced radiotherapy techniques to spare the neurostem cell compartment located within the hippocampal dentate gyrus, while treating patients with brain irradiation, we could preserve the typical neurogenic fate of the hippocampal neurostem cells and thereby prevent memory-related dysfunction after brain irradiation. So we developed a number of techniques for whole brain radiotherapy using intensity modulated radiotherapy, where we carved out the memory zone within of the hippocampus within the whole brain. And then we launched a number of clinical trials within legacy RTOG and energy oncology. The first trial was RTOG 0614, and this was a trial of using a medication called memantine, an NMDA receptor agonist, which actually has been shown to have some pharmacologic effects on hippocampal neurogenesis. This was a study of whole brain radiotherapy for patients with brain metastases with or without memantine. And it was observed that memantine over the lifespan of a brain metastasis patient actually provided a 22% relative reduction in cognitive toxicity. A modest effect, but meaningful nonetheless. And after this study, it was deemed that memantine was standard of care for all patients who receive conventional whole brain radiotherapy for brain metastases. As a successor to this study, we launched Energy CC001. This is a study where all patients receive whole brain radiotherapy with memantine and were randomized to the receipt of hippocampal avoidance with intensity modulated radiotherapy. And this study observed that in addition, that added to memantine, hippocampal avoidance provided an additional 26% relative reduction in cognitive toxicity. So both of these trials were deemed to be practice changing. And what was really interesting is that both of these approaches, both the pharmacologic approach of memantine and the technological approach of hippocampal avoidance, seem to be complementary in their effects on cognitive function. In RTOG 0614, memantine preserved verbal fluency and had effects on learning and memory domains as assessed by the Hopkins Verbal Learning Test. And in addition, hippocampal avoidance added to memantine had even greater effects on executive functioning and all learning and memory domains as assessed by the Hopkins Verbal Learning Test. What was really fascinating about Energy CC001 was its impact on patient-reported neurologic symptoms. This was assessed using an assessment called the MD Anderson Symptom Inventory Brain Tumor Module, created by Dr. Terry Armstrong. And it allowed us to capture how patients felt that their symptoms were doing over their lifespan. And for the first time in any brain metastasis study, we actually saw a benefit with our intervention. Specifically, hippocampal avoidance actually preserved patient-reported symptoms at 6 months, both the burden of neurologic symptoms they experience, as well as the interference of those symptoms in their activities of daily living. And importantly, it also preserved their patient-reported cognitive function, as patients who received hippocampal avoidance reported less problems remembering things at 6 months. So this really underlined an important point that Dr. Dempsey made, that our intervention for brain metastases we have to really consider the palliative benefit. This was consistent with the palliative benefit of our hippocampal avoidance. So we took the sandwich of whole brain radiotherapy and really made it a little bit more, a little safer to deliver. It's kind of like the peanut butter and jelly sandwich analogy, where peanut butter is memantine and the jelly is the hippocampal avoidance, and they work together to make the sandwich even more delicious for people to consume, but specifically safer for our patients. But there's always room for improvement. And for those of you who like to put a little chutney on the sandwich, we are investigating other opportunities to continue to enhance whole brain radiotherapy and make it safer. We are launching a clinical trial here at my institution, Northwestern Medicine Cancer in Warrenville, using a compound called MW151. It's a compound that was a small molecule that has excellent CNS bioavailability, and that has been shown in preclinical models to reduce neuroinflammation and better preserve hippocampal neurogenesis and hippocampal dependent memory following whole brain radiotherapy. So this is a small business translational grant that we have received from the NIH, and we'll be launching a phase 1 trial in combination with hippocampal avoidance, specifically to look at safety of this drug, which we anticipate will be safe, but also to look at inflammatory biomarkers to see if there's any significant reduction. So as we mentioned, we've kind of reinvented the wheel on whole brain radiotherapy in terms of making it safer with both pharmacologic as well as technologic strategies. But now that we've reinvented the wheel, the question is, how do we use it in our clinical practice? So when I see brain metastasis patients in our brain metastasis center in our clinic that we have, I see them as situations where there's multiple times during their survivorship that I'm going to have to treat them with one of our radiotherapy tools. Generally speaking, we can typically use stereotactic radiosurgery on different metastases several times in their survivorship. But we can typically only use hippocampal avoidant whole brain radiotherapy once during their survivorship. So the question arises at this time, when is the appropriate timeline or the appropriate point in the survivorship of a brain metastasis patient when we use these strategies? Do we use hippocampal avoidant whole brain radiotherapy at the beginning when they first present with brain metastases? Or do we use instead stereotactic radiosurgery and reserve hippocampal avoidant whole brain radiotherapy for some time later when they develop distant brain relapses? Or do we consider using it near the end of their survivorship? I'll speak to the last first. I think most people would agree that this is there's no role for treatment near the end of their survivorship, and that was demonstrated by the Quartz study. So let's first speak about at the beginning. So this is CCTG CE.7. It's a phase 3 trial of stereotactic radiosurgery versus hippocampal avoidant whole brain radiotherapy with memantine for patients with 5 to 15 brain metastases. This is led by Dr. David Roberge, and the initial design of this study was SRS versus conventional whole brain radiotherapy with memantine. But once the results of Energy CC001 were available, we amended this study to include hippocampal avoidance in the experimental arm. This is for newly diagnosed brain metastasis, and its co-primary endpoints are overall survival and neurocognitive progression-free survival. So this will perhaps provide us some insight into how to manage newly diagnosed brain metastases at the beginning of that survivorship. There's a similar study. So that study of CE.7 is for non-small cell carcinoma, but there's an emerging literature questioning what's the appropriate management for small cell carcinoma. So this is Energy CC009, which was activated just this past year. It's a phase 3 trial of radiosurgery versus hippocampal avoidant whole brain radiotherapy for 10 or fewer brain metastases from small cell lung cancer. I'm working on the study in collaboration with a co-PI, Dr. Chad Rusthoven of University of Colorado. And these patients are randomized to radiosurgery alone versus hippocampal avoidant whole brain radiotherapy, 3rd degree and 10 fractions. And the primary endpoint of this study is cognitive functioning failure. So this is a study that Dr. Joseph Bovey is also joining us on the study team and developing and enrolling to this study. So we spoke earlier about when else can we consider hippocampal avoidant whole brain radiotherapy, and another option may be later in someone's survivorship, meaning we treat them with upfront radiosurgery for their gross macrometastases, but then consider hippocampal avoidant sometime down the road. And when do we try to do so, or how do we try to do so? Well, as we talked about earlier, the benefit of whole brain radiotherapy is to treat micrometastatic disease, what we call distant brain relapses that can occur after radiosurgical management. An omission of whole brain radiotherapy leads to a higher rate of intracranial progression. So one of my collaborators, Dr. Michael Chan at Wake Forest, developed a metric called brain metastasis velocity. Brain metastasis velocity is a total number of new brain metastases, that is distant brain relapses, since the upfront radiosurgery divided by the total time interval in years or fraction of a year. So for instance, if we treat someone with radiosurgery and we do an MRI, say at 2 months, and they have 3 new brain metastases, that would equate to a brain metastasis velocity of more than 13 brain metastases per year. Similarly, if we do a patient, treat them with radiosurgery, and then at 6 months, they have 7 new brain metastases, that again is a brain metastasis velocity of more than 13 metastases per year. And the question is whether this metric can be used to identify high-risk patients for whom optimal intracranial control with the use of whole brain radiotherapy with hippocampal avoidance might be indicated. So Dr. Chan and his team observed that brain metastasis velocity not only predicted for overall survival at first or second relapse, they observed this over multiple different systemic therapy areas, with 2007 being sort of the differentiated, the border between pre-targeted therapy area and post-targeted therapy area. And they also validated a multi-institutional database of more than 2,000 patients. And it's also been validated in multiple additional published series, including from our Japanese colleagues, Yamamoto and all. Importantly, Dr. Chan observed that brain metastasis velocity at first or second relapse not just predicted for survival, but also predicted for the likelihood of neurologic death. And that's specifically important for what we're trying to do with brain metastases, in the sense that, that we don't necessarily want the disease in the brain to necessarily lead to someone's passing away. So neurologic death, they observed, was 3-fold more likely in patients with high brain metastasis velocity. And patients were 43% more likely to die of neurologic death than non-neurologic causes when they had a high brain metastasis velocity. So it appears that the neurologic death was a primary contributor to the inferior survival in patients with high brain metastasis velocity, and it underlines the importance of optimizing intracranial control. So this is another trial that was activated about 10 months ago. It's Energy Oncology BN009. It's a phase 3 trial of salvage hippocampal avoidant whole brain radiotherapy with radiosurgery versus radiosurgery alone for patients who experience their first or second distant brain relapse after upfront radiosurgery, but have a high brain metastasis velocity of at least 4 METs per year. In this case, the primary endpoint is time to neurologic death. So my co-principal investigator on this study is Dr. Michael Chan, who developed the brain metastasis velocity metric, but I'm also delighted to collaborate with Dr. Bovey on this trial as well. Many people ask me, do you ever consider using hippocampal avoidant during whole brain radiotherapy for patients with leptomeningeal carcinomatosis? And my answer is quite frequently no, because I don't actually like treating leptomeningeal carcinomatosis with whole brain radiotherapy. Whole brain radiotherapy is meant to treat parenchymal brain, where in leptomeningeal carcinomatosis, our radiotherapy target is in fact cerebrospinal fluid, or the CSF. And so in these scenarios, we often think, or at least consider, that the most effective radiotherapy approach might be a craniospinal radiation approach, where we're treating the entire CSF compartment of the neuraxis. But the challenge has been for many years that we really could not accomplish this with conventional photon radiation, given the risk of hematologic and GI toxicity in our brain metastasis patients. But proton therapy offers some really unique opportunities here. And to be honest, at our institution, we've been doing this for many years, where we use proton therapy for leptomeningeal carcinomatosis. But it was our colleagues at Memorial Sloan Cancer Center that actually published a phase 1, phase 2 trial that mirrored some of the outcomes we've seen. They ran a phase 1, phase 2 trial of proton CSI for patients with LMD, leptomeningeal dissemination. And they found 2 dose-limiting toxicities. One was a grade 4 lymphopenia, and the other was another grade 4 lymphopenia and thrombocytopenia, both of which resolved without medical intervention. But the outcomes of the study are rather fascinating, and I've actually updated the slide based on an abstract presentation to be presented at ASTRO in a couple weeks. But their median survival for their patient population was 9 months, which is actually pretty good. And their median time to progression in the CNS was 8 months, which really underlies what we see with leptomeningeal carcinomatosis, and that is that oftentimes the survivorship is directly related to how long we're able to control disease in the cerebrospinal fluid. And actually, this is a new data point that's going to be presented at ASTRO, and that is that they collected circulating tumor cells, I believe with Biocept, but I'm not quite sure. We'll find out in a couple weeks, using cerebrospinal fluid. And they observed that less than 41 circulating tumor cells per 3 cc of cerebrospinal fluid prior to craniospinal radiation was not only associated with improved time to progression in the neuraxis, with 19 months being the median, but also was associated with the trend to improved overall survival. So it speaks to the importance of detecting leptomeningeal carcinomatosis early in patients and being able to treat them with a smaller or lesser burden of disease, which allows us to more durably control them over the long term. So we've talked about personalized management. We have these 3 tools that we can use: radiosurgery, hippocampal avoidant whole brain radiotherapy, and proton therapy. But how do we use them in a way that personalizes management of brain metastases? Well, within Legacy RTOG and Energy Oncology, we have been fortunate to have conducted 3 very large trials that summate to approximately 6 or 7, approximately about 800 or 900 patients that have been enrolled on these studies. And so we're fortunate to have received some funding from the NIH to try to look at some of the laboratory and biomarker, as well as MR biomarker correlates of cognitive toxicity. For one, we are in the process of evaluating ApoE genotyping. As many of you know, ApoE genotyping has been significantly correlated with the risk of Alzheimer's dementia and mild cognitive impairment. But as Jeff Weffel and colleagues had shown from RTG 0614, ApoE4 allele carriers, which is also significantly associated with the risk of dementia and Alzheimer's and mild cognitive impairment, was also associated with greater declines in memory function, cognitive function in patients who received conventional whole brain radiotherapy with or without memantine on that trial. There's another trial that was conducted in Japan where they randomized between whole brain radiotherapy versus hippocampal avoidant whole brain radiotherapy. I did not include that slide in this study, but they too showed a benefit with hippocampal avoidance for patients with brain metastases. It was a much smaller trial, about 50 or 60 patients, but they're presenting in a couple of weeks a very interesting abstract where they too were evaluating ApoE4 genotyping, and they found that E4 allele carriers actually similarly had greatest decline in HVLT or memory recall at 6 months, and that the ApoE genotyping was independent of age or the use of hippocampal avoidance in the trial in predicting cognitive preservation. So we are in the process of evaluating 529 patients who enrolled on our hippocampal avoidance trials to see if the same correlations can be found in our analysis. It really provides a tremendous power for statistical analysis, and this is being led by Dr. David Grosshans at MD Anderson. Several years ago, Dr. Bovey approached me with this really interesting hypothesis about that his team had conducted at Medical College of Wisconsin, or investigated, which is the understanding that the baseline white matter integrity, what we call leukoencephalopathy of patients who present with brain metastases, may actually impact their cognitive outcomes after whole brain radiotherapy. It's an interesting idea because it really speaks to what I call the aged brain. That when you look at baseline flare abnormalities periventricularly, it really is a hallmark of white matter integrity related to microvascular ischemic changes that happen over a patient's life. And is it possible that the aged brain on an MRI, maybe more so than the actual patient's chronologic age, predicts for cognitive toxicity? So Dr. Bovey and colleagues actually ran this analysis on RTOG 0933, a very small study, but we're able to show in that small study that baseline leukoencephalopathy did predict for greater Hopkins Verbal Learning Test decline after hippocampal avoidant whole brain radiotherapy. So to some extent, it suggests that even though hippocampal avoidance does work in preventing cognitive function, it seems to perhaps maybe work differentially less in patients who have already pre-existing ischemic changes on their MRIs. And so we are in the process, Dr. Bovey and his team are in the process under this grant mechanism of trying to corroborate these findings in the 750 patients that we have through our hippocampal avoidance trials within Energy and Legacy RTOG. Similarly, Dr. Cliff Robinson of WashU has been looking at baseline hippocampal volume, and does that also predict for cognitive functioning? And for that analysis, we have almost 800 patients that we're currently evaluating. We're also in the process of evaluating various other biomarkers, including serum cytokine, kinomes, and brain subsegmentation. Various areas of the brain may be relevant. More on that to come. But back to the original thesis of this presentation, the personalized management of brain metastases. Our toolbox has really expanded over the past 10 years. Now that we can treat with multiple MET radiosurgery, we can use hippocampal avoidant whole brain radiotherapy with memantine to provide the benefit of whole brain radiotherapy in a safer context, and we can use proton therapy to treat patients with leptomeningeal carcinomatosis. But our ability to personalize and figure out which tool is most appropriate for patients has also expanded. Previously, we used to think of conventional factors like prognosis, the histology of the patient with brain metastases, and the number or volume of brain metastases that they have. But the future is really looking at much more personalized aspects. ApoE genotyping to predict the likelihood of cognitive toxicity after our management, their baseline periventricular leukoencephalopathy, and whether they're MR predictors, including hippocampal volumetry about how they might do after our treatment. And the overall goal is to provide a safer and yet effective approach to using radiotherapy to optimize the timeline and quality of life of survivorship for our brain metastasis patients. So we're really sitting at a tremendous opportunity, a great fulcrum of opportunity here to try to continue to use our radiotherapy advances to improve the outcomes of our patients with brain metastases. I thank you for your time and attention.
Thank you, Dr. Gandhi, for a great talk. It was very informative. And I think you're not available for the panel discussion, and am I right, Joe?
Actually, that was Dr. Alawalia. So
Oh,
I think
I'm
Vinay is
sorry.
able to stay with us. So
Oh, perfect. In that case, we will wait till the panel discussion for any questions. And just as an announcement for all the attendees, if you have any questions, feel free to put it in the chat, and we will discuss all that during panel discussion. So after that great talk from Dr. Gandhi, as we said, this is a truly multidisciplinary conference where we're bringing in specialists from all the various disciplines that are involved in treating brain mets. It's my great pleasure to introduce Dr. Manmeet Ahluwalia. Dr. Ahluwalia is a board-certified neuro-oncologist. He's the Deputy Director, Chief Scientific Officer, and Chief of Solid Tumor Medical Oncology at Miami Cancer Institute, which is part of Baptist Health in South Florida. Dr. Ahluwalia is a leading expert in brain metastases and primary brain tumors. He's the principal investigator of several national and international clinical trials in brain metastases, and we are truly honored to have him speak at this symposium. We can't hear you, Dr. Ahluwalia.
I'll unmute him.
Can you see my slides okay?
Yes, now we can.
Okay, thank you
Yep.
so much to Drs. Day and Bowie for this kind invitation. Always a pleasure to follow Dr. Vinay Gandhi and see what great developments have occurred in the last decade or two. It's just been very gratifying because a decade back, when I would follow radiation oncologists, I probably had hardly any data to present. I remember an ASCO meeting close to a decade back where I followed Manesh Mehta, and I would only present case series. But as Dr. Dempsey was saying, the field has come a long way. And as a physician treating these patients, I'm extremely excited about the therapeutic advances for brain metastases using medical therapies, both targeted immunotherapies. And I'm very excited to speak on this topic today, and would again like to thank the moderators for the kind introduction and invitation. This is my disclosure slide. What are the learning objectives of my talk today? Understand the role of genetics in outcomes in brain metastases. Dr. Priscilla Brastianos, who's an international expert in this, will also speak to this in much greater detail in a talk in the afternoon. We'll learn about the role of targeted therapy in brain metastases and understanding the evolving role of immunotherapy now, since we have numerous new drugs to help our patients. So most of you are aware, and as Dr. Dempsey said, we are seeing more and more of these patients in our clinic. So this slide is a few years old, but the incidence of brain metastases is increasing. If brain metastases was a cancer by itself, it would probably be the most common cancer we would see in the United States. Estimates are that between 200 to 300,000 patients will be diagnosed with brain metastases in the United States every year. And until recently, the median survival of these patients was 9 to 12 months. And as that Dr. Vinay Gandhi eloquently talked about previously, the questions used to be, oh, do whole brain radiation versus stereotactic radiosurgery. Now we talk about things like hippocampal sparing, adding pharmacological drugs to whole brain radiation to mitigate the neurocognitive side effects. But we are also seeing that our patients are living longer, and several of these components are becoming extremely important. So I must again congratulate the organizers for a stellar agenda today, because we will be talking issues about neurocognition, we'll be talking about issues of survivorship, helping with symptom management and things like this. So highly gratifying. But what are the common tumors that actually go to the brain? So any large series you open or any large clinical trial you see, half of the patients have lung cancer origin. Second most common cancer that goes to the brain is breast, and the third one is melanoma. So in an interest of time, these will be the three cancers on which I'm going to talk about the role of new targeted therapies and immunotherapies and what we've seen in the last several years in management of these patients from a medical neuro-oncology perspective. So Why is this symposium very timely and appropriate? We only know that incidence of brain metastasis is only increasing. Why is that? Because our patients with systemic cancers are living longer, and we know that brain or central nervous system is a sanctuary site. We also are imaging our patients more. And for a lot of clinical trials, until recently, brain metastases used to be an exclusion criteria. Luckily, more and more trials are now allowing these patients to get on studies, but still brain MRI is usually eligibility criteria in sense of that they like to know whether the patient has brain metastases when they're getting on a trial or not, because the outcomes can be very different. We also know different tumors can have brain metastases at different time points. And as I alluded before, lung cancer is the most common type of cancer that goes to the brain. And when we see a patient with stage 4 lung cancer, there's a 20 to 25% chance that this patient may harbor brain metastases at initial presentation. Hence, according to the NCCN guidelines, we have to do a brain imaging at diagnosis. And 80% of our stage 4 lung cancer patients, if they live more than 2 years, will develop brain metastases. So talking somewhat about the genomics, I know Dr. Brastianos will cover some of our groundbreaking work in much greater detail in the afternoon. But this is a slide we work from one of my mentors, Chris, Dr. Chris at Memorial Sloan Ketterings. This was work he did over a decade back, which basically showed that lung cancer was not one disease, but it was basically different diseases under one umbrella, driven by different pathways. So these oncogenic driven pathways, which have actionable mutations, were the ones I'm going to talk to you in great detail, including the EGFR, which is present in 10 to 15% of the Caucasian population, but 30 to 50% of the Hispanic patient population and Asian patient population. So I see several more of these patients here in Miami compared to when I was at Cleveland Clinic for 15 years, where I mostly had a Caucasian patient population. Then there's the ALK pathway, which is upregulated in 5 to 7% of the lung cancer patients. And KRAS is another very interesting target. Until recently, KRAS was said to be undruggable, but we've had 2 drugs in the last year that have shown some significant benefit in this patient population. And there are ongoing trials looking at the efficacy in brain metastases as well. And then there are a number of mutations which occur in smaller subset of lung cancer patients, like BRAF, ROS, MET. It's a very exciting avenue to be treating these patients because we have several drugs in the armamentarium now when we see these patients in clinic. So just to give you a flavor of how the outcomes are now changing based on the subtyping compared to what we used to see before. So as you can recollect, a number to remember is overall, generally, if a patient is diagnosed with brain metastases, the outcomes are typically in 9 to 12 months. But most of this, as I said, is driven by lung cancer patient outcomes in clinical trials because they are almost 50–60% of patients that enroll on clinical trials. And of those, most of the patients until recently were either KRAS or were wild type. And as a result, here you can see in curves in orange, gray, and dark blue, the outcomes of these patients is around 12 months. And hence, when you look at the overall data, the outcomes of clinical trials will stay in that ballpark. But what we know now is that if you see now in the light blue curve here, the EGFR mutant patients, their outcomes are 2 years. And then very exciting data that we saw a few years back with the group from Yale and a number of other institutions, that ALK mutant patients, the outcomes in brain metastases were 4+ years. If you had told someone a decade or 2 back that they were brain metastases patients, a particular subsite that would be living 4 to 5 years plus out, you would think that would be a pipe dream. But we are seeing this as a reality with this transformation of outcomes of these patients due to drug development in this patient population. And I'm going to talk to you about that. So always as the drug development happens, the question that comes up is, what do you do with managing these patients? And as was very eloquently mentioned before, management of patients with brain metastases is a team sport. You need multidisciplinary management, as exemplified by the group of speakers today. You need neurosurgeons. Dr. Ganesh Rao is going to follow my talk and speak about some of the exceptional work he and his team are doing about managing it with LIT. You need a radiation oncologist, and you heard the very eloquent talk by Dr. Vinekondi. and then medical oncologists and neuro-oncologists, we partner up with them. So when the first generation TKIs like erlotinib and gefitinib was having significant impact in the management and outcomes of these patients, several of us in the country, this effort led by Veronica Chang, asked this question: how will patients perform depending on what drug or modality they got? So again, this was 6-institution effort, 350 patients, where 1/3 of the patients got upfront EGFR TKI, first generation TKIs, because this work was done around 4 to 5 years back. Then patients who got SRS followed by TKI, or whole brain radiation followed by TKI. And here you can see in the curves, the group that got upfront SRS did the best. The group that got whole brain radiation followed by TKI did second best, and the patients who got who got TKI did the worst. But overall, as you can see, highly good outcomes. Everyone lived over 2 years, 3 to 4 years. Now, there are some inherent flaws in this multidisciplinary or multi-institutional collaborative, because this was retrospective data. The choice of treatment was picked by the physicians in collaboration with their colleagues, mostly through tumor boards. But what it showed was that maybe, at least with the first generation TKIs, combinatorial efforts with some form of radiation was the way to go. But then there's this new drug that came on the block, which was osimertinib, and which significantly changed the management of patients in EGFR tumors. Before this, erlotinib and gefitinib did good work, but osimertinib was really a transformative effort. The reason for that was just to help you understand, typically with chemotherapies, when we treat our patients with brain metastases, response rates are in the ballpark of 5%. This trial showed that the response rates were 55%. And most of these patients had failed a prior TKI. So a lot of these patients were refractory to initial treatment. Then, and you can see here, there's a great waterfall plots basically showing complete responses, partial responses in this patient population. What we then also looked at, what was the CNS response based on prior radiation treatment. And what we found out on this study was that if patients were radiation naive, they had higher outcomes. Or if patients got the drug more than 6 months after radiation, they did better. But that speaks to the biology of the disease, right? If someone gets radiation and does well for a longer period of time, it means they have maybe a more biologically indolent disease. So in the patients who were either radiation naive or had the drug after 6 months after first dose, their outcomes were close to 70% compared to those patients who had failed radiation 6 months before going in the study, where the outcomes were 30%. Overall outcomes, though, were 55% or so, 10 times more than chemotherapy. So this was basically transformative data for those of us who treat these patients. And then osimertinib actually, the data I showed you was from the AURA trials, where osimertinib was given in refractory setting. Then osimertinib actually moved into upfront setting. And this was a New England Journal of Medicine publication a few years back, where you can clearly see that patients who had osimertinib compared to standard TKI did better. And this led to osimertinib becoming the standard of care in patients with EGFR mutant lung cancer. But what was very exciting for those of us who treat patients with brain metastases, and as you can see here in figure B now, osimertinib blue curves, standard first generation EGFR TKIs red curve, you can see very good outcomes in patients with CNS metastases, where progression-free survival was 15 months. And this is not overall survival, it's just progression-free survival, compared to 9.6 months for the first generation TKIs. So what we know is the third generation TKIs in EGFR mutant lung cancer does much better compared to the first generation TKIs. And this is a theme that you will see with other tumor types too, and in the following slides as well. So we wanted to build on this. So this was a trial that I was involved with and I led when I was at Cleveland Clinic in collaboration with Miami Cancer Institute and UVA. And this was a study looking at osimertinib with combination of stereotactic radiosurgery, because we do believe that stereotactic radiosurgery, and I've had this belief for over 10, close to 15 years now, was the foundation of treatment of these patients, helps with neurocognitive benefit. Obviously, there's been work done in whole brain radiation with hippocampal sparing, showing very comparable neurocognitive outcomes in those patients. This trial has accrued, and stay tuned. We should be seeing some of the data coming up in the next meetings in next year. So then next, talking about the ALK space, this is around 5% of our patients that we see in lung cancer. And here, it's a busy slide. Let me walk you through it. This crizotinib is a first generation inhibitor. So very similar like erlotinib and gefitinib, having response rates in the brain. And here you can see response rates of 20% to 30%. But when you look at the newer generation drugs like ceritinib, alectinib, and brigatinib, which have greater blood-brain barrier penetration, you see response rates in the ballpark to 50 to 70%. Very comparable to what we saw with osimertinib, which is a third generation TKI with better blood-brain barrier penetration. Just going over some of these trials, this is a trial comparing alectinib to crizotinib, again, a novel TKI in alectinib compared to first generation TKI with crizotinib. And here you can see cumulative incidence of CNS progression much higher in red curves with crizotinib, much less with alectinib. So great data which pushed alectinib to the front line in management of these patients. Then there's another drug that got approved called brigatinib. And here again, this was compared to crizotinib. And you hear again, as you can see in great curves with brigatinib, patients having much better survival without intracranial disease progression in patients who had brain metastases at baseline compared to crizotinib, which is in the red curve. And you are seeing very impressive hazard ratios. This one had a hazard ratio of 0.27. Moving on to the latest drug that is being used in ALK patients is lorlatinib. Lorlatinib is effective even in patients when they progress on even second or third generation TKIs like alectinib or ceritinib. And here you can again see lorlatinib being compared to crizotinib. And obviously not cross comparing with trials, but you can see now the hazard ratio of CNS progression without previous non-CNS progression of death. Hazard ratio is 0.06. So it's not even 0.1, it's 0.06. And you can see this great flattening of curve here in the blue with someone with lorlatinib, who at 12 months, the cumulative incidence is only 2.8%. And here the crizotinib is around 33%. Some of the other trials that I showed you, the 12-month cumulative incidence was around 40%. So the data is internally consistent. Crizotinib leads to cumulative incidence of around 30 to 40%. But here with lorlatinib, you're seeing 3%. So I think the overall survival of these patients, which is like 4 to 5 years now, going on to 6, as we'll see in the next few years, will go on even more. So we are actually following the path of targeted therapies that was shown by CML, where we had the first therapy, Gliomas, which basically was a game changer and was the magic bullet. And so we are seeing targeted therapies basically helping out these patient population. Next, moving on to immunotherapy. As you know, there has been so much excitement about immunotherapy, which has been transformative in management of patients with cancers. And so until a decade or so back, CNS was felt to be an immunoprevesite. And then there were a couple of Nature publications which basically showed no, CNS is not an immunoprevesite. And Dr. Kim Margolin led the first trial of ipilimumab in brain metastases, which actually showed benefit in patients with brain metastases. So what's happening with immune checkpoint blockade in patients with melanoma and non-small cell lung cancer? So this was a study led by Harriet Kluger and Sarah Goldberg out of the Yale group. And this was the first iteration of this study that was published in Lancet Oncology in 2016. And here you see response rates in lung cancer, which was around 33%, and 22% response rates with melanoma in brain metastases. So this was definitely an effort showing that immunotherapy worked in this patient population. This was an update by Dr. Sarah Goldberg in the non-small cell lung cancer space. So initially she had presented the data with 18 patients with lung cancer, where 6 of those patients had responses, which was around 33% responses that I alluded to. And here now you can see these waterfall curves, plots going down, and the response rates in 34 patients who were PD-L1 positive was around 30%. So again, internally consistent data. This is very much comparable to the response rates that we see with drug alone in patients who have systemic disease. However, what we know is that PDL expression in the brain can change compared to the systemic PD-L1 expression. Data from the Mayo Group showed that this discordance could be around 14%. And what we learned from this study was that you could have responses in the brain, here shown in orange curves, compared to those in the green, which were systemic. And there was 7 patients out of these who actually had a discordance in their systemic response compared to the systemic responses and the CNS responses. So 4 patients had progressive disease in the brain, but had PR in the body. And there were 3 patients who had PR in the brain, who had progressive disease in the body. So this is again area of active investigation to figure out how do we manage these patients when they develop brain metastases, because they could have differential outcomes. What this trial showed is something that we know, that checkpoint blockade alone will not work in those patients who have PD-L1 negative disease. So 0 out of 5 patients who were PD-L1 negative had any responses in the brain. Moving on, there have been, as we have talked about, if you use one immune checkpoint blockade, we are seeing nice responses. So then the question is, can you combine and use combinatorial effort? So nivolumab is an anti-PD-1 drug, just like pembrolizumab, and ipilimumab is a drug that targets the CTLA4 pathway. And this is the data from the Checkmate 227 study, basically, and the data I'm showing, this was posted at AACR, is primarily, I want to focus on patients who had baseline brain metastases. And here you can see those patients who were treated with Nivo and Ipi did much better than compared to those who had chemo. And you can see at 3 years, we are seeing this plateauing of responses. So it's very gratifying to see that even in brain metastases, we are having long-term significant outcomes and not just in the body. So, and I think that's the premise of immunotherapy, that if it can work, you can get long-term durable responses. And these results are looking really good even 4 years out. And what was interesting to see was, now again, cross comparing those patients who had a baseline brain without baseline brain metastases, the 2 curves are much closer. And those who have brain metastases, actually the curves are diverging. This would be contrary to what you would have imagined. And when we look at response rates, sorry for the busy slide, the response rates with patients with brain metastases was around 32%. So slightly better than what we've seen with pembrolizumab around, which is around 30%. But again, difficult to cross compare because these are 2 different trials. But we know that the drugs are working in this patient population. This was just hot off the press. This was data presented at ASCO 2021. This is the 2-year update of this Checkmate study. But the busy slide, the part I do want to highlight is that patients who were treated with Nivo-Ipi with CNS metastases, as you can see, the hazard ratio is more impressive than those who were without CNS metastases. The hazard ratio is 0.47. So patients getting durable benefit with immunotherapy when being treated with brain metastases. But a big question comes is that compared to the systemic disease, when patients have brain metastases, a lot of times they are on steroids. So we have seen there was a JCO publication from Memorial Group in collaboration with the French group showing that those patients who were on steroids with lung cancer actually had worse outcomes with systemic disease. So this was the work led by Adam Laco, who's a medical student at Cleveland Clinic when I was there. And basically what Adam wanted to study was, what was the impact of steroids versus those patients who were not on steroids. And here again, the data set was small, but we had a trend towards, again, those patients who were not on upfront steroids doing better than those who were on steroids. Comparable, we've had other presentation basically showing the same thing when we combined our data in all tumor types, and the N was larger there, showing that steroids matter. And I'll show you some of that data later in the presentation today, work led by Rupesh Katocha when he was at Cleveland Clinic. But what we also wanted to understand was, what was the interplay between neutrophil to lymphocyte ratio? Does it impact steroids? So we do know that NLR, or neutrophil to lymphocyte ratio, can impact the outcome of patients with immune checkpoint blockade. And what we found out was, yes, when we look at NLR here in the bottom left curve, that those patients who have a higher NLR ratio actually do worse compared to those patients who have a low NLR ratio. This is consistent with what has been shown by other groups. But what we found, which was very interesting and led to this publication in Science Reports, one of the Nature group publications, was that this interplay was actually managed by NLR. So those patients who have a lower NLR, and this is the group that will do well, right? If you see here in the bottom left curve, the steroid impact actually is more important. So those patients who are not on upfront steroids will do well. And here you can see these patients living 2.5 to even 4 years and you can see nice flattening of curves here in the blue. And those who are on upfront steroids, you can see they will do worse. Now, those who have a higher NLR of more than 4, there you can see there's not much difference because these patients biologically will progress fast. So again, the question becomes is those patients will tend to do better. Steroids impact is more pronounced. Then the other thing that we were interested in, this was another publication led by work from Adam Lacko again. He wanted to study how are the patients with KRAS mutations doing with brain metastases. So there was a data coming out with lung cancer that patients who have KRAS mutations have higher PD-L1 expression. And so the question was, do these patients do better with brain metastases? So Adam asked this question looking again at the database at Cleveland Clinic, and he said, okay, let's look at patients who have KRAS mutations and those patients who do not have a KRAS mutations but are wild type. Obviously, we excluded the EGFR and the ALK patients because we know immune checkpoint blockade doesn't work well in this patient population. And then we compared the patients whether they got immune checkpoint blockade or they did not get immune checkpoint blockade and got chemotherapy. So those patients who did not have KRAS alterations, the outcomes were, when we found out that, so first curve basically showing there's some benefit definitely to immune checkpoint blockade compared to chemotherapy, 12.5 months compared to 9 months. So this is the comparable data that what I showed you with, say, the NEVOP trial compared to the chemotherapy. But when we looked at this patient population in closer detail, this was actually being driven by those who had KRAS alterations, and which is basically, you can see here in the curves, the patients who got KRAS and had no ICI, means they had chemotherapy, they did worse. So this is these dotted red lines. And if you look at the solid red lines, which are KRAS mutant patients who got ICI, their outcomes or survivals were twice as high with a fairly significant p value of 0.004. So if you had KRAS and you got immune checkpoint blockade, you live 13 months compared to if you have KRAS and you get brain metastases and you get treated with chemotherapy, then you only live 7 months. Now, this data will be very interesting to see because we have now drugs that actually target the KRAS pathway. This work and data was generated from the time when that KRAS was an undruggable target, as I told you to you. So stay tuned, a lot of activity happening in this field, which is great. Moving on gears to breast, we know breast accounts for 15% of brain metastases that we see in our clinic. And this was work led by Eyal Azer and his group from Dana-Farber, looking at the SEER database. But here also, again, looking at the SEER database, we know that subtyping matters. So the patients here in blue who are doing the best are hormone positive and HER2 positive disease, compared to those patients who are in this light blue curves who are triple negative, where we know they do really worse. So the patients with triple negative breast cancer brain metastases, typically outcomes are around 6 to 9 months. Those who have a hormone positive disease with HER2 positive disease, outcomes are in the ballpark of 2.5 years. So here you can see 4 to 5 terms better outcomes in those patients where we actually have drugs that can benefit that patient population. So what are some of the outcomes with some of the newer therapies? Neratinib is a drug that targets the EGFR and the HER2 pathway. And this is work that was led by a good friend, Rachel Friedman from Dana-Farber again, showing that the response rate with combination of neratinib and capecitabine around 50%. And a lot of these patients had actually failed prior radiation. So very exciting to see this data. Now, this would compare to 20% of response rates that was seen with lapatinib. So neratinib is 50%, lapatinib used to be 20%. So what we are seeing again is what we saw with lung cancer, that the newer generation drugs are giving us response rates which are higher and superior compared to the first generation drug. And then there, one of the challenges in neratinib is a lot of side effects. There's a new drug on the block called tucatinib, and this is data from the HER2 CLIMB study publication, which was recently published in JCO, work led by Nancy Lin. And here again, you can see the CNS progression-free survival with tucatinib, trastuzumab, and capecitabine here in the blue curves looking much superior compared to placebo, trastuzumab, and capecitabine. And hazard ratio is 0.32. And similarly, the overall survival is also superior with the combinatorial efforts. And this has really moved tucatinib to the front line in the management of this patient population. So building on this, this is a study that I've been involved with and will be a multi-institutional effort being led out of Miami Cancer Institute. The study is going to be a 40-patient study looking at combinatorial efforts of tucatinib, trastuzumab, and capecitabine. But we're going to look at, again, the interplay with radiosurgery, which I said is an area of focus of our group. So we are looking for new institutions. If you're interested, please reach out to us. We do plan to involve at least 6 institutions in it, at looking at this combinatorial effort. Then moving gears to melanoma, which is the third most common cancer that goes to the brain. In melanoma, we know that 50% of the patients have a BRAF mutations, and this is a very druggable target. Initial trials were done with dabrafenib, which is a BRAF inhibitor, which has good blood-brain barrier penetration, and the response rates with dabrafenib were 30 to 40% based on whether you are radiation naive or radiation refractory. If you're radiation refractory, response rates with dabrafenib are 30%. If you're radiation naive, the response rates are 40%. So what we also know is that patients, when they're treated with dabrafenib, the BRAF inhibitor, the primary mechanism of resistance is through the MEK pathway. And so then there's a drug called trametinib, which targets the MEK pathway. So the question then was, can the dual the dual therapy be better than single therapy? And this was work led by Mike Davis, and was presented at ASCO a few years back, and was also a Lancet Oncology publication. And here you can see those patients who are radiation naive, who get the combinatorial effort, have response rates in the ballpark of 60%. So this obviously bodes well compared to 40% with one drug. But here was cohort B, which was those patients who had progressed on radiation. But here also you can see impressive response rates of 56% compared to 30% with dabrafenib. So we do know that these patients, when they're treated with a dual targeted therapy, are doing better than the single targeted therapy. Moving gears to immunotherapy again in melanoma. As we know, melanoma is a tumor where a lot of initial drug development happened with immunotherapy. And so the question is, how are these patients going to do with dual checkpoint blockade? Work led by Tim Margolin that I alluded to with ipilimumab a decade back showed that ipilimumab was active in patients with brain metastases. So this was study Checkmate 204, word led by Hussein Chabi, presented at ASCO in 2019. And here, the patients were treated with the checkpoints blockade in combinatorial efforts. But the important thing to remember is this is the cohort A. These were asymptomatic patients that I'll present to you before, and then I'll talk about the symptomatic patients later, because like I said, the challenge with these patient population is that they are on steroids, which can impact the outcomes of this patient population. So this was the publication in New England Journal of Medicine showing that with combinatorial efforts, we are seeing response rates of 55%. When you looked at the checkpoint blockade alone in the first study at Lancet Oncology, the work led by Harriet Kluger in melanoma, pembrolizumab alone leads to response rates in the ballpark of 22%. But when you combine drugs, which is nivolumab and ipilimumab, which is a joint effort of anti-PD-1 and anti-CTLA-4 pathway, you're seeing now response rates of 55%. The challenge with these drugs is, though, the toxicity goes up significantly too. Grade 3 toxicity on the study was around 55%. So you're going to get a 55% benefit at the cost of 55% toxicity. But from the efficacy standpoint, here you can see very nice curves with progression-free survival and overall survival. And what is very interesting to see is the intracranial progression-free survival here seen in the yellow-orange curves is very comparable to the blue curves, which is extracranial. So the drugs are working not only extracranially, but they're working intracranially. And the overall survival also, as you can see, there is very nice flattening of curves around 15 to 18 months, which are extending to 2.5 years. So this was the cohort B now. This was Checkmate 204, again, work presented by Dr. Chabi at ASCO meeting. But here now, the response rate is 55% with the combinatorial efforts in those patients who have asymptomatic disease decreases to only 22% when patients are symptomatic and they're on steroids. This is clearly where we feel that some form of radiation is critical because the benefits of radiation, whether it's stereotactic radiosurgery, whole brain radiation with hippocampal sparing, is definitely better. So we believe in combinatorial data, but I'll show you a little bit about that as well going forward. But this was a study led by Dr. Georgina Long and colleagues from Australia, again showing very similar rates when they used the combination of nivolumab and ipilimumab. Response rates were around 56% in drug-naive patients 46% in overall patients. But when they used only one drug, that was nivolumab, the response rates were 20%, very comparable to what we've seen with pembro. So one drug will give you around 20 to 22%. Two drugs will give you anywhere between 45 to 55%, depending on what the patient population is. And this is again hot off the press, the data update at 2021 in ASCO, basically the study update from Dr. Georgina Long, showing that we are seeing durable benefits in this patient population. So this is overall survival, which was 63% with Nivo-Ipi at 1 year. You're seeing 5-year survivals of 50%. So these patients, their median overall survival with melanoma brain metastases, caveat subselect group of patients, is 50%. Melanoma patients with brain metastases used to typically do the worst. Their outcomes were only around 6 to 9 months, a decade back. So the therapies have been transformative in the management of these patients. So Dr. Katocha wanted to ask this question when he was at Cleveland Clinic. What's the impact of the sequencing between these drugs, which are PDL or targeting the PD-1 pathway or PDL1 pathway, when we use stereotactic radiosurgery? And here what we found out was those patients who got immediate immunotherapy with stereotactic radiosurgery did much better, and they had great complete response rates, and which you can see here in the blue curves, blue plots. Those patients who got concurrent, he defined immediate immunotherapy within 1 half-life of the drug. He defined concurrent immunotherapy with 3 half-life lives. And here also we see those patients doing better, but not as good as those who got immediate immunotherapy. Now both these groups did better compared to those patients who had no immunotherapy or had no concurrent immunotherapy. So basically showing that there is synergy here, because we think radiation can be a sensitizer to immunotherapy because of epitope expression. And there are several trials looking at this, which I'll talk to you about in the next few slides. But then he also wanted to look at what was the outcomes of patients who got CR. And here you can see those patients who had complete responses, their survival is much better than those patients who had a PR or had stable disease. And what Dr. Katocha also showed that I've talked to you about before, that steroids matter. Those patients who were not on any steroids did much better compared to those patients who were on steroids. So this is a busy slide again. This is a recent review that we were involved with. Rais Tonse is a fellow with us here at Miami Cancer Institute, and he wanted to basically compare the drugs between response rates. So those drugs which had less than 25% response rate, we said medium. Those who were between 25 to 50, we said, those were low. Between 25 to 50% were medium, and those more than 50% were high. And you can see various drugs being clubbed in these different works. But as we saw data today, alectinib, brigatinib, lorlatinib, osimertinib are in highly active drugs, and the combination of dabrafenib and tremelimumab as well, where response rates are more than 50%. So there is a lot of interest that our group has in combinatorial efforts, and this is a number of trials ongoing with SRS and targeted therapies. Dr. Bastianis is going to talk about a lot of ongoing trials that she is leading in targeted therapy, so I did not cover that portion because she'll cover it in her talk in the afternoon. But you can see a number of drugs being combined with stereotactic radiosurgery across different continents. And this is the second slide now. The first slide was on lung cancer. This is on breast cancer and melanoma. So it's very gratifying to see that you need multiple slides now to show the ongoing efforts, just signifying the active interest in this group. Looking at questions. This is a slide looking at SRS and immune checkpoint blockades now. Again, number of trials being led by different institutions looking at combinatorial efforts, drugs like atezolizumab, pembrolizumab, nivolumab, and we talked about some of the data with these agents. And this is now a slide on melanoma and non-small cell as well as renal. So as you heard from my talk, we are very excited for our patients. Dr. Gandhi had talked about macroscopic disease, so we still believe that if patients are symptomatic, they need stereotactic radiosurgery. The question there is, what are the number of mets there? This is a moving target. It used to be 4 a decade and a half back. Then it became 10. Now we are treating even patients up to 15 mets with SRS because we have better platforms that Dr. Gandhi alluded to. Whole brain radiation still can be used. I would mostly vote for hippocampal sparing and pharmacological mitigating efforts when we use that. We do know targeted therapies and immunotherapies work in this patient population and can help us with macroscopic disease, although the data with immunotherapy is mostly limited to asymptomatic patients. Question is, can radiation sensitizers, immunotherapy serve as a radiation sensitizer? We have efforts coming out with that, our group, and several others are looking at it. The advantage of targeted therapy and immunotherapy is that they can target the microscopic disease as well as the systemic disease. We also are very interested in neurocognitive outcomes in this patient, and this has become primary endpoints in clinical trials. Dr. Jeff Fiffle, who's involved in this conference, has been leading several of these studies. What we need to figure out, what are the appropriate test points, time points. Clinical trials, we believe, are critical to the defining the care in brain metastases, so we would like to thank all of our patients who participated in these trials and our investigators who conduct this trial. And as was alluded to before, management or selection of therapy for patients with brain metastases is a multidisciplinary approach. With that, I would again like to thank everyone for their kind attention and would like to thank the organizers for the kind invitation to share our thoughts on this topic. Thank you so much.
Thank you, Dr. Ahluwalia. That was a great talk. And it's great to see how good, we're doing for brain mets patients. Some of these survival curves are amazing. And this targeted therapy has definitely changed the game for brain mets people. And keeping with the theme of, since we're kind of on time, keeping with the theme of this multidisciplinary approach, now I'm really excited to present our next speaker, Dr. Ganesh Rao. Dr. Rao is a Mark J. Shapiro Professor and Chair of Neurosurgery at Baylor College of Medicine. Now, I have known Dr. Rao since I was a medical student, and he was a neuro-oncology fellow at MD Anderson Cancer Center many years ago. And since then, Dr. Rao has really blossomed, and he's become a nationally and internationally renowned surgical neuro-oncologist with extensive clinical and research experience in surgical management of brain metastases. And I'm going to let him update a little bit about what's new that's going on in the surgical approach to brain metastases. Dr. Rao?
Thank you. Can you hear me okay?
Yep.
Hopefully you can see my screen. Am I in presenter mode? I can't ever tell.
Yeah, you are a presenter now, but we don't see anything. Is the share button at the bottom of your screen? Oh, here we go.
Am I in the right mode though? Because sometimes
yeah, you'll want to swap that up at the display settings.
Yeah, got it.
Perfect.
How's that? Great. Great. Well, thank you so much, Dr. Day and Dr. Ovi. And I have known Mahua for many, many years. She still looks the same, and I've aged terribly, but I appreciate the invitation for this. And it was great to see Manmeet and Vinay give these fantastic talks. I'm really excited about what the future holds for us. And I'm going to sort of switch gears a little bit and talk about, for some people, a fairly novel surgical option for patients with brain metastases. And my talk is really going to focus not just on brain metastases, but what we do about those patients who have brain metastases that have been treated, particularly with radiosurgery, and what the options are for them. And so I'm going to focus on a new technology called laser interstitial thermal therapy. So I'll briefly talk about the history of the application of laser interstitial thermal therapy, or LIT, in neurosurgery. There are a lot of applications for lasers in neurosurgery, particularly in neuro-oncology. I'm really just going to focus on metastatic tumors and radiation necrosis, but you should know that it has been used and described for primary brain tumors, recurrent primary brain tumors, and even angiomas. And an equally important area of the use of LIT in neurosurgery is for epilepsy. So my colleagues who are epilepsy surgeons have been using it more and more for the treatment of mesial temporal sclerosis, hypothalamic hamartoma, tuberous sclerosis. It's achieved a lot of use, not only in adults, but also in children, particularly for epilepsy. And then I won't talk about it, but you should know that there is an application for this in spinal metastases as well. And that's something one of my colleagues, when I was previously at MD Anderson, Dr. Claudio Tatsui, has really championed. So I am a consultant from Ontaris. They do make one of the laser devices. I serve on their safety committee, but I don't get any, I'm not an investor in any of these companies that I'll talk about. There really are only two vendors for LIT at this time, Ontaris and Visual Aids. I've used both of them, and I'll be able to talk about both of them. So again, lasers in neurosurgery have a very long history. They were actually used since the 80s for tumors in the body. There's a lot of misconceptions about what we use lasers for in neurosurgery. Really what we're talking about is heat that's generated by the tip of the laser fiber and absorbed by the tissues. and the tissue death is temperature dependent. And I'll touch on that in a little bit, but we're really not talking about laser light that would you think about when you see Star Wars or that sort of thing. It's not destroying tissue like that. It's really just depositing heat into the tissues. So the preclinical use of lasers in neurosurgery is actually described many years ago, back in 1986. And then in 1990, a Japanese group described its use for deep-seated brain tumors. If you look at this paper from back then, it's an extremely cumbersome system and was very difficult to use and really didn't take off for use in any meaningful clinical capacity after that description. In the late 90s, early 2000s, new laser devices were being created, and those could be used in conjunction with MRI scan to monitor temperature. So that was really the key, because at that point you could actually see the changes in temperature deposition. As you can imagine, you want to make sure you can control temperature for at least a couple of reasons. One is if the temperature approaches 100 degrees Celsius, you'll get what's called a steam event, and you're essentially boiling the tissue, which is something you don't want to have happen. But you also need to be able to control that temperature and keep it away from critical structures in the brain. And so that's why being able to see it real time with MRI was so important. It also required the use of a stereotactic frame for probe placement. That was a little bit cumbersome, particularly in an MRI environment where you couldn't have something that was metallic. Now we use like cell head frames all the time, as I'm sure many are familiar with this for radiosurgery, but also for the implantation of deep brain stimulators. And those are not MRI. Those are MRI compatible, I should say. And so there's technology to allow us to do that. But really, the first experience, meaningful experience, that was described here. Treatment of a primary brain tumor where they could actually real-time visualize the temperature gradients for this presumed low-grade glioma. And now, obviously this is a tumor that was, you can tell, even the untrained eye can tell that it's probably an inadequately treated lesion. You can see the kind of the penumbra here, so to speak, of how that heat deposition works, and I'll talk about that in a little more detail. But it was really the first time that we could appreciate the use of real-time thermography, as it's called, to identify how that thermal damage is being deposited. Still, there remain some barriers for use. Lasers have been FDA approved for soft tissue ablation, even intracranial, for many years. It doesn't have a CPT code yet, although that's coming in 2022. There's still some negotiation going back and forth between CMS and neurosurgery, but hopefully it'll happen. That is a challenge. So for those of you that are users or neurosurgeons, you know that it's been challenging to get this approved. You need to monitor the deposition of heat in real time. As I mentioned, MRI thermography made that doable. You need to be able to contour the delivery of thermal energy. We need to be very careful with critical structures, particularly when you have lesions near eloquent brain. And then you need to be able to anchor or fix that laser in a specific trajectory so it won't move. And so these were all things that needed to be overcome in order to use this technology. So credit really goes to Alex Carpentier from France, who described LIT for focal metastatic brain tumors in neurosurgery, the journal, over a decade ago. This is work that was actually done with the Visual Aid system before it was bought by Medtronic. That was actually developed here in Houston, and was a project from a couple of graduate students, I think from Texas A&M, basically. And they created this system that allowed for real-time visualization in the intraoperative MRI environment. And really championed this technology. It combined a therapeutic laser with an image processing workstation for real-time MRI-guided thermal ablation. And there was a way to cool that laser, so you need to make sure that it's cooling as well when it's not being used, or that you can immediately turn off the laser if you need to. And then again, relevant changes in temperature can be estimated using the proton resonance frequency relationship, or the Arrhenius model. I won't go into detail about this. There won't be a quiz on this later, but basically this is what allows us to calculate the spatiotemporal behavior of temperature over tissue, or bioheat transfer. So what happens at these various temperature ranges? That's a critical component to delivering heat, particularly to brain tumors. So at 43 degrees Celsius, you get some damage, but you don't kill the cells. And so the real threshold that most of us that use this believe that we need to cross is 46 degrees Celsius. That's where you really see thermal denaturation of critical enzymes and get cell death. And now that we can monitor that temperature in real time, we can actually see where that's happening. 60 to 100 degrees, you'll start to see significant denaturation of proteins and cellular components. tissue coagulation. So at the laser tip, you were often seeing temperatures in the 60-degree Celsius range. And in fact, when we look at these tissues, and occasionally we have the ability to take these lesions out after lit, we can see that there's significant tissue destruction there. We want to avoid going over 100 degrees Celsius. That's when you get vaporization of water, and that can be catastrophic because you can basically get a boiling event in the brain. So these temperatures need to be very tightly regulated during the procedure. The zones of damage were described several years ago. Basically, again, at the tip of the laser with some radius, you will get maximal thermal damage, and then you can get sort of an effective ablation beyond that, where you're probably at about 46 degrees. Then beyond, below about 43 degrees, where you still see some damage, you won't get any cell killing. And so that can be particularly frustrating if you can't get the laser hot enough to treat larger lesions. But there are ways to overcome that, as I will show you briefly. So I mentioned we have to create a trajectory. We have to anchor the laser probe to the skull, advance the probe to a target, hold the laser in place. Again, initial descriptions with a stereotactic frame. These are all barriers that have been overcome, but it can take several minutes to sometimes a few hours actually to generate enough heat or deliver enough heat to a lesion. And so keeping that laser still in the target is critical. So the probe implantation has gone through a variety of iterations. Placement of this in the intraoperative MRI environment or any operative MRI environment is challenging. I've seen all variations of skull fixation. This is just an example of several different types. I mostly use the BrainLab or VariGuide system for drilling a hole and fixing what's called a bolt to the skull. So you fix that bolt to the skull, and that allows us to pass the probe through, and it maintains her trajectory. And we pre-plan the trajectory, and we can actually, when we do an MRI scan with the laser in place, we find that in our series, less than 1 millimeter deviation from planned and actual trajectories, which we find acceptable. It's something that's critical when you're off and you don't implant the laser directly in the lesion you want to treat. That can be really frustrating and often requires us to redirect and replace it, and that can take a lot of time. When you're placing this, I generally target the deepest part of the lesion on the software. There's often some heating from the tip of the probe, usually about 5 millimeters or so. So you don't have to put the probe directly all the way to the target. You can actually back it up a little bit. The visualized fiber is slightly smaller. It's a diffuse tip. It's saline cooled. The Monteris fiber is variable. They have up to 3.3 millimeter probes, so you can get a larger lesion treated that way. And it does have side fire capabilities, meaning you can actually directionally steer that. And I'll show you some examples of that. It's a CO2 cooled tip. So that's sort of the background of where this technology, how it's developed, just a very, very brief history. But really, I find the most useful indication for this technology is for those patients who have already had stereotactic radiosurgery and now are progressing. And as you've heard from two excellent talks and from Dr. Dempsey prior to that this is becoming a more and more common problem. What do we do with these patients who have radiosurgery? Their systemic disease is under control. Their NED outside of the brain, and now you've got this lesion that's progressing. And sometimes they're not big lesions, and many neurosurgeons are loath to take them out with surgery. And so there are some options, right? And the other thing is it radiation necrosis or is it progressive tumor? I don't think any of us really feel like there's a 100% specific or sensitive test for this. Historically, I think we thought it's been a mixture of both of those things when we do end up taking those lesions out. And I think options are really limited for patients with local failure. We have the ability to, we put people on steroids and hope it gets better, and often it does. In the places I've worked, both here at Baylor and across the street at MD Anderson, repeat radiosurgery has generally not been performed because of the high risk of inducing radiation necrosis. There is a potentially a role for whole brain radiation, but we're getting more and more away from that. And of course, use of bevacizumab has been championed by a lot of folks, and certainly has its place. I would say anecdotally, our oncologists are always thrilled about you throwing bev at somebody, particularly if they're getting systemic treatment. And so there are options, but as we all know, we put people on steroids, they fail the steroid taper, and then you throw your hands up and say, what are we going to do? So the nice thing about LIT is that it's sort of agnostic to the etiology of progression, whether it's progressive tumor or it's radiation necrosis. I will say, well, I've said that I think the best indication for the treatment of radiation necrosis, how that works is actually a bit unclear. So let me show a couple examples. This is a patient with lung cancer who presented with a very large lesion, sort of the posterior thalamus on the left side. The only lesion in his brain, underwent gamma knife radiosurgery, had a nice response initially, but then 6 months post-op, starts to see a recurrence here, and it's on steroids, but over time we're just watching this is getting bigger and bigger. This is actually one of my first laser cases many, many years ago. And so this is the visual probe. We actually implanted it directly in. You'll see this little hypo intensity here where the probe is. That's because we did a biopsy, and when you do, and I did several bites, which is something I learned not to do in subsequent cases. The more bites you take, you induce a little bit of hemorrhage. You can actually introduce a vacuum phenomenon, so you can introduce air into that area. And that can affect the thermography. So this is an example of the actual real-time thermography. You can see the temperature gradients. Both systems have the ability for you to do what's called a pick point. So actually can just grab a point in the thermography and it'll tell you the temperature. But you can see this black spot here. That's actually the dropout from the biopsy, from the air or the hemorrhage that was caused. And so I do take biopsies now. I usually just take one sample, just frankly for posterity, so that a pathologist can say, okay, there's necrosis or there's tumor here. More than that, I think you run the risk of causing this artifact, which can really affect the thermography. But this patient had a good response. This is 2 years post-lid. He was NED outside the body. It's actually, this patient lived for many more years after this, and this lesion continued to get smaller and smaller. So that was sort of my first foray into this, and I think really showed, for those of us that use this technology, there is value to it. For the larger lesions, that lesion I showed you was perfect. It was a nice spherical lesion, easily targeted. Here's a more complicated one that's a little more asymmetric. So it's a patient with breast cancer, a young woman, multiple metastases, underwent gamma knife and whole brain radiation several years ago, and then started developing this recurrence in the cerebellum. It started getting a little bit larger, a little bit fluffier, probably radiation necrosis. And she has some local mass effect on the fourth ventricle, you can see, but started really getting symptomatic from this with cerebellar dysfunction, even some slurred speech, that sort of thing. And so this is a more challenging case. It can be done. These are actually two separate probes. So you can see a probe coming more laterally and a probe coming more medially. And the patient is prone, and this is in the intraoperative MRI environment. So in the prone position are some challenges, but it can be done. And this patient had a good response. So I'll talk about this in more detail a little bit later, but you'll see initially there's actually an enlargement of the lesion, right? So there's this thin rim of enhancement. We started to realize that was very common. Then over time, it gets smaller and smaller, and you can see at 10 months, it effectively was much smaller than it was in the initial presentation. The mass effect is better, and the flare abnormality is also significantly better. So again, it's a longitudinal process. It doesn't happen overnight. As we all know, it's not unusual now for patients to be treated with stereotactic radiosurgery for multiple metastatic lesions. Dr. Gandhi mentioned treating up to 30 lesions with radiosurgery. I think Dr. Alwa may have mentioned this, but I think we've known anecdotally that immunotherapy, because it causes an inflammatory response, may lead to an increase in the incidence of radiation necrosis. And our oncologists generally have not liked us to put patients on steroids, so that although we have to do it for LIT, putting them on steroid tapers, month-long steroid tapers for the treatment of radiation necrosis is usually less desirable. So you can actually use LIT for multiple lesions, and there's a few ways to do this. I won't belabor this, but this is a patient I treated with multiple melanoma mets that progressed after radiosurgery. We avoided a whole brain on her, and actually she had a good response to all these lesions. Even when they're in opposite hemispheres and opposite lobes of the brain, you can do this. As a patient presented with lesions that progressed. He actually had a craniotomy, so that's this artifact up here for a large left frontal met, but then developed these deeper mets that weren't, I think, suitable for surgery and responded initially to radiosurgery, but you can implant multiple probes to treat those, and he has an excellent response to that. The extent of ablation is key. This is a paper by Ricardo Comataro and my colleagues at the University of Miami who showed that you really need to get good coverage of the lesion with the thermal damage to decrease recurrence. And in our own data, this is data we published a couple years ago, we see that with complete ablation, our progression-free survival is significantly better than it is we don't get the whole lesion covered. So that's why many of us are extremely fastidious about making sure the laser probe gets placed properly. That's probably the most stressful part of the case. We looked at our response. This is a few years old now, but we looked at our experience with the volumetric response of lesions that progressed, metastatic lesions progressing post-radiosurgery with LIT, and saw highly variable. Most of the lesions did respond over time, and I draw your attention to, this is the T1 contrast and the flare volumes over time. So of course we lose patients as they succumb to their disease, but there's initially an enlargement on the post-contrast scan compared to the pre-lit contrasted study. But over time, that does go down. And statistically, the most significant decrease is in the flare sequence at 4 months. And so that's when you'll see a significant reduction in that. So I tell, the oncologist and the patients, it's going to look larger the first month or two after the procedure, but eventually it should settle down. It's usually what happens. There's an example of somebody who had radiosurgery. You can see the gamma knife MRI here, but then it progressed. We dropped in a probe, and it significantly reduced after time. This is an example of somebody did not respond, so had progression after gamma knife. You can see the probe placed here, and then it continued to progress over time, and eventually this patient needed a cream. For those of you with an intraoperative MRI scan, you need to make sure that the patient and the laser fit in the bore. The trajectory that's coaxial with the bore is much easier. This is a wireless coil that can actually be placed over the probe. That's actually very convenient. It works well. We also use body coils that can be wrapped in ioband to put on the laser. This is the intraoperative MRI environment that I used to have at MD Anderson, but most places don't have this. You can actually do the procedure, place the laser in the regular operating room, and then transport the patient down to a diagnostic MRI scanner. It's actually probably a little bit easier to do it there. Just very briefly, I want to talk about diffusion tensor imaging. So for lesions that are near eloquent cortex, you can actually incorporate DTI. So these are fiber tracks here, and with the directional laser, let's see this works, you can actually steer the heat. So you should, in real time, what you see is this yellow or blue. This correlates with the temperature. So you actually can steer the heat away from these structures. The lesion's outlined in purple here. It's a little bit hard to see, but you can see how it will actually backfill. But this is a nice way to actually stay away from those structures. Several centers are using this now. I will draw your attention, in fact, you can see Manmeet's paper here. I will draw your attention to the fact that the complication rate is not low. This is usually temporary. The patients, particularly lesions near eloquent cortex, there is again, a penumbra. You can actually cause some swelling or inflammation near those areas. And that can cause some temporary side effects. I do put patients on very slow steroid tapers, usually 2 to 3 weeks, and then get them off. This is a large study, a registry study that many users put together from 14 centers. And just to let you know, its use for metastatic disease is really limited to recurrent or radionecrosis cases. Very few people are doing this for upfront for newly diagnosed mets. I still think radiosurgery, and as Manmeet mentioned, the results with targeted therapy and immunotherapy is so remarkable that it doesn't make sense, I don't think, to do this for newly diagnosed mets. The length of stay is very short. This is in hours, so less than 2-day hospital stays in general. I'd say in my experience, most patients are going home the next day. So it's a very nice, minimally invasive treatment option, just to show you that for metastatic disease, the survival curves are actually reasonably good over time. So I know I'm a little over time, just to brief lessons I've learned here for those of you that are thinking about doing this or potentially use it. I usually don't even try it unless it's at least a centimeter in size. Positioning that probe is absolutely key. You've got to spend time doing this properly. There is a device called ClearPoint that's a little more cumbersome. It adds a lot of time to the case, but I have used it in case the lesion's on the borderline of that 1 centimeter, and I need to be very accurate. I usually use the Vario guide from BrainLab, which is relatively simple to use. I use lower wattage, so with the lasers, you actually can control how much heat is being delivered. And I generally heat from the target and move retrograde from there. Again, the dramatic edema after lit that must be managed. I generally use very slow taper of steroids, slow ramp up in temperature. Both systems have the ability to do this. If a patient is presenting with a deficit, it'll likely get worse after lit. So you have to tell them that. There are ways to incorporate new MRI sequences, including DTI, to avoid critical fiber tracks. And again, the complication rate is not trivial. So I think I've already mentioned all this. And I'll say it helps to have buy-in from neuro-oncology and radiation oncology. At Anderson, the radiation oncologists would often ask us if we could do lit for a lesion, which I thought was great. So once people buy in and see the results, it's actually, I think, a very useful technology. The more you use it, the more efficient you will get. That's all I have. So thank you. Sorry for going over.
Oh my gosh, no worries, Dr. Rao. That was just an absolutely amazing talk. I think it's encouraging actually to see some of these alternative therapies for tricky spots that we get ourselves in, especially you know, it's a problem that I know everybody on this call has probably encountered, which is you know, the unfortunate risk of recurrence following stereotactic radiosurgery or whole brain radiation therapy. And it's good to see that there's such exciting opportunities that are emerging in order to help with that problem. So thanks for sharing that with us. I'd like to move on at this point and take this opportunity to introduce Dr. Kaufman. Dr. Tim Kaufman is currently on faculty at Mayo Clinic in Rochester, Minnesota. There he's a neuroradiologist with clinical and research interests in both diagnostic and interventional radiology procedures for both brain and spine metastases. I've had the opportunity to hear Tim talk at multiple other venues on imaging for brain metastases, and clearly he's an expert in the field, and we're super fortunate to have him here with us today. And I think his topic is certainly relevant considering the speakers that have preceded him. So Dr. Kaufman, welcome, and the stage is yours.
Thank you, Dr. Bovee and Dr. Day, for the invitation. I'm grateful to be a part of this meeting. All right, can you see my screen okay?
We can.
Great. Okay, so I'll cover briefly some points about imaging of brain metastases. I don't have any relevant or oncology related disclosures. And I think as you all are making inroads into this otherwise pretty terrible disease with more promising treatments, we on the radiology side of things need to be better with our imaging for both upfront diagnosis and then in judging response assessment. So first I'll talk about detection, and the main issue here I think is with small metastases, detecting those accurately. Number two, the significant dilemma of trying to judge radiation necrosis versus recurrent tumor, particularly after stereotactic radiosurgery. And related to that, I'll cover in a brief overview advanced imaging techniques, or physiologic or mechanistic or functional imaging techniques, which may give us some insight. And in general, I would say, to summarize, they have promise for sure, but limited, at least multi-center validation, most of them. So first, detection. And I'll just throw in out of what was interesting to me, I'd never really thought it through, but brain metastases often do not follow a size distribution that's Gaussian, but rather there's often one large metastasis and then several smaller ones like this. This is from the radiology literature. If you hadn't seen it or hadn't really thought it through like I had, I just thought it was interesting, and this suggests that the brain metastases are not growing independently somehow. So the big ones, we don't have any problem with detecting. The small ones, yes. And in general, 3D volumetric imaging, which means thin section imaging, we can slice it then into thin sections. That will beat any 2D or thick section imaging for detecting small metastases, and this has been well demonstrated in the literature, and of course would be intuitive. Among the 3D thin section volumetric techniques, there are two main groups of techniques. And the first is gradient echo based, like SPGR, or if you add an inversion recovery pulse, IR-GRE techniques like MP-RAGE or Bravo. Those are really common. They're easy to perform. They're beautiful images. And MP-RAGE or equivalents form the backbone of the BTIP, the brain tumor imaging protocol that Ben Ellingson and others described in 2015 for primarily glioma trials. These gradient echo-based techniques are also used for stereotactic planning and radiation planning, and then perhaps as downsides, if we want to find small metastases, there are many small vessels that are seen with this technique because the gadolinium is visualized. And so if we subtract pre versus post MP rage, we can see all those little dots on any one slice. And so you can imagine that finding a 1 or 2 millimeter metastasis in that sea of other little bright dots can be difficult. So an alternative would be 3D FSC fast spin echo techniques like Space Cube Vista. Those are 3 different vendors' products. And a main advantage of those techniques is that there's inherent flow suppression. So those little blood vessels in the subarachnoid space largely get their signal with gadolinium suppressed. So, and not entirely, but for the most part. So that helped a lot with seeing little small peripheral metastases. Also, the white matter is relatively less hyperintense on a 3D FSC compared to a Bravo or an MP Rage or SPGR even. And so an enhancing metastasis on that background may stand out better, have a higher contrast to noise ratio. So again, for the larger metastases, of course, it doesn't really matter for at least detecting the metastases, though it has been shown that the volume, and this will be of interest to those doing SRS, the volume may be represented differently with these 2 camps of imaging techniques, post-GAD T1. For the small lesions, though, like this particular lesion, yeah, on a good day, I think we would all see this one in the temporal-occipital region, but maybe on a bad day, we'd miss it on an IR-GRE, but it stands out obviously on the 3D FSE. And this has also been borne out in the literature. Multiple people have published on this. Here's a study from a couple of years ago, and they give examples of small metastases seen better with 3D FSE than with MP Rage. And they found twice as many small, that is 5 millimeter or less, brain metastases with their 3D FSE technique compared to MP Rage. So that's the first point I'd like to make in the talk, is that 3D FSE is better for small metastases. Disadvantages of it may include, though, that it's not a stock sequence on older scanners, at least. Now, if you buy a new scanner, it'll be on those scanner platforms for the most part. The detection data that has been published has been mostly from 3T. There's one paper that just came out describing similar findings with 1.5T. I will maybe caveat all this. When we at our institution started looking at 3D FSC some years ago, it was not so great at 1.5T field strength for the most part. And that has changed, though, with newer platforms. I think its quality and its ability to visualize small metastases has come to approach that of 3T. 3D FSC isn't standardized across vendors like MP Rage is, for instance, and so that is maybe an issue for clinical trials. And one can't use it directly in stereotactic radiosurgery planning with a metal frame because of eddy currents which are induced. It works really differently than MP Rage or SPGR in this way. So you would have to perform it prior to putting on the head frame and then registering it, or using frameless SRS, or people are working on some frames with laminations and cutouts that might get around this eddy current problem too. And I'll just refer you to this article if you're interested in an imaging protocol that can be used for clinical trials or clinical purposes that it addresses some of this T1 weighted post-gadolinium issue. And if you do SRS yourself, or you're looking for small metastases, I'll just point you in the direction of this article too. If your workstation allows you to use overlapping MIPS, I always finish off my search with overlapping MIPS because it's a quick way to more sensitively perhaps run through the brain to find small metastases. You see them on multiple slices if the MIPS are overlapping. MIPS are maximum intensity projections. If you have a viewer that allows you to, it's very easy to get these. Your text could produce them for you too. All right, on to radiation necrosis now. So as you all know better than I, SRS is increasing in use, which is great, but along with this, we see enlarging, enhancing lesions post SRS, maybe a third of the time, something on that order. And so it's hard to know, is that tumor or is it necrosis? or both, a mix. And so, of course, the diagnosis is difficult, and even with surgery, it can be difficult. And so that's the motivation for turning to imaging to try to help us with this differentiation. And so brain radiocnecrosis, most common after SRS or high dose fractionated RT, typically 3 to 18 months after SRS, up to 3 years has been reported. And the overall incidence, that varies in how it's been reported as well. It depends on how you measure it, but it might be around 10%, something like that. And it is higher, the incidence of it, with immunotherapy. So say we have an enlarging lesion post-SRS, what would be the likelihood a priori that it's tumor versus radiation necrosis? Well, with the caveat that the data that I've seen would have to have some selection bias here. Lesions were intervened on surgically. It might be something like this. So here's a series by Narlock, which was mostly needle biopsies, and a third of those cases were tumor and 2/3 radiation necrosis. And then Nath et al. Looked at gross total resections and found again a third tumor. And then the 2/3 that are left, half of that was radiation necrosis, pure radiation necrosis, and the other half was radiation necrosis with a little bit of microscopic tumor. But it was suggested that that amount of tumor can influence the prognosis of the patient, so it's not that it's unimportant. So you maybe flip a coin for at least lesions that you might be thinking on intervening on might be 50% roughly chance of a tumor versus radiation necrosis on that order. So common. All right, so if we just look at an enlarging lesion on standard conventional morphologic MRI, you may have heard of the so-called cut green pepper soap bubble appearance of radiation necrosis. And all I would say about that is these means of qualitatively judging whether there's radiation necrosis or not have not really been validated. So I don't think that they're that helpful. So I wouldn't personally advise you to use them. It would be great if we could get an answer to this question, radiation necrosis versus viable tumor with standard MRI in other ways, and the lesion quotient has been purported to be helpful here. And the idea behind this is that if we have a T2 hypointense, kind of a dark nodule on T2 weighted imaging, like over here on your left, that if the diameter of such a nodule is large relative to the overall diameter of the enhancing lesion, that suggests viable tumor. And so the first couple of papers on this were promising, but others have struggled to find that it's that accurate. And I would say that my experience has been similar. And sometimes I think maybe it's leading us in the right way, but maybe not always. So I'd say at the least it's insufficient. So that's why we moved to so-called advanced imaging techniques. So here's a list of them. There are several different types, and I'm just going to give you a very brief 30,000-foot overview of them. So of them all, the Brain Metastasis RANO group said in 2015 about enlarging SRS-treated metastases that these advanced imaging techniques like MR perfusion, MR spectroscopy, and PET, the literature on them is insufficiently robust to conclude that any one modality or approach can be recommended across all patients to distinguish between radiation necrosis and true progression. I think that pretty much is the state of things in 2021 as well. But we'll talk about them because I do think that they are of some value, maybe a lot of value. I think we just need to study them better and standardize them, generally speaking. Okay, so contrast clearance, the first technique I'll talk about. This is just standard conventional MRI, but I included in the advanced technique portion, you need specialized software in order to do it. And so the idea is that you do a scan of the patient as you would normally do, and then repeat the post-gadolinium T1 weighted imaging, only that, like another 5-minute scan, at about an hour thereafter. And then if you register and subtract voxel by voxel the intensity differences in your enhancing lesion tumor should wash out faster, should wash out the gadolinium faster than radiation necrosis is the idea. And at an hour or so, you might see some separation between the two. And there's some reasonable data on this. And actually, our institution has just got the software that allows us to do this. So we're about to try it. So I'm excited about that as maybe one more technique. But I would say, again, maybe that we lack a little bit in multi-center validation of this. All right, DSC perfusion, or dynamic susceptibility contrast perfusion. This is the type of perfusion imaging that most people are familiar with. And it requires a gadolinium bolus, usually a little bit larger IV, but only about 3 minutes of imaging time. And if patients are getting gadolinium anyway for their MRI, why not, is how I look at it. So the idea is that cerebral blood volume, the volume of venules, capillaries in viable tumor, should be larger than the CBV, the blood volume in radiation necrosis. But about DSC perfusion, it's very technique dependent, and this is all the way from how we give gadolinium, whether we use a preload or not, how much gadolinium, to the parameters within the pulse sequence itself, like the flip angle, that actually turns out to be pretty important, and what sort of CBV we end up getting. And the software that we use, whether leakage correction is used, how we draw regions of interest, all of these things are really pretty important in the answer that we get about whether there's increased CBV or not. And then we have to have some threshold to say, yeah, this is too much, or this is not enough to suggest recurrent tumor. And so standardization needs to be used and studied, and I think in a multi-center setting before we could really run full bore with this. There is a nice paper out there I'll direct you to. Recently, a white paper, consensus recommendations for DSC MRI for use in high-grade gliomas, but this also applies just as well to brain metastases, I think. So if you're looking for a standardized, approved, thought-through approach to DSC, like what parameters to use on your scanner, you could look at this article. So here's how DSC perfusion could be used. Here was a solitary metastasis in the cerebellum, and it grew quite a bit after SRS. And so perfusion imaging was done. And here, it's nice when it's unequivocal, right? So here we have all this red in the lesion. And so this was increased RCBV, suggested viable tumor, was taken out, and indeed it was. Now to DCE, or dynamic contrast enhanced imaging, or permeability imaging, you might hear it referred to. This is an alternative to DSC, or it can be performed along with it, usually performed first, so the DSC gets some preload with GAD. It's less sensitive to susceptibility artifacts, like for lesions near the skull base, or if there are blood products around, and that's a big advantage, I think, of DCE. And a second big advantage is that it's independent of contrast leakage effects, which affects our accuracy of DSC estimation with that technique. So definite advantages. The big disadvantage is that it's technically challenging. We get 10 times less signal change with the gadolinium bolus going through than we do with DSC, so less signal to work with. MR spectroscopy. This is one of those techniques where if you do it a lot, you're probably pretty good at it, and then it's probably a good idea if you don't do it a lot. I think it's tough. There's a learning curve for sure. So with brain metastases, choline is increased. That's the biggest thing to look for. Lipid and lactate may be as well. With radiation necrosis, it has been reported that choline can be increased early, but it should be decreased late. And that is the main point of differentiation between radiation necrosis and metastases. So in this particular SRS-treated breast cancer metastasis in the temporal lobe, choline was really elevated, and so that suggests viable tumor. And with MR spectroscopy, as with perfusion, standardization is really needed, how it's acquired and how it's interpreted. PET. So everybody's familiar with FDG PET. The big problem with this for brain lesion imaging is that there's such high background uptake in the normal brain. So if you have a lot of uptake in background, a high uptaking tumor may be hard to find in that sea of high FDG uptake. So yes, Some people advocate it. Some people will swear it off entirely. Amino acid PET, on the other hand, doesn't have that issue at all of the background uptake. With F-DOPA has some basal ganglia uptake, but still the problem of high background uptake is mostly got around with it. And I would think of the techniques as pretty equivalent. C11 methionine, or MET, PET, F-DOPA PET, FET PET, all pretty similar, and they all have pretty good accuracies, reasonably good accuracies. It's just in the United States, at least, we can't do it unless patients are on trial because it's not FDA approved. And there's nothing in the pipeline within the next year or two, at least, for it to be approved, if not longer. In Europe, they use it all the time, I understand, and they like it, and that's great if you can. But that's the big drawback to amino acid PET in the US. I'll mention IRANO. I'm sure you're familiar with this too. You know, the general guidelines have been that if there's a new or worsening lesion within 6 months of immunotherapy initiation, then we should follow up with imaging for at least 3 months thereafter to confirm or refute that progression. And it is almost certain that there will be different likelihoods of pseudoprogression with different immunotherapy agents. And so this suggestion, I'm sure, will be revised in the future, but at least it's some sort of advice on how to deal with the pseudoprogression issue of immunotherapy. But the advanced imaging techniques are not necessarily so great. I mean, there's very poor data, very little, precious little data, I should say, on advanced techniques in the immunotherapy context. But if we have an inflammatory cell infiltrate, we might see low ADC, increased perfusion, increased PET uptake, all the things that we might normally rely on to differentiate between a viable tumor and radiation necrosis. So it's not quite so simple in the immunotherapy context. All right, so what's next? What's coming up next in diagnostic imaging? Maybe metabolic imaging. That's one new high-tech thing, low resolution and technically demanding, but we could get some insights into pH and hypoxia, for instance, just with MRI. Then, of course, machine and deep learning. So AI has been used for detecting brain metastases first, to find those small metastases, to distinguish between a solitary metastasis and another histology like glioblastoma, or to predict survival after a particular therapy. So AI, I'm sure, will be helping us out in the future, but not to the clinic yet. All right, so how would I conclude? First, I like 3D FSCT one-weighted imaging for metastases, and so I would advise that if you can, it's best at 3T or newer 1.5T scanners. Radiation necrosis is common after stereotactic radiosurgery, as is admixture with tumor, unfortunately. And that's something that we are just not going to get around. Advanced imaging techniques, if I can call them that, many lack multi-center validation. So I would just recommend that you do what you can do well at your particular site. And it's nice if you can stack them up, like DCE plus DSC, for instance, or add spectro. If you get congruent results with two techniques, that increases our confidence, of course. And that's all I have for you today. So again, thanks very much for the invitation and your attention.
That was just a great talk, Tim, and incredibly clinically relevant. I think in line with Dr. Rao's discussion, you know, your field in radiology is certainly paramount in order for us not just to detect and diagnose brain metastases, but also clearly in the form of targeted treatment and treatment outcomes. So thank you so much for that. I thought that was wonderful. That concludes our first section. We have the opportunity now for questions to be posed to our panelists. Please feel free to use, to our attendees, please feel free to use the Q&A box in the lower right-hand corner of your screen. And if there are questions that people have for any of our initial speakers, please don't hesitate to ask those. Dr. Alawalia had another commitment that he had to get to, and so he's not able to join us for our talk. Just to, or for our panel discussion, I should say, just to kick things off and to ask a question to the panelists, and perhaps Benai, I can pick on you first, seeing as Manmeet was not here. He had presented some slides that Rupesh Kotecha obviously had worked on when he was at Cleveland Clinic, looking at the utility of focused radiation combined with immune checkpoint inhibition. And one of the things that I'm always curious about, just because we seem to try to recreate the wheel every time we encounter this at our own institution, is how you manage patients who present with low volume metastases but have a targetable mutation. So say a patient with lung cancer with an EGFR ALK mutation presents with low volume intracranial disease. Do you tend to turn to drug therapy first? Or is that something that you would submit the patient for stereotactic radiosurgery upfront, or a combination of both? I'm just curious about your thoughts on that.
Yeah, no, thanks, Joe. First of all, those were some amazing talks, both by Dr. Alawalia, but also by Dr. Rao and Dr. Kaufman. And I think this session speaks to the answer to your question, which is it requires a multidisciplinary discussion in general, involving medical oncology, neurosurgery, neuroradiology, and radiation oncology. But in those scenarios where we know that we're going to get at least stability or response, and it's going to be durable with certain targeted therapies, I tend not to hold off on upfront radiosurgery, but with certain caveats. Number one of the things that has become increasingly important for us as radiation oncologists is that we understand what is eloquent brain and what is non-eloquent brain. And this is where we need to have multidisciplinary discussion with our neuroradiologists. So if I see a small lesion, for instance, in a precentral gyrus, even in an asymptomatic patient, even if they have a targetable mutation, I do have that discussion about the potential that there may be heterogeneity with respect to that targetable mutation in that particular lesion. Radiosurgery could be delivered very safely to try to control that lesion and prevent any neurologic symptoms further down the road, and at least have that option available to patients and allow them to make a decision about what they would like to do. Other scenarios that we've faced in our practice is that there is sometimes a challenge with getting through the system. So if a patient comes with brain metastases, we have a high suspicion that they probably have a targetable mutation. Well, it takes a couple weeks to get that analyzed. And then it takes another couple weeks to get a targetable mutation, a drug therapy approved by insurance to initiate. And so when I anticipate that there's going to be some delay, and if there is a lesion that I'm concerned about, then I sometimes will offer upfront radiosurgery. These are exceptions to the norm in general, but I think it really requires a multidisciplinary discussion and one that is patient-centered in their decision-making.
Excellent. Thank you so much. Dr. Sehgal is able to join us from Toronto, and I think, Dr. Kaufman, this is a question that would perhaps be posed to you. He had indicated that they find CEST imaging to be very promising for radiation necroses and early response prediction post-stereotactic radiosurgery. Do you have any experience with this, or is there any movement in the field to consider utilizing that as an additional tool for demonstrating treatment response versus tumor progression?
Yeah, I think that it'd be fantastic if that panned out. It's technically difficult, so the more advanced imaging centers should be able to pull it off. Yeah, I just haven't seen much data out there in this context on it, but I would welcome it. I'd love to see it. There may not be any magic bullet with imaging, but any incremental gain that we might get from it, from a new technique, I mean, fantastic. I'd be all for it. So yeah, I'd love to see some data from this site, and thanks for raising the question.
Sounds good.
Since we have both Dr. Rao and Dr. Gandhi, and both SRS and LIT, at some point, they both modality claims to be more immunogenic or bringing out new epitopes, and it has a combination therapy with immunotherapy. And on the basic science side, people are still kind of dancing around this concept of abscopal effect of radiation. Is that something you see with LIT too? And what are your thoughts, Dr. Gandhi, on this and radiation?
I guess
Go
I
ahead,
can,
Dinesh.
oh, go ahead.
You first, please.
Yeah, so it's a great question. I think that, in fact, there are trials, not in the Met space, but I'm sure you know in the glioma space, recurrent glioma space, combining LIT and Pembro. And I think I've been hearing that actually the results are quite promising. I think it's a little bit of cart before the horse in terms of we don't really know whether it's an abscopal effect or if there's a neoantigen response from LIT. We do know that with denaturation of some of those tumor cells, that you are going to expose the immune system to new antigens. And so there is some very nascent basic science on this, I think, right now, looking at whether or not you can actually prime the immune system or prime the environment for the response to immune checkpoint inhibitors. So I think it's still early days on that. Conversely, I think when you give checkpoint inhibitors to Mets, we're probably inducing this inflammatory response, which is why I think we're seeing more and more of these radiation necrosis cases happening after radiosurgery has been given to patients who are on checkpoint inhibitors. And maybe even I have seen that as well. I can comment on that. But I think that combo is actually resulting in us doing more LIT. Whether or not LIT and ICI can work together, I think is still an unknown question.
Yeah, just to add to those points, I think they're really good points. I think Mahua used the right term. It's a bit of a dance, and at some point we need to stop dancing and just create some evidence. And the best evidence we have, unfortunately at this point in radiation oncology, is the timing evidence. And I think Manmeet pointed to one paper from Rupesh. There are a couple other papers that talk about the timing of radiosurgery relative to the initiation of a checkpoint inhibitor. That seems to bear out what the biologic hypothesis is that when you time it and at the initiation of checkpoint inhibition, you presumably are creating immunologic response that then translates into intracranial control and survival outcomes. But those are all retrospective series, and we really need a prospective study to really validate it. And I think the TROG study is going to be doing that. We've proposed a number of concepts in energy oncology on this front. It's a bit of a hard trial to run, in part because industry is really not that interested in the idea, and neither is NCI at this point. So the best we have is the data we have, which there seems to be some interest in timing. Where I think there's a sort of a very careful balance we're trying to strike is what Dr. Rao just mentioned, is when we do dual checkpoint inhibition, and we use radiosurgery, we sometimes overdo it. And then we start seeing post-treatment changes. So that almost argues to the point of either de-escalating radiosurgical dose, or some of us are actually doing fractionated radiosurgery to try to prevent that from happening. Whereas the other part of this seesaw is many patients, as Manmeet mentioned, can't receive dual checkpoint inhibition. I mean, there's 30-40% grade 3 toxicity when giving Nivo and Ipi. And oftentimes they're treated with Nivo monotherapy. And I think in that scenario, I hypothesize, and many of us do, that perhaps there is an immunogenic response that radiation can offer. But again, more data is needed.
Excellent. I want to thank our initial group of panelists. This was just a phenomenal start to our morning. And at this point, we have a built-in 10-minute break for hopefully coffee and snacks in your own venue. And we'll reconvene, and we'll get started at 10 after 10 with Dr. Segal's discussion on spine metastases. So thank you guys so much, and we'll see you back in 10 minutes.
Phenomenal. All right, that's good. Well, it's 10:10, so why don't we kick off our second phase of our Central Nervous System Metastases Symposium. Welcome back, everybody. If there are folks that are just joining us, Dr. Mahua Day and I welcome you back to the UW-MCW Central Nervous System Metastases Symposium. We had a great start to our morning with brain metastases. We're going to migrate a little further south and talk about spine metastases next. And I'm just incredibly fortunate to be able to introduce our next speaker. Dr. Arjun Sehgal is a radiation oncologist at Sunnybrook Odette Cancer Center in Toronto, adding to kind of our international consortium here, which is fantastic. I've had the pleasure of working with Arjun as part of Electa's MR-Linac consortium, which has just been amazing. He's heavily published in stereotactic management of both brain and spine metastases. And today his discussion is going to focus on the latter with an update on stereotactic radiotherapy for spine mets. So my friend Arjun Sehgal, welcome, and thank you so much for agreeing to chat with us today, which, as he informed us, if you hadn't joined us yet, is actually Canada's Thanksgiving. So thank you so much for joining us on holiday, Arjun. We appreciate you.
Welcome. It's a great pleasure to give you an update on the evidence supporting spine SBRT, because there really has been a paradigm shift now in the management of these patients. So just my disclosures. So ultimately, what we've seen in the beginning with stereotactic radiosurgery was really response. And we never really saw response in spine mets with conventional radiotherapy for two reasons. Number one, the dose wasn't high enough. And number two, we really weren't looking for it because we never did serial MRIs on these patients. And we weren't following necessarily as radiation oncologists with the rigor that we do in the brain, as we heard in the previous excellent talks. And so the whole field has changed now in spine mets, somewhat to the chagrin of our radiologists, because now they're doing spine MRIs all the time. And it really has increased the burden in terms of imaging requirements, but it's improved patient care. And in a patient like this with renal cell carcinoma, treated with spine SBRT, you're seeing a phenomenal response that you would never see with conventional radiotherapy. And so why is this? And why do we do this? Well, number one, it was local control for the reasons that I showed you in the last slide, but then there's also pain control, because we really haven't done a good job in terms of complete response rates for pain. And we propose that these high doses, that we really escalating the biologic effective dose, 24 and 1, 24 and 2, 30 and 5, 30 and 4, there's a host of SBRT doses, are much greater than the traditional conventional radiotherapy dosing. And you have to remember also, there's heterogeneity in the dose distribution, and that's why just straightforward BEDs are representative, but not necessarily the truth. This is high dose stereotactic radiation to bone metastases, in this case in the spine. So I came up with 24 and 2 because I was finding a lot of toxicity with 24 and 1, in particular vertebral compression fracture, and 3 fractions was too onerous. And so I wanted to find some middle ground, and I developed a 24 and 2 regimen, and it just made sense to me, in terms of how to approach the issue. And we liked the dose, and then we built it forward. And we built it forward, and we used it for many years. And we published our kind of mature results of imaging-based follow-up, showing a good 90% local control at 1 year. By about 2 years, you're starting to get to that 85% local control rate. But our fracture rate has been very stable at about 10%, and that has been actually replicated by multiple groups. So it is a risk versus reward type of scenario, with fracture really the biggest adverse effect that we'll talk about. So what's the randomized data? Because ultimately we can do all the single institution, phase 1, phase 2, retrospective analysis, but you need randomized trial. So the phase 2 German randomized study came out while we were accruing on RTOG 0631 and the Canadian SC24 study, which is mine. And these data really helped us. We loved this. This came out, complete response rate with SBRT, 24 and 1 versus 30 and 10, 40% at 3 months, at 6 months, 50%. And it was not powered for superiority. This was a sample size of convenience. So this is good data. This shows you the potential, the promise for the technique, and then you have to validate it with an appropriate sample size with your statistical a priori analysis. But this helped us benchmark the results, the stratification factors, but also the sample size calculation. Now, what they did find was that the rates of vertebral compression fracture were much greater, which also we knew with high doses like 24 and 1. And then came RTOG 0631 that was presented. We're still waiting for the actual publication, but ultimately this was a randomized study of 8 gray in 1 versus 16 or 18 gray in 1. Pain at 3 months was the primary endpoint, and they used a validated scale, and they had some accommodation for narcotic requirements into the pain response criteria, but it was not international consensus response criteria. And ultimately, what the study did was it dampened the field in the sense that we're all disappointed that it showed no benefit to SBRT as compared to conventional radiotherapy in a very low dose of 8 gray in 1. And really, it goes to show you that you need randomized data, but we need to understand the study better. We need to understand what happened on the quality assurance and why this was a negative study. And we just don't have the paper yet to understand the data better. But we argued, and I was a discussant for that was a really old design. They really were at the forefront. And what we really need was a modern study looking at higher doses, because about half the patients got 16 and 1, which is not a high dose. And we need a modern randomized study. And that's what was going on with the SC24 Canadian study. And this is a phase 3 randomized study of 24 gray in 2 fractions versus 20 gray in 5 fractions of conventional radiation. Very standard Canadian palliative bone metastases regimen. Primary endpoint, 3-month complete response rate for pain, and then a host of secondary endpoints. Now, what's important here is we chose the target lesion, so in red there. And then if you treat SBRT, that's your lesion. And if you treat with conventional radiotherapy, it's typically 1 above and 1 below. Now, if you have up to 3 metastases that you want to treat, we allow that as well. And you had to pick your target. That's the main issue. So what are the key eligibility criteria? Well, we wanted a solid tumor metastases, full spine MRI at baseline. You needed to have a pain score of at least 2, and this is somewhat distinct from the RTOG study. We use 2 because we use international complete consensus response endpoints, and you need a drop by 2. So 2 to 0 could be a complete response rate. Up to 3 contiguous spinal metastases, good performance status. And what we had, the benefit was understanding instability, or during that time early on of this technique, that we could at least exclude the frankly unstable patients using the SIMS criteria. And that again is a benefit of this study from the knowledge that we gained about a decade ago and incorporated SINs into the actual study criteria. No previous radiation or surgery, and you couldn't have symptomatic cauda equina or cord compression. So how do we assess patients? Well, we use a 0 to 10 scale to brief pain inventory. We accommodate for oral morphine equivalent doses, international endpoints. And what's important here is the complete response definition. So this is a pain score of 0 without a concomitant increase in narcotics, and you can allow a decrease, or no narcotics, but that's important because that is 0. So that you ask the patient, it's not a 5 or 3, it's like, I have no pain. Okay, and so it's objective, and it's a good way to measure the utility of a treatment in a palliative setting. Now, local control, we use spinal criteria. Local control in bone mets is a host of another subject, but we at least use some validated criteria that we developed many years ago. So this is the schema. We had 229 patients that were randomized, intent to treat analysis, and the safety analysis is based on those who were treated. So ultimately 115 in the conventional arm, 114 in the SBRT arm, intent to treat analysis. And we did have a reasonably low rate of issues in terms of non-evaluable patients at the 3-month mark, as these patients are sick and palliative. So what are the baseline characteristics? Well, we had the majority of patients had either breast, prostate, or lung, so very representative of our practices. The majority were, as a result, categorized as radiosensitive. What's important here is that the majority, about 2/3 in each case had mass type tumors. So this is extra osseous extension, either epidural or paraspinal. Good performance status, good breakdown in terms of worst pain score, and either stable or potentially unstable. And again, we excluded the frankly unstable based on SINs, and the majority had either no or low-grade epidural disease, which is what we expected. Now, we did provide the SINS breakdown in both arms, and because we wrote it into the protocol, we could present it. And so you see here the breakdown of each of the criteria. What's important here is that the minority of patients had more than 50% collapse, because baseline vertebral compression fracture is a strong predictor of subsequent fracture. So what were our data? Well, our complete response rate at 1 month, which was not our primary assessment, but we did assess it, was not significant because you're radiating these patients. It takes time for that full effect to happen. By 3 months, we do see an improvement in the complete response rate that was significant, 35% with SBRT, 14% with conventional radiation, and we hit our mark in terms of our sample size calculation beautifully. And that's something also, again, that doesn't always happen. And by 6 months, again, we sustained improvement in terms of complete response rate for pain. The study only followed patients up to 6 months. When we look at the multivariate analysis, so adjusting for known potential factors that can influence the complete response rate for pain, we find that the treatment arm is significant. So this was a positive study supporting SBRT for painful spinal metastases. When we look at local control and overall survival, local control looks a bit better, but we weren't powered for this. And you have to change the power criteria when you talk about local control, but it looks better, but not significant. Low rates of toxicity. Our fracture rate was right on the money, 11%, exactly what we expected. There was a non-significant increase in the conventional arm, but this is not significantly different. And fracture is multifactorial. So at the end of the day, fractures do happen, no significant difference between the two arms, no radiation myelopathy, very good QA in terms of central plan review. So there were not a lot of deviations. And this is something that we have to understand in the RTOG study that may help explain their results, because again, this was a positive study. So we concluded that spine SBRT is superior to conventional radiotherapy, achieving a 21% absolute improvement in the complete response rate for pain, and it was durable at 6 months. Now, some people say, well, what about the overall response? Going from a 5 to a 3, in these partial responses. Even then, we do see that it's significant. It's not an a priori endpoint in the study, so we did not report it, but I'm providing it here for the readers because there are some people that still may not completely comprehend the value of complete response being 0 versus a partial response, which can vary, from day to day when you assess the patient. This is the first phase 3 randomized study showing that 24/2 now is a standard of care, and we should be offering our patients who meet the eligibility criteria of the study spine SBRT. Now, I want to get into a bit more practical aspects, and that was part of the understanding of spine SBRT for this session, is the technique. And we built the trial based on the technique that we evaluated. So we did this all with appropriate evidence. We looked at our data with the body fix system, thin slice CT, volumetric MR, delivering the sub-centimeter MLC, cone beam CT taken pre, intra, and we were doing post when we were evaluating it, but a correction threshold of 1 millimeter, 1 degree, and robotic couch corrections as a result. And we published our data, and we found that we were robust. We have a 95% confidence interval of under 2 millimeter motion in translation and 1 degree in rotation. And that's what builds our PTV margins. And that's how we made into the protocol. We also adopted the contouring techniques that we all participated on in Sloan Kettering. We don't treat the GTV, we treat a CTV. And this is an established standard of care. Now, we have done some work on this also because we did allow sacrum. And we have recently published sacral contouring guidelines. And the sacrum is different. It's very challenging. And, ultimately, you apply the same concept. Some people treat GTV alone, but we have provided this. And I published our results on using this particular technique as well. So you do have to realize that the sacrum is a different challenge, but we did include it. They were the minority in SC24. Now, one of the important aspects that we built in the trial was also understanding the craniocaudal extent, because all that work that we did in consensus contouring was based on the bone. But what about the paraspinal margin? What about the epidural margin? So we built in, and I've been doing this, which is a 5 millimeter anatomically constrained margin along paraspinal disease. and also epidural disease, in particular the craniocaudal extent. So you got to get the sagittal, you have to see where that epidural extends to, because you get these lip of epidural extensions and then go 5 millimeters above and below. And that's why I hardly ever get any marginal failures. And epidural failures is the main issue with spinous BRT. It does lead to kind of more exaggerated CTVs, in particular craniocaudally, and that's the price you pay. So you may be radiating adjacent bone in order to target that craniocaudal extension of your CTV, but this is the technique that we built into the study. Now, what about outcomes for radio-resistant tumors? Because when you're starting a program, usually you'll be referred the colons, the renal cells, the melanomas. There's still a lot of hesitancy in terms of prostate and breast because they're deemed radiosensitive. And it's true, but we've shown you can have a palliative benefit. You may not get as much local control benefit, we don't know, but these are some data that I said, let's look at our results for radio-resistant versus a histology that's inherently radiosensitive like prostate. And we've been treating a lot of prostate mets because we have a very big oligometastatic prostate program. So we got the benefit of looking at our numbers, and these are big numbers, 185 prostate metastases treated with spine SBRT versus your classic radio-resistant segments. And what you see here is your local control is still pretty good, about 80% at 1 year, which is really good when you look at some of the conventional data. It's like 30, 40% local control. And then you see prostate is just so radiosensitive that you see, 5% rate of failure at 1 year. And we do have some data under submission that the patients who are probably failing as you go out in prostate are the castrate resistant, and there is a different rate of local control in that cohort, but this was all comers. And there's some variability amongst the different histologies, but at the end of the day, we're doing pretty good. But there may be room to do better, and this is why the high tech looked at TCP modeling, and this table is really good. So if you want to try and escalate your local control, you got to escalate the dose. So for 90% local control, 2 fraction, you may have to go up to 28 grain 2. With 80%, which is what we get at 2 years, and that's what our data show, it's 24 and 2. So the model is actually really quite nice in terms of our 2 fraction experience. Now, we've been treating with 28 and 2 for like 5 years now, and we're actually in the process of looking at our data. So hopefully we'll validate this even to a greater degree, but it looks pretty good. Now, retreat is very important. There are a lot of series, but there's low-level evidence. We do need a randomized study in this regard, but it's very hard to do this. Ultimately, at the end of the day, you get about 80% local control, but there are some patient selection factors. So if you have neurologic deficits, certain types of histologies, if your performance status is poor, you have brain mets, you may want to conventionally radiate them, but if you think they're going to survive, you'll get the benefit in terms of local control. And then there's post-op SBRT. And post-op SBRT is an area that I love doing. I think it makes perfect sense. If you're going to put someone through surgery, you might as well give them an equally aggressive adjuvant therapy. And we've shown as many, about 80% local control. Conventional radiation, it ranges somewhere between 40 to 50% local control. We don't have a lot of good data, but that's what the synthesis is. And we do observe a relationship in terms of grade of epidural disease and outcomes. So if the tumor is getting closer to the spinal cord, your results are worse because you're underdosing to meet your forward PRV max dose, and that's just spinous BRT. You have to respect your organ at risk. But you will suffer in terms of local control. It doesn't mean don't do it, but you have to have the right expectations, and you have to push the surgeons to do maximal circumferential decompression. And that's where separation surgery comes in, and there's been a lot of work looking at this, whereby we've been trying to do this endoscopically, just achieve the goal of epidural resection, put some cement and close so we can move on. And the newer systems are really quite elegant, 2-centimeter incisions. You can sim them within 4 or 5 days and then treat them. So really avoiding the delays associated with big open incisions. And we do have postoperative CTV contours to guide your planning, but it is a challenge. This is a hard one. And in terms of the distance factor and what the benefit is to the separation surgery, there's dosimetric issues, and it makes sense. It's physics. It's a linear relationship. The greater the distance from the disease to the spinal cord, the better your metrics are going to be. But it's three-dimensional, and what you see here is your BED D95 can vary based on the patient itself and what that three-dimensional anatomy is of the epidural disease in relationship to the spinal cord. So you may need a lot of resection, open invasive for some patients based on the pre-op versus others. And that's what that BED D95 variability in outcome shows per patient. So let's get into serious adverse events. Well, one of the ones that was initially worrisome was spinal cord myelopathy. And really, at the end of the day, if you follow the numbers, it should never happen, and it hardly ever happens anymore. Because now we know how to do it. But in the beginning, we didn't know. And we did a lot of work, and I did some a long time ago, creating those numbers based on cases. We've increased them now based on new modeling in the high-tech report. I've gone to these numbers, which is about a 10% increase in our numbers for many years, and we haven't had a problem. And I have adopted the highest numbers based on high tech only for high-grade epidural disease, because I think it's okay. But the safe benchmark is still based on the 2013 data that I submitted, and 17 grade 2 is what we used in SC24. Now, retreatment, there hasn't been a lot of work since some of the original work that I did. I can tell you I've increased these numbers by 20%, and it's been safe in my hands, and we've been publishing our data along the way. But this is a safe benchmark. I think you have to use your judgment, escalate as your technique matures and how good you are. But this is a long time ago. So fracture, this is really the issue now, not radiation myelopathy. And it's a major challenge. You know, a patient like this that I treated, I knew it was high risk, but it was melanoma, and the person couldn't have surgery at that time. They wanted to get on immunotherapy right away. They wanted no delays. So we did it, and he did fracture, and he had to have surgery anyway. And this is the hard part of what spine SBRT does. I mean, I could have just given him 8 and 1 and be on your way, but he would have progressed. And so it does get challenging in some patients. But use the SINs. I think that's a good way, because if he was frankly unstable, you can argue, no, he has to have surgery. That patient was potentially unstable, and this is the gray zone. But the SINs is a very useful tool, and you can kind of put in your numbers, come up with an overall score, and you're good. Now, what have we learned about predictors? Well, early on, we started seeing a lot of fractures with 24-on-1 because I was using it, and we had to look at our data. So we put our data together with the MD Anderson and Cleveland Clinic, and what we observed really is the number one predictor is really vertebral body collapse. So if you have collapse, that's a high risk for future collapse, malalignment, lytic tumor, and the dose per fraction. So if you hit someone like this with 24-on-1, you're going to put that patient potentially at a 40% risk of fracture, if not higher. But if you use lower doses, it's not necessarily 10% with 24-on-2, it may be about 30%. So we have to understand this better, but we have done a lot of work. And that work really has shown a dose complication relationship based on the dose per fraction. And we understand also that there's that acute fracture phenomena, which is that acute destabilization from the inflammation, and then that smoldering necrosis that happens in the long term. And that's why we see late fractures as well. But ultimately, you can salvage them with cement augmentation procedure, and it really works really quite well. You can increase the complexity with percutaneous. So there's a lot of things that we can do without having to do a big open procedure. Now, Bob Timmerman did some really great work actually looking at prophylactic cement augmentation in someone who doesn't even have a fracture. And it was really quite remarkable that I was able to do this, but they had a lot of pain. So what they observed was really good pain response rates. It's based on historical controls. I did get the SINs, and there was a good breakdown in terms of 7 patients with 10 patients of the 29 with greater than or equal to 7. So potentially unstable. But this is very forward thinking, and I do use prophylactic cement augmentation. It's very controversial if someone doesn't have a fracture in the first place, but I do use it more and more. But I'd like to treat first because you can get tumor extravasation as well. Now, the other main toxicity you have to think about now is lumbosacral plexopathy or brachial plexopathy, but in particular lumbosacral plexopathy. And these peripheral nerves, once they start running down the lumbar spine, you're radiating a very long length. And unlike the spinal cord that doesn't have a length effect, I think it's an organ in series, the peripheral nerves are different myelination, and that's where you do get a length effect. And that's why we see more lumbosacral plexopathy than brachial plexopathy. Now, we looked at our mature results because we had to understand this. I mean, when you cause this complication, it's terrible for the patients because those are the long-term survivors and they're complaining pain in the legs and mobility issues. And so we said, well, let's look at our long-term survivors. So out of our database of 600 patients, 1,400 metastases, we found that 79 patients of the 600 were living more than 3 years. Very few died within 3 months, only 52. So the majority are in the intermediate zone. But in those long-term survivors, we do see about a 3 to 5% risk of brachial plexopathy or lumbosacral plexopathy in the long term. But what these tended to be were the heavily radiated patients. So I still consent them even de novo, but especially when I do repeat SBRT. So, in terms of conclusion, I would say that spine SBRT is an established field with great provenance. We do have level 1 evidence now. 24/2 is our preferred Canadian fractionation, and we're still learning about fracture and how to deal with it best. There's lots of work to be done in rear radiation and in the postoperative indication, and integrating more with our interventional radiologists and spine surgeons will improve outcomes for those potentially unstable. We just have to learn more about how to do it better and safely, the timing, the strategy. And similar to brain radiosurgery, which is the standard of care, as we know, it took many years to get there. So will spine SBRT, but we've made a very strong first step with SC24. And with that, I say thank you very much.
Thank you for that. He is an assistant professor. Dr. Bhatia is an assistant professor of neurology and a fellowship trained in neuro-oncology. His clinical and research interest lies in management of malignant brain tumors, and he's going to discuss medical management. How does that play a role in the management of spine metastases? So with that, we'll go with Dr. Bhatia.
I just unmuted you for you. Are you having any issues here for you?
Yeah, thanks so much. I was trying to figure out how to unmute myself because the screen looks a lot different. Let me see here. Give me 1 second. Thank you. Okay. Are you able to see the screen?
Yes.
And not the presentation mode, right?
Correct.
Okay, perfect. Thank you, Mahua, for the kind introduction. It's an honor to speak today at this conference in front of all these leaders of the field. And just to introduce myself, as Mahua was saying, I'm a neuro-oncologist. I just was recently recruited by Dr. Dempsey, Dr. Day, to the University of Wisconsin. I did my training over at Memorial Sloan Kettering. So I'll be briefly mentioning Dr. Walensky when he mentioned Dr. Bilski's NOMS framework. I got a chance to work with him and learn how to treat metastatic spine disease. But as a neuro-oncologist, it was actually unfortunately very difficult, as you can imagine, to talk about systemic therapies in spine disease because these therapies are only more recently coming into play. So first of all, I have no disclosures. To give you a brief outline, I'm going to talk about some of the basics of spine anatomy and clinical history for any of our trainees listening, the epidemiology of spine metastases, the oncological parameters affecting treatment, and the impact of the systemic therapies on spinal metastatic disease. I'm going to touch on some targeted therapies and immunotherapies. And we've already had great talks, as you know, by Manmeet Ahluwalia, and we will have another one by Priscilla Brastianos and others to discuss targeted therapies and immunotherapies in much greater detail. I'm going to try to focus those talks on vertebral metastases and spinal cord metastases because most of the data, though, as you know, is in brain. And then we'll touch on the spine complications of treatment. So getting into the gross anatomy, just so we orient ourselves, the spine is really made up of the spinal cord and the bony vertebral column. And so we have to take all of this into account. 30 to 90% of patients with malignant tumors of the advanced stage will have some disease in their spine. And 20% of these ultimately result in symptomatic compression of the spinal cord. And the most common location, as we've heard earlier, is in the thoracic spine. 70% of metastases go here, only 20% lumbar and 10% in the cervical spine. And then the other important anatomical to note is the fact that how we organize the different compartments. And so extradural, meaning outside of the dura, including the vertebral bodies, and then intradural extramedullary is within this space here. And then of course, intramedullary, which is really the spinal cord itself. And so whenever I look at an image, I try to think about that from that perspective. When we're seeing these patients in clinic, we need to make sure we understand what are the clues to a spinal cord lesion from history. And so we think about when we hear a patient say that the symptoms are more bilateral greater than unilateral, sensory or motor symptoms, that should clue us into the spinal cord. Any complaints about bladder, bowel, and or sexual dysfunction, stiffness in the legs, any kind of neck or back pain, definitely a sensory level across the trunk, although this is often more reliable as a symptom than a sign. Patients can complain of a tight band around their trunk or torso, a neurogenic claudication, which would suggest maybe more of a cauda equina pathology, sensory ataxia, any kind of dyspnea when lying flat, which would indicate a C3 to C5 lesion, and a time course of symptoms, which is usually subacute. Sorry, Chad, if you're able to turn my video on, for some reason it's not turning on when I tried it, but
I don't have that capability.
Okay, I apologize. I'll turn it on when I get to figure out how to. I have this double monitor here. Apologies, but I'll turn it on in the discussion at the end. So when you see a spinal mass on MRI, it's important to think about the differential diagnosis. And so the algorithm for diagnosis, I took this from a review article that kind of outlined all the different diseases that we see in the spine. Of course, the metastatic diseases are really extradural, and of course also can occur intradural or and intramedullary. So the NOMS framework, as recently mentioned by Dr. Walensky, was created to ensure the optimal use of treatment in the right patient at the right time, and contains 4 sentinel aspects of the disease: neurologic, oncologic, mechanical, stability, and systemic disease. And, it's unfortunate because systemic therapy is not a part of the NOMS framework. And it's really, and even with the advent of all these novel systemic therapies, including targeted therapies and immunotherapies, they're not yet clearly integrated into the NOMS framework, and likely because chemotherapy has really been considered more effective for visceral rather than osseous metastases. But and it's also important to note that several of these chemotherapeutic drugs that actually negatively affect bone health by acting through various mechanisms. For example, doxorubicin, cyclophosphamide inhibit osteoclasts, and you also can get stimulation of osteoclasts from cyclosporin, reduction of vitamin D levels, and phosphate wasting and hypomagnesemia. And so it's important to note the negative effects of chemotherapy on bone. Additionally, there's really only limited premature data on the effect of these newer systemic therapies, specifically on bone spine metastases. But I'm going to spend the next few slides discussing that. So the epidemiology of spinal metastases, as mentioned earlier, the most common primary spine tumors, primary tumors, systemic tumors that demonstrate a bone tropism include breast, prostate, lung, thyroid, and renal cell. Although the incidence is significantly increasing as we've made strides in systemic control and diagnostic methods. So looking at things first from an extradural metastases from systemic malignancies, starting with breast cancer, in the advanced setting, which is most relevant for the development and progression of bone disease, including spinal metastases. We often use taxane-based regimens or capecitabine as the most commonly used agents in breast cancer, especially when visceral disease is present and we need a rapid tumor regression. Other approved chemo drugs include gemcitabine, vinorelbine, eribulin, pemetrexed. But, despite the fact that several trials have reported on the activity of these agents I just mentioned, I had to go all the way back to 1992 to find an article that really discussed the bone-specific effects of chemotherapy in metastatic breast cancer. And as you can see, older cumulative data from 12 trials supported a tendency for soft tissue lesions to have a higher response rate, about 55 to 60%, compared to visceral and bone metastases, much lower at 31 to 44%. So there's really a lack of contemporary studies on the bone-specific effects of chemo in metastatic breast cancer. When looking at prostate cancer, we know a lot more about the bone-specific effects of chemo in prostate cancer. Prostate cancer, docetaxel is an established treatment for castrate-resistant prostate cancer and high-volume hormone-sensitive prostate cancer. The CHARTED trial was a landmark trial which defined the role of docetaxel in high-volume hormone-sensitive prostate cancer. And you can see they defined high-volume disease here by the presence of visceral metastases and/or greater than 4 bone metastases, with at least one outside of the vertebral column and pelvis. And looking at those updated results, you can see these Kaplan-Meier curves with showing that docetaxel in combination with androgen deprivation therapy had a significant survival advantage in high volume disease compared with androgen deprivation therapy alone. However, this difference was not significant in low volume total disease, and this provides significant evidence for the activity of docetaxel in osseous disease. Also, cabazitaxel is also approved for the treatment of metastatic CRPC after progression on docetaxel. And because the majority of patients studied in prostate cancer trials, with these drugs have osseous metastases, characterizing the effects of chemo on markers of bone metabolism really became a relevant endpoint. So now there's an ongoing single-arm phase 2 study of cabazitaxel in metastatic CRPC patients with bone-only metastasis, assessing bone progression-free survival, but also with several bone-specific endpoints, such as time to skeletal related event, time to bone pain regression, bone pain response, and several different bone turnover markers. So we know of this landmark trial in non-small cell lung cancer in patients specifically with bone metastases, which demonstrated a significant survival benefit of pembrolizumab plus a platinum-based chemotherapy. But unfortunately, there was no data published on the specific effects of these treatments on bone metastases. So we're still very interested in that within small cell lung cancer. And then moving on to intradural intramedullary spinal cord metastases. When the spinal cord becomes involved, things are a lot more difficult. And so, I've listed some chemotherapeutic drugs here that do have penetration into the central nervous system. However, this does not necessarily translate into an increase in overall survival. Likely due to several reasons, one of which is the insufficient concentrations of adequate duration that can really cause an anti-tumor effect. Future studies must assess the CNS extent of disease in order to optimize systemic and/or intrathecal dosing to eventually improve survival. So some updates in targeted immunotherapy in vertebral and spinal cord metastases. As I mentioned earlier, we've already had a lot of great talks, and we're going to have more later. So I wanted to focus specifically on bone responses, if I could, starting with hormonal therapy, moving on to some tyrosine kinase inhibitor therapies, some bone-targeted therapies, and some novel targeted therapies. So when focusing on androgen-directed therapies in prostate cancer, there are 2 new drugs approved, the CYP17 inhibitor abiraterone acetate, which is, and then the androgen receptor antagonist enzalutamide. Both of these drugs have recently been shown to prolong overall survival in previously treated patients. A recent analysis here sought to make an indirect comparison between abiraterone and enzalutamide. So this post hoc analysis that you see looked at the landmark COO-AA301 trial, which compared the time to first occurrence of skeletal-related events, spinal cord compression, palliative radiation to bone, or bone surgery in metastatic CRPC patients, and found that the patients who received abiraterone acetate resulted in faster and more pronounced alleviation of skeletal pain and prolonged time to occurrence of first-related skeletal-related events. The PREVAIL study was another key study here that resulted in the approval of the androgen receptor inhibitor enzalutamide for metastatic CRPC. When focusing on bone-specific endpoints, enzalutamide significantly also delayed the occurrence of the first SRE and significantly improved pain in chemo-naive men with metastatic castration-resistant prostate cancer. And so both drugs demonstrated their ability to delay bone progression, resulting in improvements in their bone-related endpoints. This review demonstrated a clinically but not significant benefit favoring enzalutamide over abiraterone in terms of radiographic progression-free survival. So for patients with non-small cell lung cancer, the spinal column is the most common site for metastases. So this was a prospective study in France which followed patients with spinal metastases from lung cancer. Here you can see the Kaplan-Meier survival curves from left to right according to systemic treatment, EGFR mutation status in the middle, and ALK rearrangement on the right. So on the left, you can see that patients who received immunotherapy treatment after the diagnosis of spinal metastases had a significantly higher overall survival than the patients who received chemotherapy or no treatment at all. And so then moving on to the middle survival curve, these patients who just had the presence of an EGFR mutation had significantly better overall survival than those who were EGFR negative. And similarly on the right, those 21 patients in the study who presented with anaplastic lymphoma kinase gene rearrangement, ALK rearrangement, had a better overall survival than those who did not have the ALK rearrangement. So, I mean, the take-home point here is that we see that the incidence of spinal metastases is increasing, our systemic therapies are getting better, but we don't yet have a prognostic scoring algorithm that takes into account genotype and treatment, because these novel discoveries are going to change how we manage patients with spine metastases from a medical oncological perspective, and how best to incorporate these treatments these genotypes and treatment regimens is really important. And then switching gears to targeted therapies and immunotherapy with CNS penetration, we have similar difficulties, as I mentioned earlier. Prospective data on the safety and efficacy of these targeted therapies will be discussed later, but really from a brain standpoint, intracranially. When you think about things from a spinal metastases perspective, sometimes the responses aren't reported or not necessarily focused on in the paper. So it would be interesting for some type of validated response criteria for spinal metastases. And then some updates in bone-targeted therapies, just to review, this is not new information, but the zoledronic acid and monoclonal antibody against receptor activator of nuclear factor kappa B ligand rank L are the two most widely used systemic agents for targeting bone metastases in several cancers, the mechanism of which is to impair osteoclast-mediated bone resorption and reduce tumor-associated osteolysis. Numerous studies have demonstrated the significantly reduced rate of pathological fractures and pain and analgesic consumption, and in the improvement of quality of life. On that note, I thought this would be helpful just in the light of the COVID-19 pandemic. This is a study that was trying to determine whether zoledronic acid administered every 12 weeks is non-inferior to every 4 weeks, to see if we can space out how we're treating with these bone-targeted agents and sparing patients extra visits to the clinic. And at 2 years, zoledronic acid given every 12 weeks was non-inferior to 4 weeks for reducing occurrence of skeletal events. And so the thought would be to consider de-escalating bisphosphonate therapy is a reasonable thing to do. And these early results from ongoing clinical trials have been confirmed. And then it's important to touch on some of these pitfalls of hormonal treatment. So secondary osteoporosis, this is widely prevalent across different studies, ranging anywhere from 9 to 53%. It's important to supplement with calcium and vitamin D, exercise, make sure bone densitometry is being done as part of the standard of care. And then the other big issue with responses in the spine is really a lack of imaging endpoints for spine metastases. There's been some really nice papers using DCE MRI, and I think it's definitely a leader in terms of trying to best quantify responses of the tumor microvasculature, but certainly not yet standardized across institutions and not really available at some of the community sites. And so really establishing these imaging endpoints for spine metastases could significantly improve how we manage our patients. And then I wanted to touch on some the resurgence of alpha particle emitting treatments for bone metastases. The approval of radium-223 for cancer therapy in 2013 really ignited interest in these treatments. As you can see here in the figure from this article in 2021, there was a significant improvement in patients without symptomatic skeletal events with radium-223 versus placebo. And so now, there's really over a dozen, maybe more, alpha-emitting radiopharmaceuticals that have entered clinical trials. However, many challenges remain, I should say, including the proper dose, timing, route, or ideal chemotherapeutic combinations. And so, we'll see how these studies turn out and see how we can best incorporate them into management of these patients. And then this sometimes I thought would be good to throw in systemic therapy considerations for spinal metastases surgery. How do we deal with these systemic therapies when someone's going for surgery? So just to review this, so for conventional systemic therapy, we'd want to hold systemic therapy 2 to 4 weeks prior to surgery. And then also hold 4 to 6 weeks post-operatively to facilitate wound healing. For anti-hormonal therapy, it would be okay to continue, through surgery. Immunotherapies are often continued through surgery. Small molecule TKIs are generally stopped the day prior to surgery and can be started post-operatively at the surgeon's discretion. And then anti-VEGF therapies should really be held for about 4 weeks prior to surgery if possible, and ideally 4 weeks post-operatively to facilitate wound healing. These are the kinds of questions that come up often in the clinical setting, and so it's nice to have some kind of consensus on these. And then to touch on some of the spinal complications of treatment, radiation-related myelopathy is very rare now, and as Arjun had pointed out earlier, really should never be happening anymore. But it is important to be aware of the complication and be aware of the history and the exam and what you would hear a patient complain about in this right clinical setting. So, because very rarely, even despite careful attention to dosimetry, the risk of permanent myelopathy from radiation remains possible and frequently is devastating. So early symptoms of radiation toxicity include paresthesias with Lhermitte's sign occurring 2 to 4 months after treatment. This can sometimes respond to a brief corticosteroid course, but sometimes it doesn't. And then less readily reversible signs and symptoms such as paresthesias, pain, sphincter dysfunction, and weakness can develop later. So here is an MRI showing hyperintensity on T2 weighted imaging here on the left, with or without enhancement. And then at later stages, as you go to the right, you see spinal cord atrophy predominate. Many treatment interventions have been tried unsuccessfully mainly because these are such disabling symptoms. But we try high-dose corticosteroids, we try hyperbaric oxygen, anticoagulation. Some people have tried bevacizumab. The outcomes are mixed. But we do what we can to try to help the patients in this rare complication. And then the other thing I wanted to mention, but didn't have a picture of, is the possibility of cavernous malformations occurring in the spine. These are really well described intracranially, but sometimes can be found in the spinal cord and cause sudden paraplegia due to hemorrhage. So something to think about and look out for. And so with that, I just wanted, again, thank you for the opportunity to speak. This is a nice picture of our Carbone Cancer Center at the University of Wisconsin-Madison overlooking Lake Mendota. We have an excellent team here of neurosurgeons, radiation oncologists, the medical oncology team, neuropathologists, neuroradiology. So it's just been a pleasure so far, and I look forward to the future.
It's an excellent talk, Dr. Bhatia. Thank you so much. I think sometimes it's under-recognized the benefits that systemic therapies can have on this problem with spine disease. We tend to concentrate all of our attention on, surgical intervention and radiotherapeutic intervention. But this was eye-opening and fantastic. So thank you so much for giving us your expertise today. So it's my great pleasure to introduce our next speaker. Dr. Dylan Koss is an assistant professor of neuropathology at the Medical College of Wisconsin. He completed his residency at University of Virginia, and we were fortunate enough to recruit him here to MCW, and it's been an absolute pleasure working with you for the beginning of your career here, Dylan. You're just excellent. So he's going to discuss today really not an uncommon conundrum of deciphering metastases from unknown origin. And I'd like to welcome Dylan, and thank you so much for giving us your time today.
Thank you. Thank you, Joe. It's been a pleasure working with you these past few months as well. And thank you, Mahua, for the invitation to give this presentation here at this fantastic meeting so far. Let's see, am I sharing my screen?
You are, yep.
Is it presenter mode or is it normal mode?
Looks like presenter mode.
How about now?
Perfect.
Yep. I always choose the wrong monitor in these kind of situations. All right. And thank you to the attendees for sticking around. I know it's close to lunchtime, and sticking around for a pathology talk close to lunch is always a risk factor. We like to make a lot of food pathology comparisons, so I'll try to keep that to a minimum today. So I'm going to talk essentially about the process that we use as pathologists when we're evaluating a metastasis to the brain or the spine, particularly if it's a metastasis of unknown origin or if we're unclear about where the origin may be. I want to talk a little bit about what tools we as pathologists and what the anatomic pathology lab has at our disposal, some of the limitations to our current diagnostic approach, and hopefully some of the up-and-coming additional ancillary studies that can augment our diagnosis and bring us more towards a more precision diagnostic approach. I have no conflicts of interest or disclosures. So as was very eloquently talked about this morning, we know that brain and spinal metastases are some of the most common tumors, and it's one of the most common things we encounter on our neuropathology service. We know about 8 to 10% of patients with cancer will develop a CNS metastasis at some time point during their care. And as mentioned this morning, if you look at the autopsy studies, that number appears to be quite a bit higher, estimated at between 26 and 40% once the brain and spinal cord are examined grossly and microscopically after formalin fixation. With that said, I will take this brief opportunity as the director of the autopsy service here at MCW to say that we are learning a lot from doing autopsies on these patients, not just in finding metastases that may not have been diagnosed clinically, but also describing the way that these metastases infiltrate the brain and spinal cord, as well as the responses to treatment. In terms of direct metastases to the spinal cord, we talked about before, they're fairly uncommon, but metastases to the spinal column with extension into the cord, dura, and canal is fairly common and also makes up a pretty large proportion of our caseload. The common causes of metastasis are the frequent flyers, the lung and breast cancer carcinomas, followed by primary cutaneous melanomas. But metastases from other primary sites are becoming more common as systemic treatments improve and patients are living longer. The tumors are attempting to find safe haven under the protection of the blood-brain barrier. When I think about when I think about working up, diagnosing, and reporting brain-inspired metastasis, I've started borrowing some of the terminology that's now being used for primary brain tumors, following the C-Impact Now series of papers and the forthcoming WHO Blue Book they keep threatening to release. Notably, I like to use what's called the integrated diagnosis. With this standardized process, we're beginning to put together all the different pieces of information obtained through the pathologic workup and provide a synthesis of this information in the pathology report. The pieces of information we're collecting include the initial cytomorphology of the case, i.e. the information that we glean from the intraoperative pathology in the case, the permanent histomorphology, so these are the slides that are cut from a fixed tissue block, and ancillary laboratory studies, including the immunohistochemical profile, which can be further separated into the IHC that provides purely diagnostic information, by which I mean there are stains that elucidate the differentiation profile of the metastasis, and we can match that with the expected differentiation profile of the primary site, as well as other IHC markers that really serve more as prognostic and predictive biomarkers. They may not be specific for any one diagnosis, but they provide useful clinical information in terms of behavior of the tumor and the response to particular treatments. Obviously, more information can be further gleaned by the great molecular testing that's available on tissue these days. This has essentially become the standard of care for the evaluation of many metastases. And finally, I'll briefly talk about methylation testing on brain metastases. This is an up-and-coming study that has been shown to assist in diagnostically challenging brain metastasis. So to highlight how we as pathologists use these diagnostic tools, as well as some of the limitations that come with them, I wanted to present a couple of cases that I encountered on my day-to-day pathology service over the past 6 months. My first case is from a 59-year-old woman this is a fairly common story for us, a reportedly complicated past medical history. She'd received most of her care at an outside hospital, and our access to her medical records were very limited. She had apparently been diagnosed with breast cancer many years prior and was reportedly without residual or recurrent disease. When she came to our surgeon, she'd been complaining of long-standing nausea, vomiting, headache, and some balance issues. She underwent imaging studies which showed an approximately 4-centimeter cerebellar mass, and imaging from the chest, abdomen, and pelvis showed some suspicious findings, including a solid cystic mass in a right adnexa and suspected peritoneal and mesenteric metastases. So our neuropathology team got involved with the case when the patient went to the OR and the surgeon sent us a request for an intraoperative consultation. Unlike general surgical pathology, we in neuropathology rely fairly heavily on the intraoperative cytology rather than the routine frozen section, and this helps us to limit frozen section artifact and preserve a lot of fresh tissue for permanence. Here's a representative image from this case. Let me change my pointer around a bit. So this is a representative case of a frozen section touch preparation. In this procedure, a little bit of the most abnormal looking tissue that was sent to us is gently pressed on a charged glass slide and then immediately stained in hematoxin and eosin, or H&E. At this low magnification, I think you can see that you're not normal brain, which should consist of this fine pink fibrillary processes and small inconspicuous glial cells, and possibly neurons if you're in gray matter. Instead, we have clumps of these blue to purple cells with few scattered individual cells in the background. This tells us that we are not a normal brain and that the tissue appears to be a lesion. Taking a slightly closer look at these clumps of cells, you can make out a very cohesive arrangement of cells with large nuclei, polygonal appearing abundant pink cytoplasm. The cells are arranged in such a way that they appear reminiscent of glands, but in a disorganized or sloppily constructed way. Overall, this tells us that it's an epithelial proliferation, and the gland-like structures hint that this may be an adenocarcinoma. There is notable cytologic atypia and pleomorphism, wherein one atypical cell may be 2 to 3 times the size of its neighbor. Nuclear hemochromatism or dark staining nuclei and occasional prominent nuclei are also seen. What's important to also mention in this case is this pink grunge material in the background of the cells, suggesting necrotic change. This tells us that the process is highly likely to be malignant. The other procedure simultaneously performed in many labs and was done on this intraoperative consultation is the tissue smear, also occasionally referred to as the squash prep. In this case, very small bits of tissue, often around the size of a grain of salt, coarse grain of salt, grossly appearing to be abnormal, is placed on one end of the glass slide. Another slide is placed on top of it, and the tissue is forcefully smeared between the two slides before being stained. The smear can teach us a lot over the touch prep, and especially can teach us a little bit about tissue architecture. At this low power, we can still make out the poorly formed glands, but now you can also see an overall growth pattern where the clusters of neoplastic cells line these vascular cores, kind of suggesting a fern-like process, which to us tells us this likely shows papillary growth. Now with the intraoperative complete, we can report the preliminary pathology as metastatic carcinoma with glands and papillary features, suggesting adenocarcinoma. We cannot at this point definitively determine with the primary site, but this initial information will prepare us for how to continue the workup the following day. We can let the surgeon know our preliminary findings and that we have enough viable tissue to complete any possible ancillary studies. So it's the next morning and the tissue is fixed in formalin and has been processed by our histology lab. Now on permanent section, we can evaluate a two-dimensional representation of the tissue submitted. Now what we lose in the transition from 3D to 2D, we gain in the ability to look at the tissue as a whole and also the ability to see the high resolution details within the nucleus and cytoplasm. At the initial evaluation of this lesion at low magnification, I can appreciate that the tumor does indeed show many of the features implied on the intraoperative section. There are clusters of epithelial cells showing disorganized gland-like spaces, as well as areas of tumor necrosis with the faint outlines of dying tumor cells. A closer look at these viable tumor cells show the gland-like structures made up of large cells with large nuclei and prominent nucleoli, as you can see here, here, and here. At the bottom left, you could also see that these tumor cells are lining a fibrovascular core, supporting this papillary architecture. The individual tumor cells show, again, this marked nuclear pleomorphism, where there are vast differences in nuclear size and shape. Small intracytoplasmic lumina are also seen in occasional cells, a fairly common feature seen in adenocarcinomas. Mitotic figures are quite abundant and actually can, even on light microscopy, show chromosomal hyperploidy, in this case showing a pentapolar star-shaped mitotic figure. By sampling the entire resection, we can see the interface between the tumor and the adjacent tissue, in this case, cerebellum. Note that the tumor itself is fairly separate from the brain tissue. This circumscription from the surrounding parenchyma is typical of metastases and helps us to differentiate it from infiltrating primary tumors like glioma. This also helps to emphasize why correct sampling of the specimen at the time of intraop is very important. If this area on the top of the slide is only sampled, the pathologist may erroneously report the intraoperative frozen section as cerebellum, no tumor seen, or even in rare cases, misinterpret the normal granular cells of the cerebellum as something more nefarious, like small cell carcinoma. So now at this point, we've seen all the permanent tissue and we've confirmed the preliminary findings. We can also confidently make the diagnosis of metastatic adenocarcinoma with papillary features, but we can't yet definitively tell where the metastasis is coming from. So to do that, we make use out of immunohistochemistry, or IHC. In this case, the adenocarcinoma, in this case, we've already decided that the tumor is an adenocarcinoma and is most likely to be either breast or ovarian, given the presenting history. In this case, we also wanted to consider metastatic lung adenocarcinoma, given the overall relative frequency in the population. So we started with a panel of stains. This included GATA3 and mammoglobin. These are stains for breast carcinoma, which were negative in this case, and helped to argue against the breast primary. TTF1 and NAPSIN-A are stains for lung adenocarcinoma, which were also negative in this case and helped to argue against the lung primary. And then our final set of stains included stains for ovarian serous papillary carcinoma. This stain PAX8 is a transcription factor positive in the nucleus of cells of ovarian carcinomas, and here shows diffuse strong positivity. The other helpful stain in this case is P53. So this is an IHC stain that acts as a surrogate marker for TP53 mutations. In the normal wild-type staining pattern, the IHC only shows patchy, weak positivity in the nucleus of the tumor cells. However, in the case of a TP53 mutation, the stain can either show diffuse overexpression or complete loss of staining. Here we have complete loss of the staining within the tumor cells, while we still have retained wild-type expression in these scattered blood vessels. This serves as a positive control and lets us know that our stain worked. So by pooling all this information together, we can conclude that the tumor represents a metastatic high-grade serous carcinoma with evidence for ovarian primary by interpreting both the morphologic and immunohistochemical features. And after discussing the case with the team at Tumor Board, we decided to have this patient tested for BRCA mutations, especially given the history of breast cancer, and the fact that we know now that patients with BRCA mutations appear to have a higher risk of brain metastases from ovarian primaries. So taking a step back, and let's talk a little bit more about the intraoperative process. So this is usually the starting point for when us as pathologists are introduced to your patient, unless for some reason it was previously discussed at Tumor Board or a courtesy heads up is given before the case. But in the vast majority of cases, this is the first time we're learning about the patient. When I'm evaluating any case at frozen section or an intraoperative consultation, I go through a mental algorithm which makes sure I think about all the important information in the case and helps me to avoid any common pitfalls. My first question is this biopsy lesional or not? Is it coming from the right place? If so, do I think it's neoplastic or non-neoplastic? Could this represent a tumor-affected demyelinating lesion, an inflammatory process, or an infection? Especially if that finding will alter the operative course. If the tumor is neoplastic, does it look like a primary brain tumor or a metastasis? And finally, if it does look like a MET, how far can I go in categorizing it? Ideally, we can routinely differentiate between carcinomas, sarcomas, melanomas, and hematolymphoid proliferations, but further subcategorization at the time of interop is very difficult. Once a frozen section diagnosis is determined, we need to think about whether or not there is any additional information we need to communicate to the surgeon at that time. If an infectious process is considered, tissue should be sent over to the microlab before reaching the unsterile environment of pathology growth room. If a hematolymphoid process is considered, the tissue can be submitted for flow cytometry. If a sarcoma, small round blue cell tumor, or other undifferentiated pediatric type tumor is seen, tissue can be saved fresh or frozen for electron microscopy. Finally, in the age of next-gen sequencing and molecular studies, we need to be thinking about whether there's adequate viable tumor for all the necessary ancillary testing. It's good to know on our part whether the reason for the biopsy is being done to obtain tissue for something like foundation medicine testing, which often requires quite a bit of tissue or is otherwise at risk of failure due to quantity non-sufficient DNA. And as mentioned, there are many limitations to true frozen section pathology. The brain is full of water and lipid and a bunch of things that don't respond very well to being placed in liquid nitrogen. So as such, the morphology of these frozen sections shows significant distortion and ice crystal artifact. This often persists into the permanent controls. Frozen sections are also thicker than the sections used on the permanent slides you're used to seeing and require leveling into the tissue to get adequate representation, leading to consumption of the tissue and less tissue remaining for permanence. Finally, the freezing process appears to impede many of the other studies we regularly perform, particularly IHC, resulting in weaker antigen-antibody binding. And electron microscopy is often distorted due to ice crystals. This is where the intraoperative cytomorphology, i.e. the touch prep and smear, shine. You overcome many of the issues with frozen section by adding additional benefits. So this is a three-dimensional representation of the area showing individual cells and cell clusters, allowing evaluation of the whole cells rather than just through thin sections through them. In addition, the amount of tissue used in the smear and touch prep is often negligible compared to the amount used in the frozen section, leaving plenty of tissue, fresh tissue for permanence. Experienced pathologists will also learn that there's a lot of information, additional information that you get from performance of the smear technique. From a physical standpoint, you can actually feel how well the tissue smears as you run it through the glass slides. And that tells you how cohesive it is. If it's thin and watery, you're dealing with something more like a lymphoma or a pituitary adenoma. Whereas if it's tough and rubbery, you're thinking about things like meningioma, peripheral nerve sheath tumor, sarcoma. And if it's calcified, it tells you that if it's gritty, it tells you it's likely containing lots of calcifications. Even looking at the glass side before you put it under the microscope, you can get a lot of information. So the old med school adage of blue is bad still holds true even to this stage of training, where the normal brain smears out pink like cotton candy, while the metastasis on top is dark blue and clustered. Here there are, of course, limitations to the touch prep and smear, as there are limitations with everything. Like I said before, very cohesive tumors will resist the pressure of smearing and may result in reflexing to a true frozen section. By smearing and doing a touch prep, you are prone to sample bias, and there's a chance you may miss certain areas and may not be able to say what is a margin on a resection specimen. The shearing force of the smear also ruptures cells in the mitotic phase due to the fragility of the cytoskeleton, leading to a slight underestimation of the mitotic rate. But the main limitation is whether or not your pathologist is experienced in this process and feels comfortable doing it, which is not necessarily a routine part of the workflow in a general AP lab. Differentiating between different metastases on smear can be difficult, but in many cases there are hints that may suggest one diagnosis over another. Melanomas can be difficult in that they do not always retain their melanin pigment once they metastasize, and because they're often hemorrhagic, it can sometimes be difficult to differentiate between the hemosiderin or blood breakdown pigment from the melanin pigment. The classic melanoma is less cohesive than a carcinoma and more cohesive than a lymphoma. They're often multinucleate and have prominent cherry red nucleoli. Adenocarcinomas can show a very wide variability in morphologies, but are typically very cohesive, sharply demarcated, and show clusters of cells, often showing kind of these poorly formed gland structures, sometimes referred to as a drunken honeycomb appearance. Intracytoplasmic lumens and vacuoles are not always seen, but are very supportive if they're found. Metastatic squamous cell carcinomas are uncommon. When they are seen, they're fairly similar to adenocarcinomas in that they're highly cohesive, but show more of a cobblestone path-like pattern due to the abundant cytoplasm and clear cell-to-cell adhesions. Renal cell carcinomas, as seen on the top here, usually fail to smear properly due to their high vascularity and cohesiveness. They look like jagged clumps of cells, but if you look at the periphery of some of these smears, you may find these small individual cells. They tend to look somewhat monotonous and bland and show abundant, clear to foamy cytoplasm, leading to them being mistaken as macrophages in some cases. Small cell or neuroendocrine carcinomas are discohesive and fragile, with many cells lysing during the smearing process, leaving behind naked nuclei and mitoses with very little visible cytoplasm. Classically, the chromatin pattern is the speckled salt and pepper appearance. Just want to briefly talk about, before talking about permanent pathology, I do want to briefly touch on the critical steps that go between receipt of the specimen in the pathology lab and the delivery of the slides to the pathologist's desk. So really the most important part of this whole process is the fixation. So ideally all tissue that's received in the lab should be fixed in 10% formalin immediately upon receipt, and it should stay in formalin for at least 6 hours. This is especially important in some breast cancers where interpretation of certain IHC biomarkers like ER, PR, and HER2 are only valid when they're within this appropriate fixation window. When the slides do finally come to us, we take a look at them under the microscope and try to determine a diagnosis based on the histomorphologic features. The most common metastasis we see is the adenocarcinoma. These tumors can range from well-differentiated, where the tumor mostly resembles the normal counterpart of the organ it originated from, to poorly differentiated, where it may not even resemble an adenocarcinoma at all. The well to moderately differentiated types usually give hints to their origin at initial inspection. So the lung adenocarcinoma up here on the left here, often show kind of this papillary frond-like appearance, reminiscent of primitive lung tissue and alveoli. Breast carcinomas, most commonly ductal, often elicit a hyalinized stromal response and can show some lobular-like single-file features. Colon cancer has a reputation of being tall, dark, and dirty with hyperchromatic columnar cells, cribriform growth, and abundant necrosis. And prostate is more commonly seen in bony mets and often exists as round to oval nest with central areas of necrosis. There are unfortunately mimics of adenocarcinoma that should always remain in the back of your mind. So glioblastoma earned its now extinct multiforme moniker due to its wide variety of morphologies. There are uncommon variants in which epithelial differentiation is predominant in the glioblastoma, most notoriously the epithelioid glioblastoma. Of note, this variant very commonly, about 50%, harbor BRAF D600E mutations, making molecular differentiation from some metastases difficult. Gliosarcoma is a tumor by very nature that shows altered differentiation, and it's not uncommon to see foci of squamous or epithelial differentiation within the more typical areas. Anaplastic oligodendroglioma shows clear round cells with clear halos that may be mistaken for clear cytoplasm. However, the infiltrative growth of these tumors and features like vascular proliferation should point you away from metastasis. And finally, it's always good to touch on these various epithelial primary tumors of the CNS that in many ways look almost identical to carcinomas in other organs. Choroid plexus carcinoma primarily occurs in young children, in which metastasis is not really a high concern, but atypical choroid plexus papillomas both occur in adults and have rarely been shown to drop into the spine, leading to some diagnostic difficulty. Papillary tumor of the pineal region is also a rare tumor that shows epithelial-like features, but can be differentiated with immunohistochemistry. Metastatic neuroendocrine carcinomas or small cell carcinomas are difficult in that they are small round blue cell tumors that closely resemble other small round blue cell tumors, especially those of the CNS. Embryonal tumors such as medulloblastoma and the new molecularly defined embryonal tumors of the CNS show similar staining profiles and may require molecular testing to rule out. Embryonal tumors may show rosettes, but not always, as you see here. Age and history are key. As discussed, when you are in the posterior fossa and you want to make sure what is being sampled is not the granular cells of the cerebellum. At low magnification, they can look very small, similar to a small round blue cell tumor, but at closer look, they lack the atypia, and they're often adjacent to Purkinje cells, which should set you on the right course. Renal cell carcinoma, particularly the clear cell variant, often shows high vascularity and a proliferation of nests of bland cells with abundant clear cytoplasm. This could, in some cases, look identical to the primary CNS tumor, hemangioblastoma, as seen here on the right. To make matters worse, both entities can be seen frequently in patients with von Hippel-Lindau, so immunostains like inhibin and CD10 are critical in differentiating between these two. Melanoma, as we talked about, can be both melanic and amelanonic, and that doesn't necessarily correlate with the morphology of the primary cutaneous tumor. Melanoma is often referred to as a great mimicker in pathology is the fact that it can show both epithelial and spindle morphology, or a combination of both. As a quick reminder, there are native melanocytes in the leptomeninges, so therefore primary melanomas and melanocytomas of the CNS are possible. Differentiation based on morphology alone is very difficult. However, there are molecular differences between the two, with many of the primary melanomas of the CNS showing alterations in GNAQ, similar to what is seen in primary choroidal melanomas of the eye. They don't typically show the BRAF mutations you see in the cutaneous forms. Morphology is helpful, but when a metastasis maintains its differentiation. But what about when a metastasis looks like nothing you would expect based on the presumed primary? So this is a recent case I had of a 69-year-old man with a recent diagnosis of pulmonary adenocarcinoma. He had an endobronchial biopsy done about 6 months prior, and you see here on the left end, it shows a very typical proliferation of a well-differentiated adenocarcinoma. 6 months later, he presented with multiple lesions of the brain concerning for metastases, and they took that out. And you can see here that on the right, this metastasis looks nothing like the primary, with just sheets of malignant cells offering no clue to its origin. It's in these situations where immunohistochemistry proves that why it's become such a cornerstone of modern path labs. IHC is critical in differentiating metastatic tumors and providing evidence for where they originated. While no stain is 100% sensitive or specific, a panel of stains can help at least provide clues as to the primary source and help to guide further clinical evaluation in metastases of unknown primary. Now, IHC uses an antibody that's often developed in either a rabbit or a mouse, and this antibody is designed to preferentially bind to an antigen within the cell. That antibody is then linked to either a chromogenic compound, so that's the brown precipitate you see whenever a pathologist shows you an IHC slide, or a fluorescent dye, which can be viewed under a special microscope. Based on the location of the positive staining, you could determine the location of the antigen. So the majority of stains we have are linked to the cytoplasm. They hit most commonly the intermediate filaments like GFAP and cytokeratin. There's also cytoplasmic IHC for cytoskeletal structures as well as secretory granules. I bolded nucleus here because the nuclear stains are often very helpful when evaluating a met of unknown origin, as it will target the nucleus-rich transcription factors, and it's the component of these metastases that seems to be held on to the longest while as the tumor dedifferentiates. So it may be the only thing that comes out positive. And finally, I'll touch briefly on membranous staining patterns. This is the least common of the three, more commonly seen in the hematopathology labs, but is what we're looking for when we're evaluating IHC for PD-L1. So unfortunately, IHC is not a silver bullet for difficult diagnoses. There are common technical problems that impede easy interpretation, most commonly due to technical artifact. Tissue that's either cauterized or crushed will not stain well. Tissue that's either under or over fixed often has an unreliable staining pattern, wherein the tissue at the edge of a piece of tissue may stain a little bit better where the formalin's had time to perfuse. A particular problem for spine mets is the amount of bone received with the tumor. The tumor then usually requires decalcification in an acid before we can section it, and that alters both the fixation ability and the ability for the antibody to bind. Finally, there are plenty of lab-related issues that can affect the results, including the age of the antibody, storage of the antibody, selection, and clone. When using IHC for diagnoses, there are typically a series of steps one takes in order to limit the number of stains that need to be ordered. While IHC is fast and relatively inexpensive to perform, the number of stains run should be limited to preserve tissue from molecular studies and limit unnecessary costs to the patient. If the origin is strongly suspected, a panel of 2 to 3 stains is usually performed to support the suspected differentiation. Doing a single stain is often risky, as metastases, as I mentioned, will often lose markers, especially as they become more de-differentiated under the microscope. Alternatively, some stains will show some aberrant positive staining where they shouldn't due to cross-reactivity. The most notorious for us in neuropath is keratin and GFAP, showing some overlap. The graphic to the right here is a summary of the appropriate stains we use to support common tumor types. In the case of a tumor of unknown origin, the ideal process is to really kind of start at the top and use a stepwise algorithm to place the tumor in the appropriate category. So this usually begins with basic stains to funnel into the overall realm of carcinoma, sarcoma, melanoma, glial, hematolymphoid, followed by specific markers once the basic differentiation is confirmed. Here's a case that emphasizes why doing multiple stains is often necessary. So this is a case I had very recently of a 78-year-old man with widely metastatic prostate cancer with an elevated serum PSA. The primary tumor was evaluated here many years ago and was shown to be PSA positive by immunohistochemistry. When we received the vertebral spine metastasis, we saw that the tumor shows fairly typical prostate morphology by H&E with maybe some decalcification artifact in the center. But there's really no staining for PSA. And so it's really unclear to me whether this represents either a loss of PSA production by this metastasis or whether it was an artifact of the decalcification treatment. But in this case, it was necessary to do additional immunostains to support the primary source. In this case, we used a transcription factor, which, like I said before, is often a little bit more reliable and shows nuclear staining, and this is NKX 3.1. I think it's important when discussing IHC to touch base on some of the prognostic and predictive markers. A stain like Stains like ER, PR, and HER2 have some diagnostic importance as they're more frequently positive in breast cancer and ovarian cancer, but are not specific. They've been shown to be positive and have some non-specific staining in other adenocarcinomas, especially lung for some reason, particularly lung adenocarcinomas in women. Instead, these stains are often done to subcategorize the metastasis into its particular hormone receptor and HER2 subcategory. So this obviously has had critical importance on both primary and metastatic breast cancers and can predict response to targeted therapy. All three stains are quantified, which results into some intra-observer variability, particularly in HER2, where it might be harder for a pathologist to interpret if unfamiliar. The role of hormone receptors in metastatic ovarian cancer is a little bit less clear. During my evaluation of the previous case, I did find some studies correlating extent of androgen receptor, so AR positivity, in the primary tumor, responding to better overall outcomes and lower risk of brain metastasis. And then I couldn't talk about prognostic predictive IHC without at least briefly talking about PD-L1, which has become a daily order in our IHC lab. As you all know, the extent of PD-L1 expression on these tumor cells, in some cancers, the tumor-associated immune cells, has been associated with responses to immunotherapy. There is occasionally a discordance between PD-L1 expression within the metastasis versus the primary tumor, so it's usually important that we do this even if the PD-L1 on the origin has already been done. There are validated antibodies to PD-L1. These show circumferential membranous staining, as shown here, when they're positive. It's our policy to reflexively order these stains in metastatic non-small lung cancers and melanomas and report the proportion of positive cells in our report. Like HER2, this antibody evaluation is somewhat subjective in that it requires quantification by a human being. So I here like to show these to a pathologist who reviews most of our non-small cell lung cancer, so we're at least internally consistent. And like PD-L1, molecular testing of our metastatic brain tumors have become really an everyday occurrence. We are well into the next generation of sequencing and have a number of molecular methodologies at our disposal that have variable advantages and limitations. Many labs still rely on standard single-gene pyrosequencing studies due to the quick turnaround time and relative technical simplicity. This obviously works best on single nucleotide variants. What I'm showing here on the left is one for BRAF showing a V600E mutation. This can be more useful than the mutant BRAF V600E specific antibody in that it's capable of detecting less common mutations such as BRAF V600K and the other ones we see fairly frequently in melanomas. In the middle of the kind of the spectrum of molecular testing is the lab-developed homegrown next-gen sequencing solid tumor panels, wherein laboratories can design an in-house panel that covers genes that suit the patient population needs. Increasingly, this next-gen sequencing is being combined with chromosomal microarray, which also helps us to evaluate for copy number variations, duplications, deletions. This is more technically challenging as it requires more personnel to set up, perform, and interpret the tests. It also requires an informatics infrastructure to process and store the data. The benefits to this is that the tissue is usually retained in-house, does not need to be shipped, often improving turnaround time, and the results are directly inputted into the patient's chart like a surgical pathology report. And then on the far end of the spectrum for molecular testing are these large commercial laboratories we all know and love, like Foundation and Tempus, which cover a wide variety of molecular alterations. They often also include tumor mutational burden and report significant FDA-approved therapies and potential clinical trials based on the results. So in essence, there is an abundance of options available, and the issue really comes down to finding the right test for you. On the pathology side, from our standpoint, the primary rate-limiting step is ensuring adequate amounts of tissue are available to extract enough DNA, RNA for these studies. For example, Foundation medicine usually requires about a cubic millimeter of pure tumor, which essentially amounts to 20 unstained slides. So on limited biopsies, this can be really tricky to attain, especially if some of the tissues already been used for IHC and our typical diagnostic workup. If we know up front that the tissue is being desired for molecular studies, we can usually separate some of the tissue, some of the cores into different cassettes and use one for diagnosis and one for molecular studies, but not always. And then I think I have a little bit of time left. With my remaining time, I want to touch on on a potential ancillary study that I think may be of assistance for diagnostically challenging tumors in the years to come. For the past several years, primary brain tumors with ambiguous histology or molecular results or unclear subcategorization by routine diagnostic studies. So I'm talking about like the category 3, 4 non-Wnt, non-sonic hedgehog medulloblastomas and the posterior fossa ependymomas, supratentorial ependymomas that don't fall into any neat category by the IHC alone, have benefited greatly from DNA methylation profiling. This has grown in clinical acceptance and has now become more widely available in CLIA-certified reference laboratories. Recent studies have shown that genome-wide methylation datasets can be built to subcategorize metastatic tumors based on the site of origin, and in some cases subcategorize into therapeutically relevant subtypes. This could end up being a useful technique in cases where the previously described workflow ends in equivocal results or when tissue is too limited for the routine panel of studies. A recent Nature Communications paper described construction and validation of a DNA methylation classifier platform, but for the most commonly encountered metastases using a combination of about 100 brain metastases. These were lung, breast, and melanoma, and almost 2,000 publicly available DNA methylomes. From there, they developed a three-step classification process. So step one included discrimination between the metastasis in general versus primary glial tumors, the majority of which were glioblastomas, and a smaller subset were simply categorized as low-grade gliomas. They picked two methylation regions found to be hypermethylated in metastases that could reliably distinguish between it and a GBM, as you can see here by the T-SNE clustering here on the top right. The assay performed slightly worse when comparing metastases to low-grade gliomas, probably likely in part due to the lower sample size in this study. The second step is they looked at brain metastases of lung, breast, and cutaneous melanoma and found 6 methylation sites that could reliably distinguish between the 3. And not surprisingly, melanoma versus the 2 carcinomas were the easiest to separate, but they were able to pretty definitively separate all 3 of these frequent flyer metastases. They also took into account whether the patient received therapy, systemic therapy for the primary tumor, which did not appear to affect the methylation patterns, at least in the regions they were looking at in the study. In addition, the study was able to actually accurately determine the origin for several of the initial 100 tumors that were inconclusive on the typical anatomic pathologic examination. Finally, they took a look at the breast cancer cases and picked out 10 methylation regions and were able to distinguish between hormone receptor and HER2 status. Later, they were able to confirm this with IHC testing. There are some limitations. This is still a new thing overall. While the amount of DNA needed for this study is low, the purity of the DNA, i.e. the tumor to non-tumor ratio, needs to be pretty high. The authors of the previous study required at least 70% pure tumor to be included. Likely this means that blind methylation testing of tumors will not replace the need for histologic examination so that the appropriate tissue can be microdissected from the block. The study showed good performance when dealing with common players, the common metastases, as well as the common primary brain tumors, but it's unclear how it performed when evaluating less common tumors, often the reason why these cases can be so diagnostically challenging. And like many new platforms, development and clinical validation can be difficult and requires large training and validation sample sizes. These are clinically demanding and laboratory demanding studies that require large laboratory staff, including technicians and molecular geneticists. So with methylation testing as for primary brain tumors, clinical availability will likely roll out fairly slowly over time. So to end, I'm sorry, I went a little bit over. I just want to take the time to reiterate that despite being a common part of the neuropathology service, metastatic tumors can be a difficult diagnostic dilemma. We do our part to provide the most accurate and specific information about the tissue that we can by integrating the various morphologic, immunophenotypic, and molecular features. But no test is perfect and no pathologist is perfect. So there are always limitations and common pitfalls associated with each step of the process to be aware of. But the future is bright and there's always new techniques and technologies on the horizon to augment and enhance our mission towards precision diagnosis in CNS metastasis. Thank you for your time. There are my references. I'm happy to send those out, and feel free to contact me if you have any questions after the meeting.
Dylan, that was just great. And I think, just being a clinician on this call, I certainly underestimate the rigor of the pathologic diagnoses of these tumors and the absolute critical importance, at least in this day and age, that we have to have, that even help guide our subsequent systemic therapies. So thank you so much for taking such a deep dive into that. I thought that was just fantastic. So thanks for your time. We're just a bit ahead of schedule, which is great, actually. There's plenty of opportunity for questions for our excellent spine and pathology specialists that have shared their time with us this morning. I don't see any populating yet within the list, but I'd like to start out with one directed to Dr. Segal, if that's okay. We have talked and seen a lot of pictures with regard to epidural deformation of some of these tumors, and just curious about your thoughts on how you approach those, especially with the thoughtful multidisciplinary approach of surgery first versus radiosurgery first, and some of the thoughtful rigor that goes into those decision-making processes for those challenging lesions as they present.
Yeah, so that's a great question. Thank you for that. The issue is the grade, right, of the epidural disease. So once you get into Bilski 2 to 3, then you're starting to talk about deformation of the spinal cord. And so in these situations, if someone's had previous radiation and we can get separation surgery done in a minimally invasive way, if the patient is not neurologically compromised, then we will go for it in the oligometastatic patient. At this stage, and JP can kind of correct me or expand on it, it's very hard to put somebody through an epidural decompression when they're neurologically intact, because there's still complications that can happen. And it is a big deal. So at the end of the day, for somebody who's oligometastatic, yeah, sure, I think you're justified. In some previously radiated, I think you can do it. It all depends on your service, but putting them through a big open invasive surgery would not be fair. Now, if they are neurologically compromised, then we push for maximal circumferential decompression. And I'm on the phone with them and I'm talking to them how much epidural decompression you have to go anteriorly, and our surgeons get it, but if they're an outside surgeon, I'm talking to them. I'm pushing them for maximal circumferential decompression, and that's a relationship that I have. But you have to establish that with your team, because some want to just kind of go in there, do a little bit, and then get out. But we don't want that, and so that's kind of the idea. Now, the last thing I'll do before I'll say is that you have to be aware that the difference between the cauda equina and the cord. So if you've got decompression of the thecal sac in the cauda equina, we don't really know what that means. Should you be trying to decompress them? Because you're sparing the sac anyway. So we don't go for separation surgery in that situation because there's no cord.
Excellent.
I would just add to that. I mean, I think that as our techniques have just kind of evolved, and the techniques meaning radiation therapy and also our newer chemotherapies, I think that we can pull back a little bit more on surgery than we had previously, because we can save surgery as a bailout option. And if you're lucky enough to be able to give stereotactic radiosurgery, and what I mean by that is that the insurance company approves it, right, which is a bigger hindrance sometimes probably than the effectiveness of the treatment, is that it can be planned in such a way too to limit the amount of dose that's coming to the skin over the area where your surgery would have to be if you have to salvage somebody. So I feel a little bit more comfortable in that scenario than with conventional radiation therapy, because then you can salvage these people if you can't treat them effectively. Now, obviously, we have to drop the dose a little bit depending on how much epidural disease is there. So that single fraction 24 gray that Josh and Mark are proponents of at Sloan Kettering, it's probably just too much for that kind of situation. But maybe the 2 fraction option, or even multi-fraction option, more fractions that make it a little bit more safe, and that has to be balanced with how effective it's going to be. But also with these newer chemotherapies, and I put all the immunotherapies in that group as chemotherapies, they can be quite effective in even shrinking these tumors. So, patients that we would have just pulled the trigger on to operate, now if you can get them through the chemotherapy, you might not have to do any sort of surgery for them. And I think that's a better treatment for them as far as their options.
I think bridging off of that, and a comment you'd made, Dr. Walensky, with regard to expanding that fractionation, Arjun, can you comment, in situations where you wouldn't feel comfortable doing 24 gray and 2 fractions, and perhaps going to 3 and 5 fractions in those situations?
Okay, so let's just kind of just clarify a few things. So if you want to do, say you have high-grade epidural disease, all right, and you want to do a single fraction, you can do it. I mean, you're limited by the cord dose. So I think the concept becomes, in terms of the safety, not the de-escalation. It's just whatever you're going to let the cord go to. So if you want to say, I want to give single fraction radiosurgery with high-grade epidural disease, and I'm going to take the MD Anderson dose escalation study for the cord and let it go to 16 and 1. Sure. You know, I mean, that's up to you. And that's why we have arranged a stepwise approach to core tolerance. So we have, you know, breast cancer, someone's going to live 10 years, no epidural disease, bone only, little confined disease, oligometastatic. Maybe I'll still limit to 17 gray and 2. Now we get to epidural disease or radio-resistant, I've gone up to 18.7. And now when you talk about high-grade epidural disease, maybe in that case, if I'm not going to operate, then I'm going to go to 19.4. So that's the issue, JP. It's not the safety of giving it, it's the dose limit to the court. Now, alongside with what you're saying, which is actually partially correct, is that the proportion of late toxicities is directly affected by the dose per fraction. So if you use single fraction dose tolerance to the spinal cord, you have an increased risk of late effects than if you fractionate, okay? And so taking that dose escalation maybe to 16 and 1, like the MD Anderson has said, in someone who's going to live, you know, 5 to 10 years, you may see radiation myelopathy that based on their initial data, which is a phase 1 short follow-up, they're saying it's safe, but you don't know at 3 years and 5 years. So then you fractionate, and then you say, well, look, I'm not comfortable with single fraction dose tolerance to the cord, I'm going to give 2. In some cases for us, when we're dealing with the sacrum in particular, I do a lot of 4 fractions. My group is more comfortable, I'm more comfortable because we're trying to mitigate the risk of lumbosacral plexopathy. And when I have 4 to 5 level spines, we go 4 fractions because of that issue of safety in the technical delivery. Not so much in terms of the dose, because as you get more levels, there's a bit more uncertainty at the craniocaudal extent. So you just have to be clear on the concepts of when to fractionate more. And so there's a technical aspect, and then there's a safety aspect.
Excellent. That's a very practical approach. One of the challenges that we certainly face, and I'm certain I'm not alone, is the difficulty in target delineation in a post-operative setting. Curious, it's kind of 2 parts, one for Arjun and one for Dr. Walensky as well. One, you know, what imaging studies are you utilizing, and how are you overcoming the conundrum of some of the artifact that we see, especially with MRI delineation of our targets following surgery? And then as an offshoot to that, Dr. Walensky, you know, and something that I don't think has been discussed yet in this forum, you know, I know these carbon fiber fixation devices are becoming more frequently used. Just curious about your thoughts on the clinical application of those, specifically in patients with metastatic disease to the spine.
So I guess I'll take a little bit of this first. And when we think about, say, somebody's going to get post-operative stereotactic radiosurgery, my kind of plan for these patients is while they're recovering in the hospital from their surgery, we get them to undergo a myelogram for their stereotactic radiosurgery planning. So that can compress some of the time that it takes just for the planning, because, you know, it's one thing to draw your contours, but the physicists do a lot of math that somehow takes a lot of time in the best of places to get this done. So during their recovery, then they're recovering from this. In the myelograms, you know, although it's invasive, you know, but it's invasive, but it's fairly safe. It's nothing compared to what we did surgically. It does a great job of allowing you to see exactly where the thecal sac is and where the CSF space is. You know, I'm sure the spinal cord floats around a little bit, and it might be a little bit different when you're in position, but you're really giving your dose to outside that thecal sac, right? So that's the protective zone. And I think that if you try to base your targeting on a postoperative MRI scan with the metal implants that we have in place, then you're going to have a lot of trouble, and probably no physicist will allow you to do it. Where you're going to radiate it, it's sort of difficult depending on what you took out, right? If you're very aggressive, then there's sometimes not much of a target, but I would base the target based on the preoperative MRI scan, except for the epidural disease, because the epidural disease is no longer there. So you're gonna be radiating that dural surface as your component. As far as the carbon fiber implants are concerned, there's now 2 companies that are making them. You know, with like all technology, I was very optimistic about it. The imaging quality is great. The cost of them is pretty high. So You know, it depends on your contracts with your different vendors, but for a titanium screw, it's probably about $600 a screw, where these carbon fiber implants are going somewhere between $1,500 and $2,500 per screw, which for a spinal construct can be significant as far as cost. And this is metastatic disease, so then it's debate of how long this person is going to be with us, and do we need that kind of an implant versus in our primary tumors. So from an imaging perspective, it's nice, but I think the myelogram is actually still a great way to image them for postoperative stereotactic radiosurgery. And the other aspect of it is that just the cost is pretty prohibitive, and the durability is one of the nice things about these implants, but we're not requiring these implants to stand over time like the titanium implants that we have. So, or what we do in our primary tumors. That might be a long-winded answer to that carbon fiber question, but that's sort of where we are with that.
Great.
Okay, so I'll say a few things here because, you know, our experience is a little bit different. So I will say a couple of things. Number one, in terms of the titanium implants, we've done a round robin. We sent a titanium implant around the world. It doesn't make a difference on the dose delivered, okay? So you just have to explain to your physicist, don't worry, it's okay. You know, we know now that it doesn't do anything, and that's time after time, but we've proved it in a round robin. Second thing is in terms of delineation. So your target is the postoperative bed and the level involved. Now, we've done a lot of work looking at patterns of failure, and I pretty much do a donut more so than any conformal approach because I don't want to take a risk of epidural failure. And majority of the time, you're dealing with circumferential epidural disease. And we've shown, and we know that your preoperative extent of disease has to be covered in order to maximize your chance of reduction in local failure epidurally in the postoperative situation. So I go back, I look exactly where that preoperative epidural disease is, and I make sure I cover. And that's why I do almost 90% donut distributions, okay? So we did that pattern of failure analysis about 10 years ago in Journal of Neurosurgery. So the delineation, you need to be generous. You need to take that paraspinal tissue. You need to take the level that was done, and you have to know where your preoperative disease is. Okay, so it's actually easier to draw a post-op CTV than some intact tumors in some situations. Okay, now the issue of myelogram. So it's interesting, JP, your experience, because what happens is if you take the myelogram, let's say, which I never do anymore, okay, with appropriately weighted T1, T2 imaging, even titanium, you can do it. One thing you do need to explain to your surgical colleagues, depending on their approach, is don't use crosslinks, especially at the level of the disease. And so we've eliminated crosslinks pretty much from Toronto practice for metastatic spine because that screws up your imaging. It doesn't matter what you have then, a myelogram, an MRI, whatever. But with good T1, T2 weighting, you shouldn't need a myelogram. But some centers still need it, depending on their imaging. We have an MR sim, we have all this stuff, and you can do it. In some situations, I still do a myelogram, but maybe 3 times a year, and I do 150 post-op cases a year. And if you do it too soon after surgery, and then you use that to base your planning on, first of all, you're fusing a CT myelogram to your planning CT. So that introduces its own issues. And second of all, there's deformation that happens because there's healing from the post-operative situation. So that inflammation in that tissue, when we've gone too soon, we've seen that. And I don't know, JP, if you've seen that also, but basically the surgical wound, and say you've got a partial vertebrectomy, things are contracting and changing by the time you get them onto treatment 2 weeks later. And we've seen that based on post-operative MRIs that were done immediately post-op versus at the time of planning 2 weeks later. It is different. So I would caution that approach. And you can't, just because you have a myelogram doesn't mean you don't need the MRIs for planning. So it's all complementary. But the best way to do it is at the time of your planning to do a planning CT myelogram and MRI. Like that's the gold of the gold, right? So you have them and you do their myelogram, you put them in your body fix or whatever on the table in the CT sim, and you get a planning myelogram. That's the best. A lot of places do a CT myelogram and then fuse it later on, and that's like the second best maybe. but but you have uncertainties.
Excellent. Just great back and forth, you guys. Yeah, I'm glad to hear that people have similar struggles that we do, just with regard to that delineation. That's perfect. As they say, the struggle is real. I did have one question also for Dylan, and perhaps as well, Dr. Bhatia, you can chime in on this too. You know, and we'll hear more about this. We have an amazing speaker coming up discussing leptomeningeal disease in and of itself. But Dylan, just curious about your thoughts on, you know, the accuracy and the conundrums that we run into with CSF evaluation. And then obviously, Dr. Bhatia, you know, within your talk with systemic disease, or I'm sorry, with systemic therapies for spine disease, the correlates to that with your thoughts and clinical use of intrathecal therapies for this problem that we're actually, interestingly, seeing probably with more frequency with resected metastases and you know, these recurrence patterns that never used to be the case with the more frequent use of whole brain radiation therapy following surgery. But just curious on both diagnosis and then treatment of that, seeing as we've got you both here.
Sure. Well, I'll start from the diagnostic standpoint. You know, making the diagnosis of a metastatic disease on CSF can be difficult in that, you know, depending on the concentration of cells within the CSF, whether it's a traumatic tap, you know, how pure the CSF is when it's removed, it can be very difficult to rule out metastasis to the CSF. Now, if you have positive cells present, that's great, and luckily we have capabilities now to spin those cells down and create cell blocks, and we could actually work those cells up using immunohistochemistry, and in some cases even molecular capabilities. But in terms of actual sensitivity, there's always a chance you may have a false negative.
Yeah, thanks for the question. I thought about talking about this, but as you said, there's a talk later on this, so I didn't want to go too deeper into it. But there's no doubt that circulating tumor cells in the CSF is the future for management of leptomeningeal disease. You know, I think that it's a limitation at a lot of centers because they don't have the infrastructure to do these tests, and of course, you know, have insurance pay for it. So that's really the biggest, I think, hindrance. But I mean, the data is very convincing. Sloan Kettering has done a lot of this. I know Northwestern has too, and you know, MD Anderson. So, I mean, there's a lot of interest in, once the diagnosis of leptomeningeal disease is made, in quantifying the amount of circulating tumor cell DNA over time with intrathecal treatments. And so patients, for example, with a HER2 positive breast cancer can be monitored over time with, or let's even say triple negative. I've given intrathecal methotrexate, for example, and I mean, it doesn't always work, but when it does, sometimes we do see a decrease in the circulating tumor cell DNA that we're circulating tumor cells that we're monitoring sequentially over time. And so I think the technologies is still in its early stages, but the future is very bright and exciting.
How many times do you have to tap them? Like how often?
Yeah, so I think when you're doing intrathecal chemo, it's always better to put in an Ommaya reservoir so that you're, because I think that, you know, the treatments are twice a week, for example. It depends on the intrathecal chemo that you're choosing, but the treatments are twice a week, and every time you treat, you remove CSF so that you're seeing how the cells are looking, if there's more white cells or less white cells. And obviously it's not perfect from going up here versus doing a lumbar tab. Lumbar tab's definitely better, but of course, you know, we're trying to minimize any kind of you know, problems by causing the patient any back pain or anything like that, and increasing the risk of CSF leak and all those problems. And so I do, if I'm giving intrathecal chemotherapy for leptomeningeal disease, I will give it you know, I will check the CSF at least weekly, you know, to see if the patient's responding.
Can I ask a question, Joe?
Always, yeah, please.
So Dylan, you know, maybe you can provide some advice. I don't know if you talked about it with the bone biopsies, right?
Yeah.
So, you know, the problem of decalcification and, you know, in the education that happens, because once you take that bone biopsy, you know, what's your false positive or your true, what's your chance that you'll get a positive result from a spinal bone biopsy?
I guess I have to clarify. Do you mean in terms of getting a diagnosis or
Yeah.
and the ability to use that tissue for other studies? Because there are
Both.
two separate questions there. Getting the diagnosis is not that difficult. Like I showed in that one case, we did lose PSA positivity. I think probably because of the decalcification, but there are still a lot of IHC out there that I think will persist even with harsh decalcification of these bony metastases. But in terms of the actual molecular testing, that's where I've run into a lot of issues. I've had a couple of cases where they did the surgery primarily to get tissue to send to places like Foundation Medicine. And what we attempted in those cases were to, while the tissue was fresh, to kind of actually scrape out what we thought was the most viable tumor and submit that separately without decalcification. And we've had mixed results with that. And in some cases, it's been not sufficient quantity of DNA, but in some cases it has worked. So yeah, unfortunately, it kind of is up in the air in some cases.
I guess I'll chime in as well. I mean, you know, in my experience with like a CT-guided bone biopsy, which is most commonly what we're getting for these things, in somebody who it's not clear that they have metastatic disease. So I think there's two different groups of patients. So people that have widely metastatic disease, first of all, they probably don't need a biopsy anyway, because if they're active in their disease, you know what it is, unless there's somebody who is now more remote from their initial diagnosis where they might have a secondary or primary. But somebody who you're trying to find out the diagnosis and they don't have a different target besides the spine, and you're not sure if it's a primary tumor or a metastatic tumor of unknown origin, those patients, it's about 50% non-diagnostic with a CT-guided biopsy. And what I tell patients is that if it's non-diagnostic the first time, we'll do another one. If it's not diagnostic the second time, then we consider whether or not to do an open biopsy or not. But, you know, you're getting more towards the primary tumor world then at that point. And so, yes, it's uncomfortable and annoying to have a CT-guided biopsy, but it still gives you the best opportunity for the best treatment in the future if you can do it that way rather than doing an open biopsy.
I have a question for Dr. Segal. You know, talking about your toxicity of like fracture, along the same line as thinking of like adding memantine to hippocampal sparing, have you considered adding like bisphosphonates or these next generation anti-osteoblastic, osteoclastic with your SRS to prevent those fractures?
That's a great question. Great question. Good point. And a lot of the data just show that it doesn't do much. It's not preventative. The patients who are on bisphosphonates or these drugs, because you're blasting it so hard, okay? You're just killing that bone with the dose of radiation. So if anything, and where we're trying to be more thoughtful is in the use of prophylactic cement augmentation. So the drugs aren't going to do it because the pathophysiology is different. But using more cement is happening, and you know, there's some small risks. But you know, for someone where say there's a partial fracture, no mechanical pain, but I'm going to hit them hard, then I talk to them in my IR saying, listen, we're going to do it. Can you cement them after, and try and get it approved that way.
Excellent. I can't thank this panel enough. The information shared and the presentations given just exceeded my expectation in every way. So I appreciate you all for taking the time and for sharing your expertise with us. For the remaining attendees that are here, let's take a break for lunch. We'll reconvene at 1 p.m. Central Time. And thank you guys very much. We appreciate you.
Thank you.
Thank you, everyone.
Thanks so much.
Thank you.
Well, I'm also very grateful for the opportunity to be talking today. This has certainly been a fantastic meeting so far, and I'm honored to be included amongst all of these panelists. So first, as a brief background, I'll share with you that certainly we know surgery plays an important role in the management of brain metastases. It can provide a pathologic diagnosis, improve neurologic symptoms, and improve local control for larger brain metastases. We know that surgery alone is inadequate for local control. From prospective clinical trial data, we know that 1 year local control with surgery alone is on the order of 35 to 45%. However, we know when surgery is followed by either adjuvant whole brain or radiosurgery, the 1 year local control essentially doubles. We also know that single session radiosurgery is inadequate for brain metastases larger than 2 centimeters in size, resulting roughly in a 1 year local control of 50%. MD Anderson published a phase 3 trial in the Lancet Oncology in 2017. They essentially wanted to ask the question, with modern surgical techniques improving the rate of gross total resection, is adjuvant treatment necessary? So they randomized patients after surgical resection to either observation or radiosurgery. The primary endpoint was time to local recurrence in the cavity. Eligibility included up to 3 brain metastases and the largest cavity measuring up to 4 centimeters. The SRS technique they used was a 1 millimeter margin on the cavity. Their SRS dosing was based on volume and ranged from 12 to 16 gray. The results showed that for 128 evaluable patients, the 12-month freedom from local recurrence for patients who received adjuvant radiosurgery was 72% and was significantly better than those who underwent observation following surgical resection, with a local recurrence of just 43%. Therefore, the findings were that radiation to the surgical cavity remains the standard of care and improves local control. Radiosurgery is an effective alternative to whole brain as a postoperative treatment. Of note, preoperative tumors that were greater than 2.5 centimeters in maximal dimension had worse local control, which was likely related to the radiosurgery dose, being that you may be limited to getting enough dose for those larger cavities. The NCCTG N107C trial was published in the same Lancet Oncology journal. They were asking the question, which is the best adjuvant approach? So patients were eligible if they had 1 resected met with a cavity less than 5 centimeters in maximal dimension and included up to 3 additional metastases. Patients were randomized after surgical resection to either whole brain radiation therapy with the dose and fractionation scheme determined by the institution versus radiosurgery to the cavity plus a 2 millimeter margin with, again, volume-based radiosurgery single session dosing. The co-primary endpoints of this trial were cognitive deterioration-free survival and overall survival. It included 194 patients, and after a median follow-up of 11 months, they found no significant difference in median overall survival, whether patients were followed with whole brain or radiosurgery. However, they did find a significant benefit for radiosurgery for both median cognitive deterioration-free survival and 6-month cognitive decline. One surprising finding from this study was that the 1 year local control was better in the whole brain radiation arm as compared to radiosurgery. However, they concluded that SRS should be considered one of the standards of care as a less toxic alternative to whole brain radiation. So why do we think radiosurgery had a worse local control than those treated with adjuvant whole brain radiation? Certainly it can be challenging to target these resection cavities. I shared with you these 2 very common scenarios. So on the top, case 1 is a large left temporal mass, and you can see on the postoperative MRI, a very odd-shaped cavity, and also very hard to know how much to include in your target of that bone flap in the dura. The case below is a large right cerebellar lesion that had both dural contact and sinus contact. And you can see how the resection cavity basically just collapsed and would also be very challenging to target. Therefore, we may be having insufficient target coverage for these lesions. And given radiosurgery has a steep, unforgiving dose gradient, it's going to be very important to try to delineate these as best as possible. And it's important again to point out that despite the higher BED for radiosurgery as opposed to whole brain radiation, there is perhaps not enough dose given with this single session radiosurgery, even though we're treating microscopic disease. Therefore, a panel of experts, some of whom are with us today, was formed to help develop contouring guidelines. You can see from this coronal image that even amongst experts, the cavity delineation is quite varied. The consensus group obviously took into consideration previously published data demonstrating that a 2 millimeter margin of normal tissue around the cavity can significantly reduce local recurrence. The consensus recommendations are essentially to delineate the entire surgical cavity, including the tract, plus a 2 millimeter CTV margin for any lesion. They also offered various CTV expansions, whether or not you have dural contact or sinus contact. All of these recommendations essentially result in a larger target volume, which may lead to both larger, possibly more toxicity, or limit the ability to give effective dose. Certainly, there is a concern for increased risk of radiation necrosis when you are adding these margins of normal tissue. Dorr et al. Published their series in 2016 that included 95 patients treated with a relatively conservative hypofractionated radiosurgery regimen of 7.7 gray times 3 fractions. The target they used was a resection cavity plus a 2 millimeter margin. They found a 20.6% risk of radiation necrosis. Risk factors included size of preoperative lesion and volume of healthy brain tissue receiving 21 gray. Prabhu et al. Formed a multi-institution retrospective review. The intent of this review was to look at radiosurgery alone versus combination radiosurgery plus surgical resection, and to try to determine if there was any impact on overall survival. So that was the primary endpoint, and they did find that combination treatment with surgery and radiosurgery seemed to have a survival advantage over radiosurgery alone. However, we know there are several caveats for retrospective reviews. What's interesting, and I'd like to point out here, is that they looked at the rates of radiation necrosis. They found that for patients treated with surgical resection followed by adjuvant radiosurgery, they had the highest risk of radiation necrosis of 23% compared to SRS alone or preoperative radiosurgery. Another possible downside to postoperative radiosurgery is leptomeningeal disease. Looking across several series that reported their 1-year risk of leptomeningeal disease, you can see that the risk is upwards of 30% in some of those series. When we took a deeper dive from these series, we found significant risk factors for leptomeningeal disease, including breast cancer histology, posterior fossa location, multiple metastases, piecemeal resection as compared to en bloc, and hemorrhagic or cystic metastases at presentation. There are ongoing efforts to characterize leptomeningeal disease better so that we can ideally understand this and try to reduce the risk factors. When we look at all of this data together, can we think about is potentially preoperative radiosurgery a better option? There are certainly potential advantages in that this is easier to plan with better target definition. There's no need for added margin, which may reduce the risk for radiation necrosis. It avoids delay in initiating adjuvant systemic therapy after surgery, since the radiosurgery is already done. And it may potentially lower the risk for leptomeningeal disease by sterilizing the tumor margin. We are also treating vascularized tumor with adequate oxygenation. Disadvantages may include that we're treating without pathology. However, many of our patients present with a known diagnosis of cancer. The tissue, however, may not be appropriate for genetic and mutational analyses, and as we see from Dr. Priscilla's recent presentation, that this may be very important in understanding how to treat these patients. It also leads to the question of what do we do in the event of a subtotal resection? There can be many challenges in the workflow of treating these patients who are often presenting with large metastases from which they're symptomatic. We are often meeting these patients as inpatients, and we're blessed with our workflow that for the most part, we're able to get these folks in for gamma knife radiosurgery prior to their surgical resection. But I understand that this is not the same across all hospitals. Also, potentially with preoperative radiosurgery, there may be some additional postoperative complications that we would not have seen with adjuvant radiosurgery. The initial pre-op radiosurgery experience was published by Asher et al. In 2014. This included 47 patients, half of whom were treated on a prospective trial, with a total of 51 lesions. The median time between radiosurgery and surgical resection was 1 day. The median prescription was 14 gray, prescribed to the 80% isodose lab. Of note, this was approximately a 20% dose reduction from the standard RTOG 905 dosing for intact brain metastases. After a median follow-up of 12 months, the local control was 86%. At 2 years, local control was 72%. The leptomeningeal disease rate was 0, so they found none. There was a risk of radiation necrosis seen in 8% of patients, and there were no wound complications, suggesting that this may be a safe treatment approach. They did find that local failures were more likely in larger lesions, so in lesions greater than 10 cc's in volume or greater than 3.4 centimeters in maximal dimension. They also found a trend in surface lesions and in eloquent areas being higher for local recurrence. The same group led an effort to develop this multi-center cohort study called the PROPS-EM study. It was recently published in the Event Journal. This included 242 patients from 5 institutions with over 250 lesions treated. 94% of these had undergone a gross total resection, and 62% were treated with just a single brain metastasis. The median time between radiosurgery and surgical resection was 1 day. Median prescription dose was 15 gray, and almost all patients were treated with single session radiosurgery. After a median follow-up of over 2 years, the results were quite good, demonstrating a 1-year local control of 85%, 2-year local control sustained at 82%, 2-year overall survival of 38%, 2-year risk of leptomeningeal disease of 8%, 2-year risk of adverse events of any grade of 7%, and grade greater than or equal to 3 postoperative surgical complications of just 4%. They found that subtotal resection predicted for local recurrence, which makes sense. And when they looked deeper at the leptomeningeal disease, they found that the majority of it was classic sugar coating, which we know can be very challenging to treat. I'd like to share with you our Cleveland Clinic preoperative SRS dose escalation trial. The phase 1 treatment schema is as follows. After consent and study enrollment, gamma knife radiosurgery is done per our dose escalation prescriptions. This is followed by surgical resection within 2 weeks. Usually our patients end up going to surgery within 1 to 2 days from their gamma knife procedure. Patients are then followed with brain MRI and neurologic evaluations every 2 to 3 months. Eligibility includes age greater than or equal to 18 with a diagnosis of cancer other than very radiosensitive histologies. APS greater than or equal to 70, 1 to 4 brain metastases, one of which is greater than 2 and up to 6 centimeters in diameter, planned for gross total resection. So our initial eligibility only included up to 5 centimeter in maximal diameter. However, we ended up treating many patients off trial that were just bigger than 5 centimeters. So we amended the trial, and at that same time, we amended the trial to include eligibility for patients who had up to a total of 10 brain metastases, amenable to treatment with radiosurgery. Prior SRS is allowed to lesions other than the one planned for surgical resection. The primary objective of our phase 1 dose escalation is to determine the maximal tolerated dose for neoadjuvant radiosurgery for brain metastases larger than 2 centimeters in size. We have 3 different cohorts based on maximal tumor dimension. Our SRS dosing starts at the base RTOG 9005 dosing for intact brain metastases and is escalated at 3 gray increments for a total of 6 gray higher than the base dose. Dose limiting toxicity is defined as a CTCAE grade greater than or equal to 3 adverse event. We follow 2 patients at a dose level for 4 months. If there's no dose limiting toxicity, then radiosurgery dose is escalated by 3 gray. If 1 dose limiting toxicity is observed, 2 additional patients can be enrolled at that level. If greater than 1 dose limiting toxicity is observed, the trial will stop and the next lower dose will be defined as the maximum tolerated dose. As of this month, we've enrolled a total of 37 patients. For tumor size greater than 2 up to 3 centimeters in maximal dimension, we've not enrolled any patients at the 3rd dose level. This reflects our kind of clinical practice in that our neurosurgeons are no longer really offering many surgeries for patients who have tumors of this size. For tumors of this size, many patients, we offer our staged radiosurgery approach. For tumor size greater than 3 up to 4 centimeters in maximal dimension, we are still enrolling at the 3rd dose level of 21 gray. For tumor size greater than 4, now up to 6 centimeters in maximal dimension, we've enrolled 6 patients at the 3rd dose level of 18 gray, and this arm is now closed to accrual. The following data I'm going to share with you is from an early analysis that only included 28 patients. The median age of our patients is 63. The majority are female. The majority are white, and KPS is greater than or equal to 70 for the most part, except in 1 patient. Primary cancer histologies, the majority of which was non-small cell lung cancer, followed by breast cancer. When we look at tumor characteristics for all patients, 82% of them were supratentorial. Most of the infratentorial lesions are seen in the larger size cohorts. We had piecemeal surgery done in 39% of patients, and also the majority of this was seen in those with larger tumors. The median maximal dimension treated so far was 3.7 centimeters. Lesion volume was 17.3 cc's. Our maximum dose reflects our clinical practice of prescribing to the 50% isodosine. Our homogeneity and conformity indices were, on the most part, 2 or less. When we look at toxicity, after a total follow-up of 13 months, 26 patients were evaluable for toxicity. The patients so far are doing quite well. 4 patients had grade 1 or 2 related toxicity, and for the most part, these were fatigue or headaches. We have no dose-limiting toxicity thus far. When we look at tumor control and survival, 13 patients have died, 2 have experienced a local recurrence. We have only 1 case of leptomeningeal disease, which was actually not in the study lesion, but a separate treated lesion. 6 and 12-month local control is 87 and 81%. Distant brain control is 59 and 50%, and overall survival 89 and 64% in 1 year. When we looked at local control, there was a significant difference for larger tumor size. So for those with a maximum diameter of 3.5 centimeters, or for a volume of 15 cc's. Given the fact that the initial published series from 2014 saw a trend to local recurrence for tumors that were in the surface location, we took a look at our tumor location and found that almost all of them were along the surface, which makes sense since they were resectable. Therefore, we were not able to tease out any differences given location. When we look specifically at local control broken down by size cohort, it's not surprising that the smallest lesions have the best local control. I'd like to point out that this analysis so far does not include lesions treated at the highest dose levels. I get asked all the time where we think the benefit for dose escalation is and why are we doing this. And I really believe that we're going to see that in these higher, these larger lesions that might need that higher dose. This is the one patient who had LMD. He's a 71-year-old with stage 4 non-small cell lung cancer. He had a local recurrence and then developed focal LMD. You can see his high-definition brain MRI done on the day of planning. And the lesion on trial was a left occipital lesion, which received the base dose of 15 gray. There was a separate lesion not on the trial, which was right temporal location, 4.4 centimeters, and received 12 gray. On day 4, postoperative imaging demonstrated a gross total resection in the left occipital lesion, however, a near total resection in the right temporal lesion. 3 months post-SRS, there was local recurrence in that right temporal lesion, which was CBV positive. Given the fact that this area only received 12 gray up front, we felt that it was safe and this patient was treated with repeat SRS. However, 5 months post-SRS, they developed focal LMD. This is an example of what we'd like to see. So this is a 56-year-old with stage 4 non-small cell lung cancer who presented with a 4.5 centimeter right occipital metastasis. This is their high-definition brain MRI on the day of planning. They were treated at the second dose level and received 15 gray, prescribed with a 55% isodose line. On day 5, postoperative imaging demonstrated a gross total resection. This patient is now doing really well, 4 years post-SRS. In conclusion, thus far, neoadjuvant radiosurgery with dose escalation followed by surgical resection for brain metastases greater than 2 centimeters in size results in acceptable toxicity and local control comparable to postoperative SRS or whole brain. A low rate of LMD failure was found. The phase 1 continues to accrue patients, and the phase 2 portion of our trial will be conducted at the maximum tolerated radiosurgery doses. I certainly admit to being biased and have debated the topic of pre versus postoperative radiosurgery several times. However, I understand that there are still some questions that are unanswered. Patel et al. Shared with us a retrospective multi-institutional analysis comparing postoperative radiosurgery with preoperative radiosurgery. These patients were matched quite well, except for the fact that the preoperative patients were more commonly had breast cancer histology compared to postoperative patients. They essentially found that local control, distant control, and overall survival was equivalent regardless of approach. However, there were significantly lower rates of symptomatic radiation necrosis with the preoperative approach, with 5% compared to 16%, and significantly lower rates of leptomeningeal disease in the preoperative group, with 3% compared to 17%. Fortunately, we have ongoing prospective trials from which we can learn. MD Anderson has an ongoing phase 3 trial actually randomizing patients to postoperative SRS versus preoperative SRS for their resected brain metastases. This was activated in November 2018. The primary endpoint is 1 year leptomeningeal disease-free rate with an anticipated accrual of 86 patients. We're stratifying patients by tumor size, location, and histology, all of which we know are risk factors for leptomeningeal disease. This Alliance trial is a phase 3 trial trying to evaluate what may be the optimal postoperative radiosurgery approach. This was activated in October of 2019. Key eligibility for this trial includes a 2 centimeter or larger resected metastases, cavity less than 5 centimeters in size, 3 or fewer unresected mets, all less than 4 centimeters in size, no leptomeningeal disease up front, and KPS greater than or equal to 60. Patients will also be followed prospectively for quality of life and activities of daily living measures. After patients are randomized to either single session radiosurgery with 12 to 20 gray volume-based dosing, or fractionated radiosurgery with 27 gray in 3 fractions, or 30 gray in 5 fractions. Perhaps this fractionated radiosurgery approach can overcome the dose limitations seen with single session radiosurgery for our larger resection cavities. In summary, it is certainly an exciting time to be involved in this field, and with ongoing multidisciplinary collaborations and development of thoughtful clinical trials, hopefully we can continue to do better for our patients. Thank you for your time and attention today. A special thank you to my colleagues at the Cleveland Clinic who are very supportive of collaboration and enrolling on our trials, and a special thank you to our patients who continue to inspire us every day. I'll be happy to answer any questions at the panel discussion time.
Thank you, Dr. Murphy. That was a great talk and a great presentation of not just the clinical trials that have been done, but also what's coming in the pipeline. So that's
you know, it's really wonderful. It's such a privilege to be asked by Dr. Day and Dr. Bovee to speak amongst so many of the really global leaders in so many fields and topics that we're all interested in. And I think for hopefully most of us, it's really exciting to see all the progress across all of our disciplines that is happening now, which just feels like it's accelerating more and more in all directions. But it can make it a little overwhelming to keep track of everything going on in surgical, radiation, molecular oncology. So it's really wonderful to kind of have a chance to bring all those different disciplines together and think in a really global, holistic way about everything going on and the rapid changes, which is really exciting. And I'm really happy to actually be speaking after all those people, because of course, listening, it made me think about a lot of the things I'm going to talk about. And I would kind of counterpoint debate a comment that Dr. Day made, that, you know, that treatment of brain mets and leptomeningeal disease, it often did feel so much like everyone just thought of that as well as palliative care now. But I think there's also emerging evidence, you know, that's over 10 years old now, that palliative care should be moved up into treatment. And I'll touch on that later. And I think a lot of the people here would agree. So I have no relevant disclosures, but I would love to disclose, and I was particularly pleased that, you know, I grew up in Wisconsin, just outside Madison. So hopefully the UW and the MCW people are lovely colleagues and don't feel competitive. Maybe my brother would be the MCW people hiding that badger, but there I was drooling in a bowl cut on the left. If only you could see the shag carpeting, I remember it well. So a lot of people have talked about this, but, you know, going back to the 90s, you know, the prognosis for patients with brain metastases was pretty dismal. And I think a lot of our colleagues and even some patients and families, the impression they get is now very outdated. But at one time it was accurate, and it reminds us how much things have changed in a relatively short time period thanks to all these advances. But prognosis was extremely poor for the vast majority of brain mets patients into the 90s. And all we really had was steroids and whole brain radiation, and they did help a little bit. Long-term survivors always were there, but they were extremely rare, and they've become more and more common with all these advances. A lot of the original trials were based on this original RPA class system, and I've circled KPS there for a reason, because we're going to talk a lot about it, and I think we all recognize how important it is, although it is kind of reductive. But we knew that KPS, and in only one class, age, and in only one class, the presence of systemic disease, were important factors. And that was really all we had to go on in the 90s to design trials. And all those trials, and most of the trials we have up until very recently, really suffered from a big lumping problem. You know, if you had designed a chemotherapy trial for lung mets, you know, during any of these years and included people with lung mets from various causes, people would have laughed at you.
So I don't know why we were lumping these patients together for so long that we all recognized were extremely different. So finally, we've moved away from that, but that's still a lot of what we have to go based upon. So getting up into the current era, which still is starting to feel pretty outdated, but in the 2010s, they basically pooled all the data from the RTOG trials, including over 4,000 patients. And this was somewhat real world data, but it was limited a bit because the patients with the worst prognosis were not included in these trials, and many of them were run at kind of dedicated urban treatment centers with a higher level of care than is still available to many people. So they probably represent a slightly improved picture than the reality of what happens around the nation and certainly around the world. So they started getting better data, and others have shown this, so I'll move through it rather quickly, just pointing out the key points. But now we can be a lot more detailed in looking at patients in terms of prognostication based on the tumor histology type, the KPS still, there it is in red. Every single time, the KPS around all different types is still one of the strongest predictors of outcomes. Age is important only for some of them. Number of brain metastases, which we designed many of these trials around, is only important for some of them. And then the molecular subtypes clearly have emerged as very different prognostic factors. So that's what we're working on now, which is certainly a lot more nuanced, but this is already incredibly outdated because of all the advances you've heard about today, many of them really in the field of systemic chemotherapies. In lung cancers, we have new immunotherapies, new targeted agents. In melanoma, we have targeted agents and immunotherapies that can really have stunning changes in both systemic and CNS disease. In breast cancer, we're further and further subdivided into different molecular types and combining therapies, treating people with BRCA as their baseline differently, and now immunotherapy finally. And for some of us, I think we really recognize that survival from renal cell brain metastases really changed dramatically with largely the invention of SRS, but also the benefit of systemic therapies that did seem to have a significant role in prolonging and extending survival from brain metastases. I'm sure most people here know KPS, but I'm highlighting that most of these trials were done for people of KPS of 60 or higher. So they don't really tell us anything about how useful our treatments are for the very large number of people. And as a neurologist, as many people here are, I look at the scale and I'm like, this is a little unfair to our neurologic patients, including our patients with brain or spine metastases, because sometimes somebody with one brain met or one spine met in a sensitive area will take them from asymptomatic to a KPS of 30 or 20. And then often we see that, well, now they're not a candidate for treatment. So I just wonder how much these apply to some of our patients. And of course, how do they apply to some of our patients who were born with cerebral palsy and have lived most of their life with a prior existing deficit, but were very functional. So this measures function in a very kind of gross way. It tells us nothing about quality, but it's often assumed to really tell us something about what patients' quality of life are. But I think we all see every day that individual patients will judge their personal quality of life to be extremely different at very different levels. There will be very disabled low KPS patients who say that they're happy and they're doing things they enjoy and they want to continue active treatment. And there'll be other patients who would get a KPS of 100 from some people, but I think we tend to discount or ignore a lot of the cognitive deficits that Dr. Weffels was talking about, and a lot of the psychological distress that our patients and caregivers go through. So this really does not measure quality of life, but it's what we've gone on, but it is very simplistic. So I think when I think about this prognostic data that we have and knowing that KPS is very important for it, despite its limitations, I think the question is, can palliative care, good symptom management and palliative care across the spectrum, can it actually actively modify KPS and therefore prognosis and hopefully quality of life as well? And the answer, as I think most of us know, is a resounding all caps underlined bolded yes. This has been definitively proven. Most of us quote the 2010 New England Journal paper, where patients with metastatic non-small cell lung cancer, many of whom are at high risk of developing brain metastases in that era and still now, that having early palliative care together with standard treatment at the time of diagnosis made a significant, almost 3-month improvement in overall survival. And you know, I also love talking about how median overall survival, but I like looking at the curve, because I would argue that really this tail of the curve effect that you see after the median survival time point that we talk about, there's a big and significant gap. They arrive at a similar place eventually, but I would say this blank area at the 20 to 30 month point represents 10 months of a large number of patients who were clearly benefited by this therapy. So I think we need to get away from talking about median overall survival and really talk about the area under the curve, because that's the total benefit of a therapy. And I think it discounts tail of the curve effects that may end up arriving at the same place or may not be that different at their medium. And we see this with Temodar and GBMs. So I think we really need to look and think about these curves to really get the value of these treatments for our patients and measure them in a way that really applies to what a lot of our patients are telling us, is that they do care more about quality of life and freedom and function than they care about plain old survival. But often that gets boiled down to, you know, doc, how long do I got? So getting back to some of these GPAs, luckily other people have talked about this, so I won't go into too much detail. The different subtypes of breast cancer all now have very different and improved systemic treatments, some of which have been shown or are strongly suspected to be beneficial in brain and spine metastases. And it changes, you know, every multiple times a year sometimes. So especially in breast cancer, it's getting better and better. In the lung cancer curve, you can see the huge difference between the lowest risk GPA in gold and the highest risk GPA in red. The same ones in breast, it's really dramatic when I think also about that area under the curve and how are these patients doing at these later time points versus the people with higher risk factors based on detailed data that we can predict. So this is a large, significant portion of patients as I think we're all seeing, and now we're encountering new problems like Dr. Weffel was talking about. How are they dealing with the long-term after effects of their treatment, long-term after effects of radiation, long-term after effects of chemotherapy on brain and cognition? There was recently a study published showing that fractional anisotropy brain imaging prior to chemotherapy in breast cancer was fairly predictive of neurocognitive deficits post chemotherapy. So we may get to a point where we can risk stratify patients. And if the benefit of their chemotherapy is marginal, we may be able to scan them and say, the benefit of chemotherapy for you is not worth the risk of the cognitive deficits and your likely prolonged survival. So I think there's a lot going on if we could manage to really know it all and apply it all, where we could really improve not just survival in long term, but quality and function in that long-term period. Again, KPS is just the strongest predictor. And I think of that all the time because I think about symptom management, but I also think it's important for us as a multidisciplinary group, you know, that sometimes we think, well, we want to do this surgery or we want to do this SRS, even though it has some risk. We know that doing it is likely to improve survival, but we seldom talk about the risk of complications, and that if that surgery we do early in this patient's long disease course, hopefully, if it causes a hit to their KPS that might be irreversible, is the risk worth it? Even if that one intervention at that one time point is shown to improve survival. So I think we all try and need to try harder to work together and think holistically, not just about our treatment plans and interventions in the short term, but where is this patient likely to be headed? What are their goals? And not have these one size fits all kind of, I call it Betty Crocker medicine, where we follow a guideline, you know, add water, add 2 eggs, and you're going to get the same brownies every time. But some people like different brownies. So really involving patients early on in these decisions rather than having them be really isolated and simplistic and patients passing from one discipline to the next discipline to the next without any coordination of care, thinking towards the longer term goals and what the patient might want those to be. So there's a lot of emerging prognostic factors, and this is just a couple that I think are interesting. There was a really, really great study that was published and presented at SNO, but published in 2019, 2018, and then again in 2021. They looked at patients, and this has been shown in systemic cancers of all types, that sarcopenia or measures of frailty are very, very strong predictors of outcome, you know, independent of any other prognostic variable, and in some diseases, quite strong ones. And surprisingly, in not just brain metastases, but also in GBMs, where there is no systemic disease, except maybe at the molecular level, that purely temporalis muscle thickness, which is very well correlated with measures of systemic frailty and systemic sarcopenia, was a really strong prognostic factor, not some minor, barely made a p-value, but temporalis muscle thickness in both brain mets and GBMs prior to any treatment or intervention. So this is not disease-related muscle atrophy. This is not even steroid-related muscle atrophy, was a really strong predictor of prognosis and outcome. You know, and since hearing this data, I find myself looking at my patients more, and it's right there on their MRIs. So this is something that's in front of us every day, but I think most of us don't integrate into, you know, our decision-making and prognostication for patients to guide them in choices and risks they may take. There are some fascinating molecular level studies about tumor infiltrating lymphocytes, strongly correlating with chances of long-term survival in breast cancer brain metastases. And I'd like to point out that the patients in that study did not receive immunotherapies of any kind. So this was kind of intrinsic natural immune responses, not treatment-related ones. So this is just an example of the temporalis muscle measurements. They're very simple to do, and you average the mean. Obviously, you go to the pre-op MRI to do them. So they're very simple. The data is right there in front of our faces, and I hope more of our colleagues get interested in it. It's just shown across all different cancers and even non-cancer conditions. And, you know, there's not much molecular data to say, well, why is this happening? Can we intervene? You know, is it just, you know, fattening our patients up with dietary things, or is this a larger metabolic problem that's going on with cancer patients before treatment begins? So this might be something modifiable and treatable, and it's not getting as much attention in an interventional way. We also have huge prognostic challenges, a lot of which people have touched on. So we have these better prognostic data, but then everything's different, you know, 2 years after they're published, so that we have all these new disease-specific treatments, many of which we don't know what their efficacy is in the CNS. I think it's really eye-opening, the work that Dr. Brastianos and others have done, showing that the molecular status of brain and leptomeningeal metastases is often very different than the systemic disease. I think this is still news to a lot of our systemic medical oncology colleagues, and many of them are actionable changes. But often it's been a black box that we had no window to. So this is a new-ish recognized problem, but I think some people are using it already. And I hope we really can expand it and have it be something that all of our oncologists know about, and then are able to do and perform the tests needed to get the prognostic data from that, because a lot of it is clinically applicable. But sometimes you basically have a completely different treatment plan for the brain and CNS than you do for the systemic disease, which is not how most of us are used to operating. There's also all this new uncertainty that others touched on. You know, we have no idea really how to interpret these MRIs. We're already struggling with how to judge necrosis in brain metastases after SRS. And now we have even bigger problems interpreting pseudoprogression and pseudoresponse in people on immunotherapies after things like lit and focused ultrasound, people who get multiple rounds of SRS. So you may have an active lesion in one location, a controlled lesion in another location, and a lesion that is necrosis after treatment somewhere else. So almost every tumor becomes its own thing to be interpreted rather than one summation of everything happening. And then many of the patients are on multiple tyrosine kinase inhibitors that can affect imaging, especially the angiogenesis inhibitors. So I often have no idea how to interpret these MRIs for my patients and tell them what's happening. So how could I even prognosticate if I can't diagnose accurately? But I think what I like to do in these situations when patients and people are talking about prognosis is what we can do. We can, as neurologists and neurosurgeons and palliative care specialists, we can see what patients' symptoms are treatable, what symptoms might we be able to improve, and which are not going to improve, which is hard to be honest with people. But then, predicting for them, at least in the short term, what their symptom burden is like and how can we help it. And that we do have a better handle on. So this is to me my most important slide for this whole talk, and many of you know this, but this has been proven time and time again, and I talk a lot about this directly with patients, because they read online and they hear quotes from other providers and from friends who look up data. I have this diagnosis and therefore I have this many months to live. And we all know that prognosis does not apply to individuals. It is an average in a population. So I love talking about the real survival data from all the different studies. And this was a great study with over 460 patients at the time of admission to hospice. So not from their diagnosis. 2/3 of them were cancer patients. Most of them were very impaired. And only 42% of them died within 1 month of the predicted time that they would die. And this was a one-to-one study. So basically they followed the physicians and care team to the patient. And then after the patient's last visit, when they were sent to hospice, they asked the provider, how long do you think that exact patient is going to live? And we were terrible at it, which I think is no surprise to most of us. But I think the challenge is how to be honest to patients with that, because uncertainty can be scary. But certainly, certain sounding predictions that don't come true then produce uncertainty and anxiety later on. And there were different factors that improved it. Oncologists and geriatricians were a little bit better, but nowhere near what we'd look for in terms of diagnostic accuracy in an imaging or lab test study. And interestingly, the most recent in-person visits were significantly more pessimistic about survival. And interestingly, the longer the relationship was between that physician who saw them on the last visit before hospice, the longer the relationship between that physician and patient, it significantly decreased accuracy in a dose-dependent effect. And this has been shown now in a couple studies. So I like lecturing about this and frankly talking about it with patients. And I find that it helps shift away from uncertainty to certainty. And some of the reasons why we're not good at predicting for individual patients, now this is GBM studies, but 6% of them die of something that is not directly or maybe even indirectly related to their disease. A lot of these are older patients, so they're at risk of other events happening. Of course, a lot of the neurologic problems from brain mets increase risk of things like accidents and injuries. Treatment increases infection risk. 10% of patients die of perioperative complications. And especially as we talk about doing more and more interventions, thinking about the gains, we need to be really cognizant of the risk that we take on. And then there's a significant number of patients that die of complications of their treatment. And these are all, kind of stochastic, unpredictable events. And that's part of why we're not good. And I like to talk about this with patients too, not to scare them, but to highlight why I can't predict and to encourage them to make plans for unpredictable things happening suddenly, which is difficult for some people to do. This was a patient who was just finishing treatment for a number of small brain metastases. They did whole brain radiation because there were quite a few. And then the week after radiation came in status with delirium and were afebrile. And I think some of us would look at this and say, that looks like herpes encephalitis. And in fact, it was. We looked when I was at Sloan Kettering, 4 out of 1,000 patients treated with whole brain radiation were found to have HSV encephalitis, which is way higher than the expected incidence. There are many, many case reports. There are animal models showing that radiation, corticosteroids, and most chemotherapies increase risk of herpes encephalitis. And this is treatable, but a lot of the patients in our study were not febrile. Some of them had a normal white count in their CSF. So I wonder how often we miss this. And we just blame the underlying disease. And of course, it is treatable, but you have to move quickly. So there's another patient I've seen with this that also had a CNS vasculitis from HSV. This was a patient of mine who was 3 years in remission for locally invasive laryngeal cancer. She was on long-term dialysis because her platinum-based chemotherapy caused permanent renal injury. She lost a ton of weight in the course of her disease. She got admitted 3 years after her treatment while she was in remission with delirium and bacteremia. She got antibiotics, and the team called me because they're like, she's just not getting better. She was awake, but really ataxic. Her eye movements were abnormal, and everyone was saying, well, she must have lepto. But on her MRI, she had these non-enhancing flare changes around the third and fourth ventricles, and so she had Wernicke's encephalopathy, and her thiamine level was literally undetectable, although of course that came back like 3 weeks after all this. So it turns out thiamine deficiency is much more common in cancer patients. It often has nothing to do with alcohol. Malnutrition is common. It often emerges in the setting of a metabolic stress like an infection or ICU stay, and it's extremely treatable if you recognize it, but it's so easy to miss. So I think I like to bring these up because these are not rare, and I see multiple cases of this a year. And we know that many cancers, but especially upper GI and lymphomas, are prone to it. Patients with diabetes or on dialysis are even more prone to it. And it's not that rare. And I think we often just don't look for it because it gets literally lost in the forest of everything else happening. So the other thing I want to touch on in symptomatic treatment, I think steroids are the bane of many of our existence. My colleague Mary Welch at Columbia talks about the steroids being the good, the bad, and the ugly, and I love that. We see people on 4Q6 and 6Q6 for months for no reason. We finally have an official CNS, SNO, and ASCO certified guideline in 2019, recommending don't do Q6, please. If you're for the surgeons, yes, of course, you need it for that time period for a reason, but we should taper steroids down to the lowest necessary dose. We should only be using them for a focal neurologic symptom. If they don't help the symptom, you shouldn't continue them. But there's many goods of improving symptoms and function in KPS, but there's many bads. The side effects, especially when you get over 8 milligrams a day. We should be thinking about avascular necrosis, PCP prophylaxis, but a lot of the mood effects and the muscle myopathies are very disabling and happen all the time. Anticonvulsants we now have guidelines on, and I think this group doesn't need to know too much about, but I like to highlight that as our list of tyrosine kinase inhibitors expands, you have to be really careful with a lot of the anticonvulsants because many of them, even the ones we think of as non-enzyme inducing, do have interactions with important chemotherapies. So you almost have to be a professional pharmacologist to pick a seizure medicine for a patient now. But it just requires that extra attention and step to make sure that that you're not interacting with the chemotherapy that needs to be given. And a lot of us, I think, like to use different chemotherapies to kill two birds with one stone and treat things like headaches, mood disorders, sometimes to help increase appetite, help with neuropathic pain. One thing on here I'd like to highlight is the insomnia from corticosteroids is very distinctive. This is just my personal experience. Most traditional sleeping medicines don't help. Patients are miserable. Their partners are miserable because they're up all night and kind of manic. But risperidone, quetiapine, olanzapine, very low dose antipsychotics, we're talking children's doses, can be tremendously effective at helping with insomnia and some of the manic and mood issues. So I strongly recommend, if you don't use them, exploring that literature, although it's not very high quality evidence. But discovering those for steroid-induced insomnia was kind of a wonderful thing for me, and I use them all the time now. The symptoms in palliative care for brain metastases, as we all know, run the gamut because it all depends on where the lesion is. And then the psychiatric symptoms in patients and caregivers also run the gamut and often are not being addressed in an aggressive way. Adjustment, anticipatory grief, anxiety, and depression are all not that common, frankly, although patients are often labeled with these. But some of the studies in systemic cancers, especially breast, really say that the PTSD model really fits a lot of our cancer patients better. We're not allowed by DSM-4 to use it because you're not supposed to call PTSD when it's related to a medical diagnosis, but I disagree with that. Suicide is also something that we seldom address, but interestingly, most suicides in cancer patients happen within 90 days of their diagnosis initially, not when they're declining and failing treatment. And early palliative care has been shown to decrease that suicide risk, but of course, then you'd have to start it in the early time period. And we seldom are still involved with our families during their complicated grief and bereavement. But some of the decisions we make during treatment and the words we say and the counseling we give, especially around prognosis, certainly is part of what can lead to complicated grief and maladjustment and bereavement later on. So I think we need to be thinking even beyond the patient's death and how we talk about things and the decisions we make. And there are really very few studies looking at that. So in the last few minutes, I always end up going over because I talk too much. I do want to talk about some data I presented about medical assistance in dying, which is called Death with Dignity in Washington State. More states and countries have been passing it. Many of them have different criteria and processes. Certainly they're different in Canada than they are in the states in the US. Most of them in all states and countries do talk about competence and capacity, which is a huge concern for our brain tumor patients. As Dr. Weffel touched upon, a lot of them lack capacity before even their initial surgery for their diagnosis. Half of them are felt to lack capacity by their caregivers from the time of their diagnosis. There are some bedside tests that are imperfect but quick and easy to do that are pretty well studied to sensitively detect the possible lack of capacity. And we're enrolling these people in trials and making decisions all the time. And I don't think we often stop unless there's a glaring problem. And that means really difficult decision-making falls upon the caregivers and upon us as the providers, which is distressing. So in Washington State, in the last few minutes, we have to determine, two physicians have to determine the patient has a terminal disease with 6 months or less to live, which again comes back to prognosis. Do I know that? Not at the individual patient level, I don't. Patient is supposed to be competent, but they don't really clearly define that. And then there's a waiting period before they can obtain the medications and then possibly take them. And interestingly, we did a study looking at patients or providers who prescribe it are asked to fill out. And some of us ask the patient these questions directly, but there are reasons that they're asking for medical assistance in dying. And they kind of run the gamut, and we'll show them later on. And I think this gives us a window separate from death with dignity or medical assistance in dying. What are our patients telling us that they literally can't live with or can't live to face? And I think it really makes me think a lot about prognosis and palliative care. Others have studied this in cancer patients as well as neurologic terminal diseases. We looked at 20 GBM patients. And basically summarizing all this is that most of them requested it after they had done standard radiation and chemotherapy for their gliomas. And about a third of them did continue quite active treatment with things like bevacizumab after they had even been approved. So some of them clearly were maybe planning ahead or changed their minds, which is a common thing. And the median survival of these patients was not that different than our patients who did not use death with dignity. Pain was rare, but again, these are glioma patients, so that's not surprising. And what we found really looking at our glioma patients versus the published data from Washington on ALS patients and all cancers was that glioma patients have a mix of reasons that are similar to cancer patients but different, but also similar to neurodegenerative disease like ALS and not cancer. But what I really like to highlight in this data that I hope is relevant for this talk is that, you know, very few of our patients talked about financial burdens, not that many about pain. But what all of the patients across the entire spectrum of diseases told us is that losing autonomy, losing their daily activities, and losing dignity were extremely high and common across all diseases. So to me, this is telling me these are the issues my patients are confronting or think they will be that they literally don't want to live without. So I think there's something here for hopefully all of us to work on and think about. You know, we prognosticate survival, but how often are we prognosticating for our patients their autonomy, their ability to engage in activities, their dignity, however they define it? So I think we need to include some of these perspectives, bring palliative care early into our treatment planning, and really be thinking in these discussions we have. So I will end there because I'm a couple minutes over despite Dr. Weffel adding a minute or so, and thank my colleagues who helped with all this work. And thank you so much for inviting me. This is such a pleasure.
Jerome, that was just a wonderful talk. Thank you so much for sharing that perspective. I think it's incredibly relevant, and it's encouraging to see, just in line with other comments that we've made throughout the day, that palliative care and just that specialty alone is becoming part of many brain metastases teams, and just critically important for all the points that you've made today. So I think that's a perfect segue actually to introduce our final speaker today. I'm absolutely honored to introduce Mike Heyman. it's fitting really that we end our expert symposium by hearing a patient's perspective in living with this disease. And Mike, I'm honored to have as a patient of mine who's really kind of turned into more of a friend. Despite him rooting for the Brewers and me, the Cubs, we do still find a common ground for the love of baseball. Even though his team did far better than mine this year, and to point out Mike's dedication to this symposium, he has missed the first pitch of the second game in the NLDS series by about 17 minutes. So, Mike, thank you so much for taking the time to share your story with us. As always, and I've pointed out many times, I so appreciate you, and we're excited to hear what you have to say.
Well, I didn't really set up a lot today, but one thing I wanted to share with everyone, Dr. Bovey, thank you so much. It's been a great relationship. I've known Dr. Bovey for not even a year, but we've become very close as far as sharing our baseball concerns and everything. And not only during my gamma knife treatments, but over the phone, he's made me feel very at ease about the things that I've gone through recently. And I'm very grateful for Dr. Bovey and Dr. Katie Bilo, who's my oncologist at the hospital. But my daughter is actually on her way to her first homecoming. This is my daughter, Lucy. She's 14 years old. And I just wanted to let everyone know that this is, for me, what it's all about. I get very emotional because, things changed several years ago. But do you want to say hi to everyone?
Hi.
There's a bunch of girls in the house right now, so I got relegated out to the backyard to listen to what everyone had to say and to share my my stories. So if you're ready to go, Lou, you can go, honey. Okay. I just wanted to have her come out just to let everyone know that listening to everyone speak over the last couple hours I've been in, a lot of things that you mentioned and talked about were over my head. But a lot of the words that were shared were things that I've heard a lot about over the last 5 years. In 2016, I'm 56 now. In 2016, I was 50 years old, and life was good for me. It still is. But I had a side ache, and it wouldn't go away. It wasn't real painful. It was just kind of nagging. So I went to my regular doctor, and she sent me over to get a CAT scan. And next thing I know, I was on the phone with her because it was at a different facility. So she broke the news to me over the phone. She was very concerned. And so she let me know that I had a mass in my left kidney. And I was worried, like, okay, well, what does that mean? Because I don't know, I never really thought about it. And so she was really nervous, and I said, well, okay, how big is it? And she said, well, think baseball, softball size. And I was like, the first thing in my mind was like, oh, well, I like baseball, so yeah, I guess that fits, right? So anyway, so I kind of walked out. My wife was not with me. I had just thought I was going to get treated for a side ache or something. And, next thing I know, I walk out of the facility, and, I was in a daze. I was a little bit, shocked. I just kind of sat in the car for a little bit, drove home, talked to my wife on the phone, let her know what's going on. And it was like, from that point on, we were just planning things out. So I'm going to try to see if I can share I'll share my screen with you. It's a little bit different. I'm a fourth grade teacher, by the way. I've been teaching for about 25 years in the state of Wisconsin. I live in Wauwatosa, which is right down from the freighter facility. So I'm a little used to this stuff, but let's see if yeah, there we go. Okay. So I'm just going to share, I had a PowerPoint, but it just, I did a few things with it. It didn't really work out, but so all of the care that all of you have been doing for patients, I just want to speak on behalf everyone that has cancer, that we're grateful. I'm grateful for what you do every day. You know, I spend a lot of time at the hospital, and you know, there's a lot of pain for people, and for all of you to be able to help others in that way, it's indescribable. A lot of the talk that you've had over the last couple of hours has been about quality of life, and I've been very fortunate to not, you know, experience long, lengthy problems, and I give credit to my doctors for that. They do a great job at communicating with me and with each other quickly, and try to get me in and out of the hospital as quickly as possible so I can do all the things that we all like to do in our lives. So I wanted to start off by sharing just a couple of things. This was the so I can put that up there. This was the first, like, before I was even diagnosed, when I got to the hospital, and I was just sitting in the waiting room, and they had this big sign up there, and it's really colorful and lit up, and it was like, I looked at it and I was like, oh, I'm gonna take a picture of that, because I like to take pictures of things. And so I oftentimes look at this, and it really it describes everything that I try to do every day, you know, living with kidney cancer. So I've always had that in mind. This is the school that I teach at. I teach at Atwater School. It's been there since 1905. It's a beautiful campus in Shorewood, Wisconsin, which is just north of Milwaukee. It's been my home away from home, I guess, so to speak. I'm just going to scroll through some of these pictures. This is a picture of my father and Lucy several years ago. My dad lives in Boise, Idaho, and 2 years before I was diagnosed with kidney cancer, he was diagnosed with Waldenstrom's. I believe that's how you pronounce it, Waldenstrom's disease, or WM. So, you know, after I was diagnosed with kidney cancer, we were talking, and he goes, you know, yeah, kidney cancer, that's, you know, it's fairly common. He said the thing about Waldenstrom's is, like, there's only 1,500 people a year that get, you know, diagnosed with it. And so he's always talked about, like, you know, how things work, and how, you know, the therapies that work for people and stuff. And he's doing very well. I got to say, he does great. He gets an infusion every 6 to 8 weeks, I think it is. And he's been doing great. So, yeah. I just put a lot of pictures in this slide. So this is my mom. She lives out in Nevada, and we like to attend the sports events when she comes here. I always have to tell her who wins the sausage races every time I go to a baseball game. I live about a 15-minute walk from Miller Park, so after we leave today, I'm going to be walking down there. So if you were watching the baseball game today, I'll be there in attendance. But I always have to text her to let her know that Hot Dog won. Last night, Hot Dog won, so it's like a good thing for us. So if Hot Dog wins the sausage races, a lot of times Brewers win. So maybe Hot Dog will win today. I don't know. This is my daughter, not too far from us. You know, these are the things that, you know, for me are important. You know, they are for every parent, I think. You know, I got to teach my daughter how to ride her bike, you know, in the parking lot of Miller Park. And so everything that you do makes a difference. It allows your patients to be able to live. And, you know, it's emotional for me now. I've come in contact and come very close with several people in my life that one in particular, who I'll share at the very end, who recently passed away from kidney cancer, that I got to know very well over the last couple of years. This is a picture of my best friend, Matt. And I grew up in Northern California in Santa Rosa, just north of Stanford, right? I was able to go back and visit Matt for the last couple of years of his life. He died of esophageal cancer in his mid-50s. And so a good part of the last couple of years of his life, I worked really hard to get back there to visit with him, and was able to attend a opening day for San Francisco Giants with him. It was a very special day for me, very special day for him too. But you know, these are the things that you know, the work that you do. These are the things for me that that help out a lot. Let's see. This is my wife, Sandy, and my daughter Lucy when we were younger. So I'm gonna get a picture of that. This is my brother Stu. My brother tried to commit suicide several times, and at an unsuccessful attempt, he suffered brain damage and was in a nursing home for several years, and he passed away many years ago, several years ago. But yeah, it's, you know, life is precious to me, like it is to all of you, and the work that you're doing makes all the difference in the world to all of us. These are the people I sit next to actually for the playoffs. This is on the left is Trudy and his Trudy and her husband Ron. For some reason, we are at the playoff game together, sitting together. So when I go there tonight, they'll be sitting there. Actually, Trudy won't be. Trudy's getting knee surgery, so she's missing all of the action down here this year. But Ron was there last night with his kid, and I actually, the first time the Brewers in 2017 or 18, they had a really exciting comeback win, and I turned around and everyone was jumping up and down, and I jumped up and down and gave Ron a hug and knocked him over and fell on him, and I thought I really hurt him badly, but that was one of my big memories with him. So yeah, these are just lots of pictures that I've just put together just to share out, you know, the things that I'm able to do because of all of the work that you do. I'm able to see my daughters, you know, first getting her ears pierced for the first time, you know, and I just put those slides, those pictures down here. You know, this is her before and then during, and then, you know, afterwards she had a smile on her face. And it just kind of reminded me of, like, you know, how I try to go about, you know, when I'm getting different treatments, you know, what happens to me. I'm happy going in, and then, you know, it's rough, and then hopefully smiling at the end. But yeah, shortly after I had my left kidney removed, I was actually able to go to a concert, and I like heavy metal music. So those of you that are in the Bay Area, if you're in there, that's one of the big starting places of heavy metal music. Anyway, these two guys are actually the lead singer on the left recently, like within the last 6 months, he committed suicide. His name is Mike Howell, but this is the group Metal Church. And just a few months, or not even a few months, maybe 6 weeks after my kidney was removed, I was able to go to the concert and meet several of the performers there. So I know I'm running out of time. It's a little bit short. I'm just going to share one more thing, I guess. I know that we're running a little bit late and everyone has things to do. It's a Saturday, but two things. Is this sign, enjoying the little things in life, for someday you will realize that they were the big things. So I try to keep that point with me, that it's important for the little things to be, they're important. And then the last thing I wanted to share, and I just wanted to dedicate this to, my ability to be here today was in part because of my good friend Dan. And I lost him. We lost him a couple of weeks ago on September 22nd. But Dan lived 20 years with kidney cancer, and he was mentor to me. I would go over. He was bedridden in his house for several years, but I would spend hours, several times a week over there taking naps and helping him out and watching sports and stuff like that. And that made both of us stronger, I think. And we used to do a fist pump every time I left the house to drive home. We'd do a fist pump, and I'd let him know, I'll see you in a couple of days or whatever and stuff like that. And I remember his last time that I saw him just a couple of weeks ago, the day before he died. I gave him a fist pump, but he looked at me and gave me like 5 fist pumps, and just gave me that look like be strong. And that later that day he passed away. So this is all about him. It's all about you and the work that you do, and just hopefully a little bit of insight as to the important things that you do, and it makes a difference. So I appreciate you all being great at what you do, and it's made a difference in my life. So thank you very much.
No, Mike, thank you very much. I don't think we could have had a more fitting culmination as to why we're all here doing what we do. Many of our speakers today have placed as their last slide, thanks to the patients, thanks to our families, and honestly, you're that representative today. So we get to thank you, and your talk is inspirational. I think Dr. Day had said it best earlier. I had made a comment that the struggle is real, but she had corrected me and said that hope is real as well. And I think that this presentation is just exemplary of that. And so thanks for doing so well. Keep up the good fight. I'll keep you going. Okay. So
Thank you. I appreciate that.
This is good.
That was a great talk.
Go ahead, Dr. Day. So this was our final speaker of this block. We have an opportunity for questions for Dr. Kumthekar and Dr. Wayful and Dr. Graber, and of course Mike. So we can open the floor to that. Please feel free to use the Q&A box on the lower right-hand side of the screen if need be. Dr. Day, I'll let you lead off. Do you have questions at all?
Well, I definitely have to talk to Dr. Graber about moving palliative care up. And I completely agree with that we should incorporate palliative care more. But as you would agree that there aren't that many of you guys around to be involved in every patient that we take care of. So with that in mind, when do you think is the right time for a palliative physician to be involved in the overall care of, a brain or spine meds?
Yeah, so that's a big part. That's part of why, I'm formally trained and board certified as a neuro-oncologist, but then I also got board certified in hospice and palliative medicine. And I think, thankfully, trained as a neurologist, I think really comes in handy too. So I think the hard thing for that is that what's weird to me a little bit is if we look at the data on a chemotherapy or a surgical approach or things like SRS that has been shown to improve median overall survival by almost 3 months, everyone is doing it within a year. The New England Journal paper came out in 2010. So why do interventions that have proven randomized controlled trial equivalent benefits for survival have very differential interaction? I think there's some obvious reasons here in the United States. And I think the sadder thing also is, how do we bring some of these things to rural communities? Neuro-oncologists are very unevenly distributed in the United States. We're going to do a presentation on that at SNO. And palliative care should be one of the cheapest, easiest interventions, but are our palliative care provider colleagues equipped to handle these really complicated neurologic cases? And in the US, at least, to be on formal hospice, you have to then give up basically not just radiation and surgery and chemos, you also have to give up things like physical therapy. So I think we would have to really change reimbursement models by insurance. But we have done this historically for many other things with equivalent benefits. So I think it would have to be a pressure that comes from all sides, and really then doing studies to show the cost effectiveness of it, that compared to what these interventions cost. And I think for at least me as a provider, it's important that a lot of us, we can do similar things. Rather than say, okay, let's send them to a palliative care provider. A lot of these are relatively simple things we can do, but they take time. So then we have to spend more time with our patients. But I think I like to think of it as intervention X. And I think there's a lot of disparities between how interventions of different types are implemented that have similar benefits.
Absolutely. And you kind of hit the nail on the head in that. So do you think like every neuro-oncologist is treating terminal illness? So do you think every neuro-oncologist should be trained in palliative care as part of their fellowship training?
Yes, I mean, that's an easy answer. And I think that's also, yes, that is required a little bit through the UCNS requirements in fellowship. Interestingly, radiation oncologists in their training are required to do palliative care. So I think not just neuro-oncologists, but all of us who take care of these patients need to integrate palliative care thinking and ideas and approaches into what we do. And
right.
Yeah.
I feel like as surgeons, we're a little skeptical whenever the palliative care word gets thrown in, because like you said, a lot of like physical therapy gets stopped, a lot of things that we would push for that they can't get it. So for us, it's not a term that we accept that easily. And I would love to have that happy medium where we can still talk palliative care, but we're still doing things where we're just not saying, okay, we're not going to do anything.
Yeah. And then to some fields, they tend to talk about, well, this is a palliative intervention. Well, everything's a palliative intervention, every meal you have, every breath you take. Not all of our patients will need surgery or benefit from it. Not all of our patients will need or benefit from a chemotherapy or radiation, but literally every single one of our patients will need and benefit from palliative care in terms of counseling, symptom control, emotional support. So I think it's something we need to just think about more, not as this, okay, treatment's over and now that's beginning, but really this gradual transition of care across disciplines. And more cancer centers since that study have started having an outpatient palliative care clinic to bring that in. And I think we all need to support our palliative care colleagues that we value this. And we need this to improve our patients' survival and quality of life.
Yeah, excellent points.
Actually, where I am now, I feel like, I'm receiving counseling over the last couple of months, and some of the changes that I've had, I've lost quite a bit of weight. I'm on we call it, my buddy and I called it Cabo or Cabo because, Cabomedics doesn't sound great, but Cabo sounds really good. Everyone wants to go to Cabo, right? But, after being on Cabo for, 6 months, I lost about 40 pounds, and it took it's a stress, and so I want to try to reduce that amount of stress on my family. So now I'm receiving counseling that way, and it's middle. Like that's where I am. Like I'm at that point where I'm still receiving treatment, but I'm also gradually receiving some of those other things that are preparing me, you know, for something that I'm not really looking forward to. So
Yeah, good point to make, Mike. Dr. Wayfall, I did have one question for you. You know, obviously Dr. Gandhi had talked about the results from CC001, and I think you had eloquently displayed those same results. And while I think hippocampal avoidant whole brain radiation therapy, which I'm a believer in, I do that type of treatment, it has certainly improved outcomes compared to standard whole brain radiation therapy. But still, as we recognize from the curves on those plots, even those patients who'd received hippocampal avoidant whole brain radiation therapy, 50% of them still demonstrated neurocognitive dysfunction, at least by definition of the protocol. Where do you, and Vinay and I frequently joke, you know, can we do whole brain sparing, whole brain radiation therapy? And that's probably not feasible, right? So, you know, where do you foresee the next steps going to? And Vinay had shown some really interesting data with an investigational drug looking at, you know, decreasing neuroinflammation as a result of treatment. But I'm curious about your thoughts on the same with regard to trying to move that needle even further and separating that therapeutic window that you had so eloquently described.
Yeah, you know, so these trials are not the end of the road for this program of, you know, neurotoxicity management mitigation. When I think of these trials, the SRS trial, the memantine trial, a hippocampal avoidant trial, these were proof of principles that we actually could make a difference on cognition. I think there was a lot of nihilism, you know, in the 90s and early 2000s about whether or not we could even impact cognition at all. So don't worry about it, just keep targeting the disease. But I think we have now a demonstration that there are ways that we can reduce the toxicity of our therapies and continue to get, you know, good efficacy or the same efficacy. We also want to improve the efficacy, right? Better disease-related outcomes. We now also know that there are some pharmacotherapeutic approaches that looks like they could protect the brain, maybe even restore some cognitive function. I think this has really catalyzed a lot of interest in this area, which is important. It's drawn in basic scientists and preclinical modelers, drug companies that are now saying, wait, we could actually develop medicines that would have a market share and help patients in cognition in cancer. That would be terrific. So, you know, I think now there's a lot of excitement around brain health in the oncology space as well, which I think is fantastic. It's a great time to be working in this area with people like yourselves. And I think we are going to see more studies that are kind of supportive care in nature, right? They're in a cancer population. They're not, and you know, Eduardo Barrera, who's the head of palliative care or supportive care here at MD Anderson a number of years ago, pitched to stop calling it palliative care and to call it supportive care so that everybody would get it right away. Right? Because you're supporting them through the entire cancer journey. And I mean, I think it's brilliant. I think it makes a lot of sense. And, you know, my mother transitioned to palliative care as well with her recurrent cancer. And, you know, that's right. We had to give everything up, you know, it was really too bad. But I think there will be a lot more supportive care trials that are looking at ways that we can maximize cognitive functions, minimize symptoms, increase quality of life in cancer patients, and probably simultaneously while we're also trying to cure their disease. That these do not have to be occurring on separate paths, but, you know, we should be bringing all of this together in our work.
Yeah, well said. I couldn't agree with you more. Well, I can't thank this group of panelists enough for your time. I feel like this was a perfect culmination to just an amazing day. You guys all shared some very, very insightful comments and things for us to think about and take back to our own clinics as well. You know, this is our last section, obviously, and I just have to say that personally, I had an amazing time listening to all of these great talks today, and the thought that people put into the materials that they were going to present over their 25 to 30 minute talks. And you know, as a person who has kind of dedicated their career to brain metastases interventions and treatment, to me, this gives me a lot of hope. This gives me, you know, even more reason to get up and have excitement to go to work every day. And try to do these things to have positive impacts on people's lives for a disease process that in my early training was looked upon as a bit of a nihilistic approach to therapies. But now, especially with the great research being done and that which is on the forefront in the future, you know, we've seen amazing outcomes for people that have clearly, you know, outlived their anticipated lifetime trajectory with their disease processes in remarkable ways, and in ways where they have maintained excellent qualities of life. And I think that that's just incredibly important. And I can't thank all of our presenters enough. This was just a great day.
I would just like to echo Dr. Bovey's sentiment. This has been a great presentation, and thanks to every single presenter who came and gave such a thoughtful presentation. And, you know, as a surgeon, we are very much into instant gratifications, and we just want to fix things and cure things, but we do that, but then we hear that the patient passed away. That was just such a drag on, I feel like this, like, oh, we did something, but overall we didn't do something. But then this entire multidisciplinary approach of, you know, having medical oncologists, radiation oncologists, cutting edge research, neuropsych, palliative care, we all come together and then say it doesn't have to be that way, and we can change the future, and that's really the goal. And we do everything we do is for people like Mike, you know, so we can do better for people who are suffering from devastating diseases. And I feel like every single one of the presenters who presented their work are at the forefront of making that change for patients' lives. So it has been really an awesome presentation. And then lastly, I would like to thank Chad and Caleb, our technical IT people. I don't think we could have made it possible without them, and having them stick around all day on a Saturday with us to get us through this. And Sarah, who was our educational director, who moved on to a better job, but she helped us put this together. And Cassie, our departmental administrator, who also helped out a lot to make this all happen. So thanks to everyone, and have a good rest of the Saturday.